Very good morning, ladies and gentlemen. Summer Conference of the Cardiological Society of India, Kerala Chapter, May 6th and 7th. A nice semi-cool morning today at the Zuri Kumaragam. I request you all to kindly take your seats. We'll be moving on quickly. I request all the presenters to kindly load in your presentations if you haven't not done so as yet. And on behalf of the organizing committee, I'd like you all to kindly stick to your time because we have very jam-packed sessions. Phones on silent or on vibratory mode, please. And before we start, a few opening remarks. May I please invite the President of CSI, Dr. Prabhanini Gupta, onto the dais. Dr. Jay Gopal, our Vice President and our Scientific Committee Chairman. Dr. Deepak Davidson, our Organizing Chairman, and Dr. Jitu Samrajan, our Organizing Secretary, for a few opening remarks before we start the scientific sessions.
Good morning to all of you. I'm here actually just to welcome you because we have had an overwhelming response. Dr. Jay Gopal and Dr. Jitu and Dr. Deepak Davidson have organized a really beautiful scientific program which had a overwhelming response from yesterday. Our PG program was very well attended. It went on from 5 o'clock to 10 o'clock and it had to be terminated early for food. So I hope you all enjoy this program. Now Dr. Jay Gopal will tell you something about the scientific program. He is the person who organized the entire thing. I'm just happy and touched to be the president. Thank you.
Thank you, ma'am. Dr. Jay Gopal, please.
Good morning, senior colleagues and dear friends. It's indeed a great honor to be here as a scientific committee chairman for this year's summer conference. And I'm extremely happy to tell you that we have had a very useful time so far. I mean, I had a fantastic and a dynamic organizing secretary this time, Dr. Jitu Sam, for having organized this beautifully. I think he was in touch every other day with me, and Dr. Deepak, as the organizing chairman, has put in all his effort to bring you all to this beautiful place. Now, I know this is a fully jam-packed sort of a 2-day session, but then my philosophy was to be all-inclusive. In fact, the terminology these days is inclusiveness. So what I've been seeing over the last few years is that a lot of young faces are missing. And in fact, most of the newer colleagues are not even known to us. So this is a great opportunity for all of us to probably network and also for them also to unearth their talent. In fact, most of them are brilliant in their own way, and then I think it gives them a real opportunity. So I know, so first and foremost, you must bear with me for any kind of a lapse because whole thing has been devised in such a way that you give importance to everyone. Some of our senior teachers and also particularly from the teaching institutes are part of the faculty, and I'm extremely thankful to all my dear friends here who have come here even accepting a session to chair the session. So I've tried to cover almost the entire, because this is a general cardiology conference, but for sure I think the interest for younger generation is always interventional cardiology. That's why we thought we probably start off with the day-to-day bread and butter practice for all of us here. And more importantly, I think Dr. Prabha just mentioned that there was a very overwhelming response last night. In fact, I was so glad when Jitu told me that he wanted to organize a pre-conference workshop for the postgraduates. I was a little skeptical about the whole thing, but I mean, I'm telling you, it's a fantastic effort, Jitu. All credit to you. Congratulations once again. The hall was jam-packed. There were about 50 postgraduates attending the session, and I mean, all the senior people sharing their experience. So this time also, though initially it was a little lukewarm response, towards the end, I must tell you that we had more than 25 abstracts and cases which have come from the postgraduates. In addition to that, most of the sessions we have given them an opportunity, even in the challenging scenarios, to showcase their talent. So altogether, about 30 presentations are from the postgraduates, and I am very sure that these are the prospects for tomorrow. So we have kept that in the main session. The award session is in the, so please don't miss it. It's between 10 and 11 tomorrow. So with these few words, I would request all of you to stay put in the hall and then enjoy this academic feast. And I'm sure we'll all have a lot of learning to do from this conference. Thank you.
Thank you, sir.
Let me now, we have another 2 more minutes to go. So let me ask Dr. Deepak Davidson just to share his thoughts, and finally the vote of thanks from Dr. Jitu.
Good morning, senior teachers, my dear friends. Really started off well. Very happy to be part of this organizing team. Yesterday we were so happy that we had almost 50 postgraduate students, very senior teachers joining us for the discussions, and it went on till 10 o'clock. I sincerely pray and hope that the sessions today, tomorrow, it's going to be a great academic feast for each and every one of us. Thank you so much.
Thank you, sir. Dr. Jitu, please.
Good morning, all. It's a great privilege to stand before you and to start this CSI. It's been prepared for the last 6 months, and I hope you all will like it. And the official vote of thanks will be during the inauguration ceremony, because that will be very long, because I have a lot of people to thank. And especially thank you all for coming so early today, so that we'll have a good discussion. Thank you.
Thank you very much, sir. Thank you, ma'am. We'll move on quickly to our scientific sessions. The first session, primary angioplasty challenging cases. And may I please invite the chairpersons for the session, Dr. Bijilesh, Dr. Sibu Matthew, Dr. Jitu Samrajan, and Dr. Praveen Jain, please. Once again, may I remind you to kindly put your phones on silent or on vibratory mode. I hand over the proceedings now to our esteemed chairpersons. Over to you, sirs.
And can we start now, or 8:58 only? Okay, we can start. So we are starting the first talk, that is single coronary artery from RCC, PAMI, Dr. Anthony Jacob. The time for presentation is 7 minutes and discussion 3 minutes. We'll stick to the time.
A warm good morning to one and all present here. Today we are presenting a single coronary artery arising from the right coronary cusp, a very rare anomaly with an anterior myocardial infarction. So this elderly gentleman with known case of hypertension, dyslipidemia with coronary artery disease had undergone an angioplasty a few years ago. The records were not available. Now presented with an anterior MI with hypertension in a nearby hospital. So this patient had severe left ventricular dysfunction, and he was taken up for a primary angioplasty in a nearby hospital. So they initially hooked. They started with the right radial approach, and they tried hooking the left coronary artery, which was not possible. So they immediately switched to the right coronary. So they found that there was a stent in the right coronary, and the flow was very good. And the LCX, there was a mild disease, and the LAD, it was totally occluded. So they understood that it was an anomalous vessel, so they couldn't wire it, and they were not able to do a primary angioplasty. So this patient was referred to us to do a primary angioplasty. So in our center, we started with a 6 French short amplex catheter. You could see the short amplex catheter on the ostium of the right coronary artery, and the right coronary, it has a good flow. The circumflex was also flowing well, and the left anterior descending, the proximal part was totally occluded. So in the second image, you could see a faintly filling of the LAD, and so we thought we'll wire it. So we started with the run-through wire, which was not able to pass the run-through wire, and we tried Fielder FC wire. So with the help of the Fielder FC wire, we thought we'll push to the left anterior descending artery, so it was also getting difficult. So we started with a guide extension catheter, with the help of a guide extension catheter, and we could initiate the wire till the distal left anterior descending artery. So we were able to keep the wire till the field RFC wire till the left anterior descending artery, and with the help of the guide extension catheter, we were able to balloon it with a 3.5 mm balloon, and we were place the stent, and it was 2.5 mm balloon, and it was stented with a 16 atmosphere, and you could see the balloon was, and we were given intracoronary nicorandrol sodium nitroprusside was given, and we could achieve a good result, and this was the final result. A TB3 flow was achieved, and the patient was hemodynamically stable, and patient was shifted to CCU, and after 5 days patient was discharged, and he is still on follow-up for the past 2 years. So the take-home message is the incidence of this anomaly is extremely rare, that is 0.024%, and since there is a rare possibility of having a single coronary artery with the left anterior descending, with the left coronary arising from the right coronary sinus, while taking up any patient for primary angioplasty, it's always worthwhile to look at the right coronary artery after searching the left coronary for a while, so that this rare possibility may not be missed by the operator. In this particular case, the patient presented to a nearby hospital. They were not able to cannulate the left system, so they immediately searched for the right coronary and looked at the right coronary and identified that the left system was also arising from the right system. And however, they sent us this patient for doing a primary angioplasty. So in this rare anomalous coronary artery, the short amplax left catheter via the radial approach helped us in hooking the anomalous vessel arising from the right coronary sinus. Since the backup support was very poor and the guide catheter was sitting right at the ostium of the vessel, we did not have an adequate support, and there was a significant tortuosity of the proximal vessel, and wiring was done with a polymer coated field RFC wire. So this shows the significance of a field RFC wire in handling difficult lesions. Since the backup support was very poor, we were not even able to negotiate the wire distally inside the vessel. So for wiring itself, we had to use a guide extension catheter, that is a guide plus, which helped us in tracking the wire distally, balloon distally, stent distally, and finally achieving a good flow inside the vessel. Thank you. So.
Thank you, Dr. Anthony, for the very difficult and wonderful case. So, did I hear that this patient had an angioplasty previously?
Yes, sir.
That was known that this patient had probably.
So the records were not available. We didn't know.
Okay. So this is a anomalous coronary artery. Left system is arising from the right.
Yes, sir.
So what could be the course of that coronary? So when it goes to the left side, left coronary artery, what could be the course?
So from the right sinus, even the left coronary, the right coronary was arising, sir, and the circumflex also was arising from the right.
So when it goes to the right side, left side, it can go retroaortic, it can go between the vessels, it can go anterior to the pulmonary artery, that is called pre-pulmonic,
yes,
or it can go septal, it can go down and go septal. So which is, if it is between the aorta and pulmonary artery, it is a dangerous situation. So which can be the situation? Can you identify from the angio? So we learn all these dot and I signs in the early angiogram textbooks. When you take a RAO view, if it is retroaortic, the left coronary artery will be showing as a dot just behind the aorta. And this is probably a septal course where the LAD is going down and LCX in above. Yes, so it goes down and then goes as a septally. So it is not going between the aorta and pulmonary artery in this situation. Yes. If it goes between the aorta and pulmonary artery, it has got a high risk of compression between the aorta and pulmonary artery. A very difficult situation to wire, and the guide support is very important. You have mentioned that. Comments?
Anthony, beautifully presented case and wonderfully done also.
Thank you,
and was your first selection of catheter ambulance, short ambulance?
So for hooking for difficult lesions, for hooking the right coronary, the short ambulance is better. The 6 French short ambulance will be more helpful, so that it also acts as a guide, and so that we could pass the wire, field RFC wire, to the distal portion of the vessel.
You thought it will be easier, so that is why you have
Yes,
chosen the
Madam.
Radial, ma'am. Right radial approach was.
Hello. Sorry. See, I have a theory that for right coronary cannulation, radial is always better. So I just wanted to know the opinion of the House, especially in an anomalous coronary.
I mean,
How did you say that this is a course of the artery was not between the aorta and the pulmonary artery? It looks like that.
No, if it in the RAA view, if it is between the aorta and pulmonary artery, the circumflex will be on the lower side compared to the LAD in the proximal part. That RAA view. But if it is septal course, the LAD will come down and then go join. So the LAD will be down and circumflex will be seen above. That is the angiographic identification. There is a dot and I sign. That is the I sign. That is the curvature of the left main. The left main, if the circumflex is above and LAD is below, it is more likely a septal course. And if the circumflex is below and LAD is above, it is more likely a between the course between the arteries.
Ideally, you need a CT angio.
Ideally, we need a
because
CT
these
angio.
patients are prone for sudden cardiac death.
Yes.
Because of left main compression between the aorta and pulmonary artery.
Yes. We need a CT
Because
angio and evaluation.
while doing CT, we see a lot of patients like this who
Beg your
have
pardon,
anomalous course.
Beg your pardon, sir. Can you move on? Can you move on, sir, to the next
So we
case?
can move on to the next
Thank
talk.
you,
Nice presentation, Dr. Anthony.
So the next presentation will be on primary PCA in young STEMI. I invite Dr. Krishna Mohan M for the presentation.
Good morning to all. I am hereby presenting a primary PCA in a young STEMI patient. Coming to the patient details, 35-year-old male who is an assistant professor with a sedentary lifestyle. He is obese. He has a history of hypothyroidism with a TSH of 9.77 at the time of admission. No history of diabetes, hypertension, DLP, no tobacco use, no alcohol, no family history of CAD. A very simple case at the onset, because even I felt Saturday afternoon, going home, he had a chest pain following an unaccustomed exertion because he participated in a cricket match. He had felt a chest pain associated with giddiness and tiredness. Cardiological examination essentially normal. JVP not elevated, CVS S1, S2 normal. ECG, sinus rhythm, heart rate 70 per minute. With ST elevation in 2-3 AVF, ST depression in AVL. Echo, bedside. RWMA, inferior wall plus posterior wall. And this is the angiogram. The left system was essentially normal. And the right system, RCA showed grossly ectatic RCA with occlusion in the distal RCA with thrombus in RPLB and RPDA. So even I felt it's very easy. So I wired the RPDA and started doing the case. But what happened is after 3 thrombus aspirations, I aspirated clumps of clots with intracoronary tirofiban. The result was pretty good. Now what happened afterwards was RCA occluded. Patient went into, I wired RPLB also. But patient went into, after occlusion of RCA, patient went to complete heart block, hemodynamic compromise. So I had to multiply predilate both RPDA as well as RPLB. But there was no flow. So I was confused whether to stent or not to stent. But I went ahead with stenting because of the hemodynamic compromise in the patient. and this was the post-ending result. And post-ending, immediately patient went into sinus rhythm, BP improved, and patient improved. So, patient was discharged on day 3 and on follow-up, currently on rosuvastatin plus bempedoic acid. And coming to the discussion, why young MI is important in our scenario is 1 in 4 patients with STEMI, especially in Southeast Asian region, they are younger than 50 years old. And the most important reason, they are smokers of Indian ethnicity, family history of ischemic heart disease. Mortality is lower among them, but it is not negligible. And significant mortality can lead to loss of productive life years. And 15 years mortality could be as high as 30%. And young patients with first-time MI can have a 2-fold increased long-term mortality. And almost a third of these patients can have a multi-vessel disease. And door to balloon time, this is what we have a difficulty, that even the relatives are not accepting that this young patient can have an MI. So if we can do it within 90 minutes, then they have a better long-term survival. And these are my references. Thank you.
You said the risk factor was only smoking.
No, sir. He did not have smoking as a risk factor. I said smoking as a risk factor, as a predominant risk factor compared to all other risk factors in MI.
Okay. Usually in smokers, we see that the coronaries will be relatively normal. It is just a thrombus there.
Yes, sir. Smoker's paradox. But this patient, I presented this case because of the difficulty, because I did not expect an ectatic RCA with a left system very normal, without any risk factors. Even I felt I could do this case very easily. The reason why I presented this case was because of the ectasia of the RCA and the no flow. Even after multiple dilatations, I did not have any flow, and I went ahead with stenting.
Once you see so much of ectasia and so much of thrombus, you should think that it is already a complicated thing, because often the results are suboptimal.
Yes, sir, because I took this call because, after discussion in the department, majority were of the opinion of not to stent. But because of the hemodynamic compromise, I stented.
So because there was a lot of thrombus, multiple dilatations can have a problem of no flow. So did you consider any antithrombotic measure?
Yes, sir, I had given intracoronary tirofiban.
No, other than that, lytic measures like intracoronary, low dose
tenecteplase. No, sir, I did not give, no, sir, I did not give intracoronary tenecteplase because maybe I was skeptical about the bleeding risk, young male. So I thought, rather than giving an intracoronary tenecteplase, I thought about going ahead with stenting.
The problem is there can be no flow even after stenting such a large thrombus. So you may end up in stenting but with no flow.
Normally, when you have such a no flow after balloon dilatation, it's such a huge thrombus burden, you should not stent. You should defer stenting.
Yes, sir, this was exactly the same opinion that I got.
The problem is, if you do stenting in a patient, you will have no reflow. Fortunately, you had good flow, but most often you will have no reflow.
Yes, sir. With all due respect, what I felt was, I took this gamble. That's why I wanted to present this case, because it was my choice on the field whether to stent or not. So what happened was, when I was putting my stent there, because of the, when I was keeping the stent there, I could get a flow. So I thought if I deploy the stent, the flow may come back.
I think Dr. Jayagopal sir will have a comment on tenecteplase.
No, I think it's mostly the reluctance on the part of people. I agree with Rajesh that, when you have such thrombus, it's often better to avoid stenting. But I think you should see the beauty of intracoronary lytics. In fact, if you pursue it further, this is really a fantastic treatment. Sometimes you can really, it obviates the need for stenting. That's what I would say. In fact, we have a large experience. We have done more than 150, 200 cases now. So it's a very good adjunctive in acute MI. And now people are looking at it as an adjunctive treatment even in a primary PCA without thrombus.
Thank you. Thank you for the
Thank you,
nice
sir.
case.
Thank you. Thank you. Thank you.
Let us move on to the next case.
Next topic, surprises in acute coronary infarction. As you all know, all MI is always a surprise for us. We'll always have surprise. Well, now we'll see what surprise Newman is. Newman.
Yes, sir. Good morning, respected teachers, colleagues, juniors. My topic for presentation today is surprises in AMI. We have chosen 4 cases. It is done by a team of our team comprising of Mustafa sir and Dr. Arun Gopi sir, and I was actively involved in managing these cases. Let us go to the topic. It is like surprises in AMI. So usually our concept is that in acute MI, we go in, do the case, come out fast. So time is very vital. But what happens when we come across these scenarios? So this is like first case was an anomalous LMCA from RCC in acute MI. Though it's not very rare, but the background was it was a 75-year-old hypertensive male who presented with acute anterior MI. The patient had a triple vessel disease and LMCA is arising from the right coronary sinus, and he had mild LV dysfunction. If you look at the angio shot, you can see that with the Tiger catheter, we can see that the RCA is having 90% stenosis, and the LMCA is originating from the right coronary sinus with 90% stenosis in the mid RCA. This is the second shot which is showing that the origin of the LMCA from the right coronary sinus, and the RCA is having 90% stenosis. And distal LMCA, we can see that the distal LMCA has a 90% stenosis followed by 95% sternum stenosis in the proximal left circumflex. So, yeah, it is wired. We used a Tiger guide, and we wired the LMCA to the LCX, and it was after pre-dilatation we sent it with a 3x48 mm DUS. It was some difficulty in negotiating the stent, but with 2 wires we were able to push the stent, and finally we deployed it with a good result, and post-dilatation was done and TIMI3 flow was achieved. Then finally it was decided that since the RCA was also having a tight stenosis, we decided to intervene in the RCA also, and RCA was hooked with a JR, and we deployed a 3x38 mm stent, and proximal was covered with another 3.5x23 mm DUS. And finally, it showed a very good result, TIMI3 flow in both the arteries. So, this is the first case, and coming to the second case, it is rotablation in acute MI. As we know, rotablation in acute MI was considered to be associated with many complications, but right now we know that rotablation, when done in good hands, is very safe in acute MI. So, my case is a 64-year-old male who had an acute inferior posterior wall MI, and angiogram showed a calcific triple vessel disease with 100% occlusion in the RCA, and the patient had fortunately a fair LV function. So proximal RCA has as we can see in the angiogram, the proximal RCA has 100% thrombotic calcific occlusion. So initially we tried to wire with the GR, and we were able to do ballooning. Then finally it was not yielding, so we decided to go with the AL1, and finally this is the after engagement. So we can see that there is a tight lesion there, and also I've tried to demonstrate that we went with the increasing sizes of balloons, and finally even with an OPN 2x10 mm NC at high pressures we can see a dog boning effect there. That is, it is not well yielding. So hence it was decided to go for rota, and it was exchanged with a rota wire, and finally we did a 1.5 mm burr. Started with 1,40,000 and we went up to 1,80,000, and finally we achieved a very smooth result, and we post-dilated with a 2.5 and 9 mm NC balloon, and finally we could deploy a 3x34 mm DUS with a very good expansion. And finally at the end of the day the patient didn't have any slow flow, and we could come out with a very nice result. Now, as sir was mentioning, what about the next patient? We had to use thrombolytic therapy in acute MI followed by primary angioplasty. This patient was a young male, 47-year-old male who had an anterior wall MI, but he came late to the hospital with a delayed presentation with ongoing chest pain. He had no comorbidities. Angiogram showed a double vessel disease with 100% occlusion in LLD and spiral dissection in the RCA. And there was a huge organized thrombus in the LAD with mild LV dysfunction. And you can see that proximal LAD has 100% thrombotic occlusion. So, as a usual routine, we went with an thrombus aspiration. And finally, as we always do, the administration of intracoronary drugs was given. Then finally, check angiogram showed very high organized thrombus. Even after, usually my thing is I usually do a pre-dilatation with a long stent balloon. So usually we can see the lumen. But as you can see clearly, there is a huge thrombus burden. So finally it was decided that we should thrombolize the patient. We gave intracoronary tenecteplase. 20% of the dose was given intracoronary and 80% was given intravenously. We waited for 5 to 10 minutes. And after that, this was a check showed. We showed that a good resolution of the thrombus, and we could easily stent because we can see the distal vessel, what's the size, we can easily do a stenting. So finally, we deployed a 4 into 38 mm dress with a very nice result. So we could achieve almost TIMI 3 flow, and this patient was hemodynamically stable throughout the procedure. And since the patient's ACT was well maintained, we didn't give intracoronary tirofiban at that point. Then coming to the last case, it is an ostial LM occlusion in an anterior MI with no support from the right side. So this was a 75-year-old female in hypotension with acute anterior MI. She had a severe LV dysfunction with moderate MR, and ostial LMCA showed 100% occlusion. A right shot, actually I'm not able to find the right shot, but the right shot showed that there is no, RCA was okay with no distal filling to the LED. So this is the first shot. We are surprised that it is a 100% LMC thrombotic occlusion. We used a EBU, and finally we could wire it with a, and finally we did a pre-dilatation with a 2 into 10 mm NC balloon, and we could deploy a 3.5 into 12 mm DUS, and finally we showed a, TIMI 1 to 2 flow, but the patient then had hemodynamic compromise as already mentioned in the starting of the case. Then we put an IABP, and finally the patient stabilized. She was on IABP for 3 days, some renal dysfunction occurred, but finally the patient's BP picked up, and she is now regularly following up. Last follow-up was last week back. She is doing good. Thank you for the patient listening.
One doubt regarding what about the first case? Till what pressure you went for that OPN balloon?
40. Even after 40 for it was not yielding. So it was decided that we do a road. Because usually, as you said, we are very reluctant. Initial part of my practice I was very reluctant because we had many cases with slow flow and very difficult to manage. Finally, if you have a dissection, very difficult. But right now we have at most 10 cases which are done primary. But usually, if the patient is pain-free, hemodynamically stable, we can plan it for maybe after 3 to 4 weeks. That is also considered, but in this case, because the patient was having ongoing pain, and we decided that we should intervene at that time. That is also a discussion which we had in the lab, whether we should take the patient for a deferred stenting after some time, because the patient will be more hemodynamically stable, less evidence of slow flow. But since the patient was having ongoing pain, and because we had that experience in the lab, so we thought we will just do the stenting then and there itself.
Any complications happen?
No, sir. Fortunately, some transient slow flow, which we could manage, and TPA was definitely put, but patient was not TPA dependent, didn't go for any bradycardia or any, but he had a transient slow flow which is managed with medicines.
One more thing about the tenecteplase patient. So any other bleeding complications?
No, sir. He was a young male. He didn't have, sir, usually we don't know whether he has a history of COVID. He was not post-COVID. That time the COVID report came as negative. But right now in the post-COVID scenario, we have many patients like this, and we are confident in giving tenecteplase.
It was a radial access, no?
Yes, sir, radial access.
Thank you.
What was the dose of tenecteplase you gave?
40, sir.
Intracoronary?
No, sir. We gave 20% IC, and the rest of the dose was given intravenously.
20% means 10.
Sir, we calculate the dose, and after 20% we give intracoronary. Rest of the dose we can give IV, wait for some time, check the ACT. If the ACT is maintained, we don't give any tirofiban or abscissima.
The question about this, thrombolysis and PCA, immediately stenting. So is it advisable to put a stent immediately after thrombolysis as in this case?
Yes, sir. Yes, sir. We can put a stent, sir, if there is no bleeding and we have ACT is well maintained, we know the distal diameter size. I think there is no harm in stenting right now. Or in some cases, we give thrombolysis, we achieve a very good result. We feel that still there is some thrombus, the patient can go for complications. We'll call back the patient, do imaging, and that will be more better.
Generally, in the pharmacoinvasive strategy, the dictum is you have to wait for around 3 hours after thrombolysis. So Is it applicable to
Sir,
this
this
case also?
patient was young,
I
young
know.
patient, so we didn't expect much. If it was an older patient, definitely we would have waited for some time and did an imaging for this patient and to optimize the stenting, sir.
Probably, I also feel that it could have been done a little later. But in the first case, when you did the LAD, that is anomalous left system, then why did you change the guide?
So because like it was after doing that, it was coming out, sir.
Okay.
RCS were not able to hook with the same. Actually, it was very easy for us to do with that.
With the
But
same
like
guide, you could
because
have
like there was some difficulty in like that thing because it's not giving much support to the RCS, sir. So we had to change over the guide like once we were intervening in the RCS.
Can we move on, sir?
Okay, thank you. Thank you. Nice 4 cases.
Thank you.
Next, we will call the next case, Dr. Devendran P. An interesting case.
Okay. Good morning, senior teachers and my dear friends. First of all, I thank Dr. Jayagopal and the organizers for giving me an opportunity to present a case. This was a last-minute selection, so the exact title was not given. This is a case of primary PCI and stage multiverse PCI in anomalous coronary. My patient is a 59-year-old male with dyslipidemia for 5 years untreated with no other comorbidities. He presented with acute central chest pain of 2 hours duration, ECG showing inferior LMI, and echo showed good early function. So planned primary PCI and right radial approach. So this was a left shot. We showed only the LAD from the left sinus with a significant stenosis from proximal to mid segment. So I hooked the RCA. So you can see the RCA is totally occluded in the proximal segment, and the circumflex is originating from the RCA immediately after origin. And it also has 2 lesions, one in the proximal part and one in the major OM. So I proceeded with the primary angioplasty with a 6 French GR 3.5, the run through guide wire. And the lesion was, the vessel opened well after wire passing, and so thrombosection was not given, pre-dilated, and it was stented with a 2.75 into 38 millimeter ultimatus stent, which was first dilated with a 2.75 balloon, with a good result in the RCA. So I took him, and there was a little radial spasm. So I took check shots. It demonstrated a high origin of the radial with a very small radial. So I was sure I may not be able to proceed with the radial for the stage procedure. So this was the type of radial, the second origin. So I took him for stage PC after 48 hours. And this time when I was hooking the RCA, I was trying to, the catheter was getting deep throated into the circumflex. So I put one more wire in the RCA. So I pre-dilated both lesions in the circumflex. I put a 2.25 into 15 millimeter drug-eluting stent in the OM and a 2.5 into 16 millimeter disc in the proximal circumflex, which was first dilated with a 2.5 millimeter NC balloon. And this was the result of the circumflex stenting. And I hooked the left, you can say LAD, with a 6 of XP 3.5 with the BMW wire, pre-dilated with a 2.5 millimeter NC balloon, and it was stented with a 3 into 32 millimeter drug-eluting stent, which was first dilated with 3 into 10 millimeter NC balloon. And this is the final result. This case was present only because once in a while, yes, because people have shown more interesting anomalous origin here. So this is one of the, you can see the incidence of around 1% I got from literature, but some of the literature say the incidence of origin from opposite sinus is only 1 in 1,000, because this may be the total anomalous origin. And LCX with separate ostium from right sinus is most common, and LCX from main RCA is the second most common. And these type of anomalies can pose considerable challenges or technical difficulties during PCI. Here, I didn't have much of technical difficulty, so I present only because of this rarity. Thank you.
Sir, it's complex case and done well. I was in the initial it was a primary angioplasty, sir.
Yeah.
So at that time, when we are seeing LCX ostium seems to be slightly involved.
Yeah.
But in the later shots, the ostium is okay.
Yeah, I have taken multiple shots. Here,
yeah,
for presentation, I took only selected shots.
Like I thought, when we are
Yeah.
assessing
No, no,
during an ACS,
Yeah.
we might overestimate or because of the spasm and associated.
I know.
So it was when we
But it
came
also
for the
was
second
getting
procedure,
deep throated in the RCA.
Yeah.
So
maybe
I
because of the
confirmed that
guidance.
the ostium is not involved.
Yeah. Yes.
Okay.
Large number of anomalous coronary arteries in this presentation, and technically challenging to negotiate the wire and the tendons. But you did well.
Thank you.
So just to highlight one point that your technique of managing that anomalous circumflex artery, it's wonderful. You engage the right coronary artery with the catheter, you had a wire inside the right coronary artery, push the wire distally, disengage the guide catheter so that it's stable in the coronary sinus rather than inside the right coronary artery. Then with the second wire, you wired the anomalous circumflex and went ahead with the procedure. So
Initially, I wired the circumflex. Then it was getting deep throated.
It's not possible.
Pulled back the wire, I wired the
That's
RCA.
a very good technique of managing this anomalous circumflex from the right sinus, right coronary artery.
Thank you. Thank you.
Any questions? Any discussion? Thank you.
Next session is PAMI and occluded SVG by Dr. Deepa Davidson.
Good morning to all of you. Thanking Jayagopal sir and organizing team for the opportunity given. I believe this was sent for the for this conference by Dr. Anthony, and fortunately I got an opportunity to present this case. Thank you once again. Well, this was an elderly gentleman who had a bypass surgery in 2001. He had a Lima to LED vein graft to diagonal RC and OM. He had a check angiogram in 2014. Vein graft to OM was occluded. Now he presented with an infuval myocardial infarction in a nearby hospital. He was thrombolized with retiplase, did not have relief of symptoms, was referred to us for a rescue angioplasty. The left system was reasonable. The graft to the OM had occluded, but then the flow inside the OM was reasonably good. The LED was occluded in the mid segment. The right coronary was occluded in the proximal segment. In the second image, you could see that the right coronary is occluded. And those are the vein grafts. The vein graft to RC is proximally occluded. Those are the second one shows that the flow inside the diagonal branch is good, even though it's a very small graft to the diagonal. Well, the flow inside the Lima also was good. So our plan was to open up the vein graft to the right coronary artery. Normally, it's recommended that when you have a post-CABG infuval myocardial infarction or so, it's better to open up the native vessel rather than the vein graft. But then here the native vessel, the right coronary was austerely occluded. It was a chronic total occlusion. So we decided that we have a try our luck on the vein graft to the right coronary artery. That's a guide catheter, the multi-purpose guide catheter. Sitting well aligned in the vein graft to the right coronary artery. Wiring was extremely tough. We could not get the run-through wire across or Versitan wire across, so we wired with a Fielder XT wire. That's the Fielder XT wire. Then we started aspirating the graft. You could see that we aspirated a lot of clots from the proximal end of the graft, and still there is some amount of clots remaining there. We had to have almost 10 passes, more than 10 passes of aspiration from the proximal portion of the graft. You could see now that in the mid portion of the graft, there is a tight stenosis. Still there is some amount of clots left. So we again took the aspiration catheter. In the second image, you could see that we were pushing our multi-purpose catheter across so that we could go distally and aspirate also. Because the multi-purpose catheter was well aligned to the vessel, we could easily push it across without damaging the vessel. Then after that, we had a tight lesion in the proximal mid portion of the vein graft. We dilated with a 2.5 millimeter balloon at just 8 atmospheres, hoping that it wouldn't embolize distally. So that was a balloon dilatation at very small pressures. That's the amount of clots that we could aspirate from this proximal graft of the right coronary artery. And once The balloon dilatation was done. You could see that the flow inside the vessel is good. There are two lesions, one in the mid segment, which is actually the culprit, and distally also there is another lesion. So we wanted to stent both the lesions. The challenge with this while stenting the mid lesion is it's going to embolize distally. We would end up with this slow flow. So we wanted to have a distal protection device for during stenting of the mid lesion, which is actually the culprit. So again, if you look at the distal vessel, there is significant amount of lesion there, which would prevent us from deploying a distal protection device distally. So we decided that we'll stent the distal lesion first. So through that proximal lesion, we could track a stent distally. The stent was deployed. It was a 3.5 millimeter stent. It was aggressively post dilated so that while positioning the distal protection device, it won't get stuck to the stent. So subsequently, we took the distal protection device distally. That's the distal protection device being launched into the distal vessel that is actually positioned inside the stented segment. You could see that the distal protection device going distally beyond the lesion, and once that was deployed, we were able to get the stent across in the proximal segment. That is a 4 millimeter stent, one proximally, then furthermore proximally there was a lesion that too was stented, and that's the stenting being done, 4 millimeter stent in the proximal segment. And finally, we had in this image, you could see that there is some amount of, first image you could see that there is some amount of slow flow. We removed the filter, and after removing the filter, we gave a lot of intracoronary vasodilators, and subsequently we were able to achieve good flow inside the vessel. So this particular case was presented primarily to highlight few points. One, usually when you have an MI with the vein graft, usually the outcomes are not good because it's huge amount of thrombus burden inside the vessel. Point number one. Here we had a CT of the right coronary artery. We decided that we'll try a luck with the vein graft. It paid off. Second point was to highlight the usefulness of multi-purpose catheter, which is well aligned to the vein graft to the right coronary artery. Third point is to highlight the usefulness of distal protection device, stent the distal segment and then have the distal protection device. And finally, regarding the usefulness of aspiration catheter, we had multiple passes to remove the entire clots from the coronary artery, and finally we could achieve good flow inside the vessel. Thank you so much.
Nice case, Dr. Deepak. When you were passing and the aspiration catheter, actually it was a tight lesion. The guide catheter was going deep in, when you are withdrawing it. So the mid lesion was really tight.
The mid lesion was an extremely tough lesion.
Yes,
because we were not even able to wire with the regular wires, so we had to go for a Fielder XT wire to wire the mid lesion.
So when you were actually withdrawing the aspiration
you
catheter,
could see
the guide
that
was diving in.
Yes.
So was there an initial lesion in the proximal part, or was it induced by the guide?
We're not very sure about it. We also had to push the multi-purpose catheter so that we were able to cross the lesion also. Okay. And when we pulled it out also, you could see the guide catheter going in. We were not sure. Again, it was a 50% lesion, but then when you have a 50% lesion in the vein graft, we thought it's better not to leave it, so stented it, the proximal segment.
Again, dilating and stenting after 2 days or 3 days, is it an option?
Dilating and?
Stenting, avoiding, postponing stenting for 2 or 3 days for the thrombus to go away, is it an option?
Absolutely, that's an option for a vein graft, but then always, even if you wait, there is huge amount of muck going to be there. When you stent, there is always a risk of distal embolization because these are the 4 millimeter sized vein grafts which usually embolizes and leads on to problem. We didn't have distally particles being captured inside the protection device, but then we had a slow flow which resolved very well.
Nice case.
Yeah, Deepak, very good case. Deepak, my question is, see, you had multiple passes of, we know that thrombus extraction devices, glycoprotein 2B3A doesn't work, and the classical dictum was always put in a distal protection much before that. And you dilated quite aggressively with the 2.5 proximally.
8 atmospheres.
Whatever. So what I'm saying is multiple passes, pre-dilatation, all this would have thrown the muck.
Yes, sir.
After that, do you think that the distal protection would have done that much?
Yes, sir. Many a times, during stent deployment and post-dilatation, that's the time we tend to encounter the slow flow in these vein grafts. So that was the intention. During stent implantation and post-dilatation, he shouldn't have, because you open up the vessel, you deploy the stent and you see that there is no flow distally in many situations. That was the reason why we wanted to have it before.
Deepak, well done. I fully agree with Dr. Jayagopal. The distal protection device should be placed first. The idea of putting a distal protection device is to prevent the microcirculation being clogged with thrombus. In the process of balloon dilatation, you already showered thrombus in the distal circulation. So there's no point putting a distal protection after balloon dilatation. So always before, after you're wired, put a distal protection device first. Because vein grafts are notorious for having huge thrombus burden and friable material. So it should have been done before.
Yes, Rajesh, I would agree with you. There were two reasons. One, it was an extremely tough lesion. The distal protection device, the device wouldn't go distally. That's number one. And secondly, there are two reasons why you could have slow flow: thrombus and the friable material. The thrombus we try to aspirate as much as possible with the aspiration catheter, and whatever friable muck that's inside the lesion, that embolizes many a times, leading on to slow flow. So that was what was intended to be managed with the distal protection device.
No, I fully agree with you that you deployed the distal protection device at the correct time. The reason is that otherwise there was no space to deploy the distal protection device. You have to make space and then only deploy it. Now, I stood up to ask a different question. In vein grafts, they always say you should not go up very high with your pressures. So I want to know what pressure you deployed the stent. That's all, just for the interest of the house. You've done a wonderful job. And you could not deploy the distal protection device earlier. Where was the space?
Yeah, ma'am. Balloon dilatation was just at 8 atmospheres. The stent implantation was 12 to 14 atmospheres. And post dilatation was done with almost at around 18 to 20 atmospheres. But till we did that, we had a distal protection device. And then only we removed the distal protection device.
Sorry. Very nice. It has been a very informative discussion about vein graft angioplasty. The classical teaching is a totally occluded vein graft is not considered for angioplasty at all. But here, this patient came with acute MI and a primary angioplasty was indicated. So I am sure you are quite justified in doing the procedure. It has been done very well. And I agree with your point that the distal embolization and occlusion usually happen when you do the stenting.
Yes.
Not with ballooning. So you are quite right in putting the distal protection device before you are stenting. With so much difficulty. And wonderful result in the end.
Thank you, sir.
Very good.
Thank you, Dr. Deepak. Let us move on to the next case, last case. Ectasia, what next?
For the kind attention of the chairpersons, the
Dr.
next
Sanjeev.
case will be presented by Dr. Sanjeev Kumar, please.
Good morning, everyone. Thank you for this great opportunity, and thanks to my faculty for their guidance. Now I will start with my case. So he was a 66-year-old male who presented to the casualty with angina for more than 30 minutes, and it was associated with dyspnea and orthopnea. Patient was diabetic, hypertensive, smoker, and heavy drinker. And on examination, the heart rate was 36 beats per minute, BP was 90/70, and chest showed bilateral crepitations, and the CVS examination was clinically normal. So patient was, ECG was showing complete heart block, and also ST elevation in lead 2, 3 AVF, and also ST depression in lead V2, V3, V4. And 2D echo was showing RWMA of the inferior and posterior wall along with severe LV dysfunction. And the patient was diagnosed as a case of inferior plus posterior wall MI and complete heart block with hypotension and suspecting an RCA occlusion, and we took up the patient for primary PCI. And via the right radial approach, and we engaged the RCA with the 6 French this JR 3.5 catheter, and it showed the mid RCA occlusion with the TIMI 1 flow. So then the lesion was crossed with the run through extra floppy wire, and it was parked in the RPLB. And the lesion was pre-dilated. Then we did the thrombus aspiration, and distal RCA was also showing a large thrombus burden, and the distal thrombus aspiration was also done from distal RCA. Then we dilated it was still showing critical obstruction. Then we dilated the mid RCA lesion with the 2 2 by 15 semi-compliant balloon, and followed by the 5 by 15 semi-compliant balloon, and followed by 5 by 12 non-compliant balloon. And it was showing reasonable flow, but very slow flow. And the distal RCA was also dilated by 3.5 into 15 non-compliant balloon. This was the dilatation of mid RCA. Then distal RCA was also dilated with 3.5 by 15 non-compliant balloon. And during the procedure, the thrombus was reaccumulated, and so we did the thrombus aspiration again, and the intracoronary tirofiban was also given, and the 6 milligram intracoronary and 24 milligram intravenous tenecteplase was given. So then we were able to establish the reasonable flow, but the RCA was not stented because of the no landing zone availability, and we did not have the larger stent size because the RCA was very big, around 8 mm, and there was a fear of stent embolization distally or the under expansion of the stent. So we did not stented the RCA. And then with the Tiger catheter, we cannulated the left main, and then the left angiogram was also showing the proximal LAD ectasia, and LAD was 6 mm with ectasia. So after the procedure, the ECG was, patient sinus rhythm was restored, but it was still showing ST elevation in 2-3 AVF, also ST depression in V1, V2, V3. So patient, after the procedure, we shifted him to cath ICU, but the patient became very agitated and was managed as a case of alcohol withdrawal. After trying to settle down the patient developed acute dyspnea. Then he was managed as case of acute pulmonary edema, and he was treated with diuretic, morphine and NIV. But the patient developed respiratory exhaustion, drowsiness. So then we have to intubate the patient, and then the patient was put on a ventilator and on inotropes. Then the LFT got deranged, so the patient was also managed as hepatic encephalopathy, but the patient never came out of the ventilator, and patient expired after 2 days. So basically, ectasia is it is a dilatation of the coronary artery lumen, and by definition, that diameter should be more than 1.5 compared to the normal adjacent segment, and length should be more than 1/3 the coronary artery length. But if the normal artery for comparison is not available, then we can use the age and sex match cohort as a reference value. And in case these patients with coronary ectasia, if they present with acute coronary syndrome, then we may require thrombolysis, that may be intracoronary thrombolysis also, along with the GP2B3A inhibitors or even heparin administration. And for the tenecteplase, the dose is 1/5 dose should be given intracoronary and 4/5 dose should be given intravenous, along with the 24-hour heparin infusion. And in case of large thrombus burden, we can do the thrombus aspiration also. And other options are the percutaneous and surgical option. We can use covered stents or stent-assisted coiling, or we can use the double open cell stent implantation. But the problem is that we have to have a landing zone. If it is not available, then it may be not be possible. And if the stent may be of very high profile devices, maybe stent may be of very stiff and may not able to track. And so the optimal stent sizing is essential or to prevent the embolization or misplacement of stents. And other option is the surgical option, but then we have to bypass the ectatic vessel. Thank you.
Can I make 3 comments? You have done a very heroic effort, but for future, I'll give you 3 points which probably you should have done, but outcome could have been anything. One is you shouldn't have given morphine. Morphine is my enemy. Should have given fentanyl. Second thing is for alcohol withdrawal, you can give high dose of Librium, 10, 10, 20. The third thing is you could have considered using a peripheral stent or an onyx stent, but I don't know whether you had it online. Like for example, when I was in Trivandrum Medical College, for an ectatic lesion, if you want to put a peripheral stent, it may not be available. Yes. But peripheral stent you could have put. So these are my suggestions.
Actually, it was primary.
Yeah,
and then-
may not be available. That's the problem in government sector. But it was a heroic effort. The Tenector place and everything was good, but avoid morphine.
So this is one doubt. When you have got two ectatic segments and in between a narrow segment, you dilate it with a 5 millimeter balloon. So how do you know that that region is really 5 millimeter? Can it rupture? So normal coronary is not 5 millimeter.
Yes, sir.
So
That,
did you consider imaging, like you could have done imaging to assess the size of the lesion there before dilatation?
Initially, it was done with 2 mm balloon, but the lesion was not giving away. So then we have to go with the higher balloon.
Okay, my question is, did you consider imaging, because you could have been intravascular ultrasound or something like that?
Huh?
IV was
not done.
So we are taken away, I think we are taken away by the ectatic region before and after that, and a stenotic lesion is there. So unless you know the actual vessel size, you may be carried away by the size of the ectatic segments up and down. So you have dilated with a 5 millimeter balloon. Can it produce a rupture of the, if it is a normal segment, can it produce a dissection or rupture? That is my question. I don't know.
It was a like proximally and distally, just very small segment. Maybe that was a normal segment. Ultimately, we have to dilate that lesion. It was not giving away. We tried with a smaller size balloon, but it was still not showing flow.
Can
distance.
assess this, the vessel and then dilate with 5 millimeter?
Yeah, I think you made a very valid point. Sometimes, the normal vessel is a 3 millimeter, either far proximally or distally. But then in an occasion like this, sometimes we get to see a very ectatic segment with a very tight lesion. But I think once I have got away with even a renal stent, 6 millimeter vessel it was. But then the only thing is you don't be over aggressive in dilatation. It's like a peripheral vessel at that point of time. You get a fairly decent result. Don't worry too much about making it a perfect result. Otherwise, you end up in a slow flow, whatever.
So I think last comment, quick comment, because
just a point regarding using renal stents, 6 millimeter renal stents. Many times you would need a 7 French guide catheter, because once you dilate the stent inside the vessel, taking out the balloon through the 6 French guide catheter will not be possible, because it's a huge balloon, so you need to have a 7 French guide catheter. Similarly, when you deploy the stent, as sir has mentioned, you have to deploy it in one go, because it may not open up fully. You would think that you'll take out the balloon and do post dilatation with a different balloon. You may not have a 6 millimeter balloon in the cath lab. So or dilate it properly, 7 French guide catheter, dilate it properly, deploy it in one go and take out the balloon through the 7 French guide catheter.
thank you. Thank you all for thank you Dr. Sanjeev for the nice case. Thank you all the presenters for the nice cases and the audience for the discussion. And I thank all my coaches. Thank you.
Thank you very much, sir. An interesting start to the scientific program. We move on to session 2, and may I please invite the chairpersons, Dr. Biju Isaac, Dr. George Koshi, Dr. Sham, chairpersons for our next session. Next session titled Emerging Trends in Cardiology. May I please also invite Dr. Raju George, please, to co-chair the session. I hand over the proceedings to our esteemed chairpersons. Once again, may I request the presenters to kindly stick to your stipulated time, please. Thank you.
Good morning. We will have an interesting talk on diet controversy in serious diseases, especially in this era when about trans fats, both industrial and rudimental, more talks are going on and controversy is going on. We will have a good talk by Dr. Binoy Benjamin. Dr. Binoy Benjamin, please.
Good morning. Good morning, respected teachers, senior colleagues, and friends. So, I'll be touching upon these controversies on this diet in regard to the amount of carbohydrate, low carbohydrate, and keto diets. So, as we all know, these are popular Indian foods. All have high carbohydrate. So, it's a well known fact that in general, Indians eat a lot of carbohydrate. The percentage of calories coming from carbohydrate is very high, and many researchers feel that this could be the reason why we have more diabetes, more obesity, and to some extent, cardiovascular diseases as well. So, low carbohydrate, high fat diets are popular weight loss strategies. You reduce the amount of carbohydrate and replace that with fat. In 2021, a study says up to 16% of US adults were following some forms of LCHF diet. But its long-term effect on mortality and morbidity is controversial. If you look at the dietary pattern based on the amount of carbohydrate, on one end of the spectrum, we have high carbohydrate. More than 70% of the energy comes from carbohydrate. On the other hand, you have very low carbohydrate diets, and to the extreme end, you have keto diet. Here, only less than 10% of the calories come from carbohydrate, and you replace the rest by 70 to 80% by fat. And there is something called keto diet where 10 to 20% with carbohydrate and more than 45% diet. So today we'll be discussing about very low carbohydrate diet, VLCD, keto diet or keto-like diet. So there could be some potential cardiometabolic benefits when we go for VLCDs or keto-like diets. Weight loss, reduction in triglycerides and better glycemic control. If you look at the weight loss, some of the studies, meta-analysis and reviews shows that VLCDs are associated with weight loss. But in most of these studies, these are not sustained beyond 1 to 2 years. And if you use the same in pre-diabetes and diabetes, greater weight loss was seen, but it's observed only up to maybe few months, 6 months or 1 year like that. Could be because these patients may not be adhering to these diets over time, and loss of lean body mass can be offset by high protein intake. Hence, guidelines do not endorse these type of diets for weight loss. Now, what about triglyceride lowering? Triglyceride levels are inversely associated with carbohydrate intake. A good reduction in triglycerides can be achieved with low carbohydrate diet that are less restrictive. You need not go for real keto, classical keto diet. Even with low carbohydrate diet, you can achieve good triglyceride lowering. What about glycemic control? Again, reducing carbohydrate intake in diabetes is recommended by ADA. Most studies showed a small but significant reduction in HbA1c only up to 6 months. But there are studies showing no difference in HbA1c or even with very low carbohydrate like keto diet also. There are studies showing that there is no impact in glycemic control. What about the risk? There are potential cardiometabolic risks like increase in LDL cholesterol and potential increase in mortality. If you look at the increase in LDL cholesterol, again, contradictory reports are there. In a meta-analysis in 2006, showed significant increase in LDL cholesterol up to 12 months despite a significant weight loss. But there are studies where even in obese people, it reported a small decrease in LDL cholesterol as well. But by and large, in general, elevated LDL cholesterol levels have been observed in most of the studies where VLCDs are used. So in generally, LDL cholesterol goes up. What about mortality? Again, some reports are there, some contradictions, like several large cohort studies from North America and Europe suggested an association between high mortality and low carbohydrate diet. And on the other side, in 2017, one peer study from 18 countries across 5 continents, it was a large study involving 135,000, reported increased mortality associated with high carbohydrate intake. So this is an important study published in Lancet in 2018, where the ARIC cohort was assessed. More than 15,000 patients aged between 45 to 65 were assessed to know what's the impact of mortality depending on the dietary carbohydrate intake. And the researchers got a U-shaped association between the percentage of energy coming from carbohydrate and on all-cause mortality, both in ARIC and PURE. You can see both high carbohydrate diet on one extreme, it causes high mortality, and low carbohydrate diet also increases comfort, high mortality risk. Whereas a moderate carbohydrate intake to the tone of, that's a sweet spot, between 50 to 55% intake was having the least amount of mortality in this trial. In pure also, when you go with high carbohydrate diet, that's pure study result is depicted in blue. There also in high carbohydrate diet, your mortality goes up, and between 50 to 55% intake, you have reduction in mortality. And one reason why many researchers feel is increase in the intake of animal protein. See, when you reduce this carbohydrate, you replace that with protein, and many of these studies, diets permit liberal intake of animal protein like beef, pork, etc. And these diets high in animal proteins are associated with cardiovascular risk in some of these studies. Even in the same study, when you replace this carbohydrate with animal protein, your mortality risk is higher. Whereas, if you replace that with plant protein and fat, such as vegetables, nuts, peanut butter, and whole grain breads, it is associated with lower mortality. Another reason is you displace cardioprotective foods. There are certain, you restrict some of the important cardioprotective nutrients like fiber-rich whole grains, beans, legumes, starchy vegetables, and most polyphenolic fruits like berries, apples, and all, and which are associated with reduced carbohydrate intake. So that could be another reason. Now, what's the present hot controversy? That keto-like diet is associated with increased risk of cardiovascular events. This was published, this was a study published in, it was presented in recent ACC 2023. Study from University of British Columbia, association of low carbohydrate, high fat diet with plasma lipid levels and cardiovascular risk in a population-based cohort. Here, a keto-like diet was compared with standard diet. Keto-like diet, you are using less than 25% of the daily calories from carbohydrate and more than 45% from fat. And anyone who is not following this diet is labeled as standard diet, and these were compared. The study group analyzed the data from UK Biobank, prospective population-based study, more than 50,000 patient participants, aged between 45 to 75, predominantly healthy white European ladies, and the result shows there was significant increase in LDL cholesterol and apolipoprotein B. After 11 years of follow-up, 9.8% of LCHF group had cardiovascular events, whereas it was only 4.3% in standard diet. Hence, keto diet pattern has twice as many cardiovascular events when you compare it with standard diet. You can see the result. That graph which is shown in red is that low LCHF group. You are having significant decrease in the probability of event-free survival. And if you see the hazard ratio for events, definitely diabetes and current smoking has more hazard ratio, but when compared with hypertension, this has got more hazard ratio than hypertension. And if you see the subsets with highest level of LDL cholesterol have maximum mortality, but even in lower levels of LDL cholesterol, the mortality with this particular diet is more than standard diet. There are lot of limitations for this study. It's an observational study, so causal relationship cannot be inferred. It's a self-reported dietary assessment, so it cannot be accurate, may not be accurate, and participants provided dietary information only in one point of the time. We don't know whether they adhered strictly to this diet for the next 10 or 11 years. It's a relatively small sample size. Only around 300 patients were adhering to this particular diet, and the effect observed in this cohort of British descent, majority women, healthy adults, can we extrapolate to the whole world population? That's again controversial. So in a nutshell, keto-like diets do not give sustained benefit over years. At the same time, it could be harmful as it causes increase in LDL and more atherosclerotic cardiovascular events. So you should be targeted at a balanced diet, which is the key. Moderate the carbohydrate intake to 50 to 55% of the total calorie intake. Keto or keto-like diet should be discouraged, especially in high-risk individuals with high LDL cholesterol. If someone is already on keto diet, check and control LDL cholesterol meticulously. Thank you.
Any questions, please?
Bino, it was an excellent talk. I think the message is everything should be done in moderation.
Yes.
Extreme is bad. There was such a lot of enthusiasm on keto diet, and now it has come down. First of all, it does not sustain the weight reduction. The problems related to elevated LDL, adverse outcome, everything has come to light. I think that is a standard rule everywhere.
Excellent talk.
My question is, Bino, what about the Mediterranean diet? Do you think there's still some, I think that's the only thing which has come to stay.
So anything, whatever you go for moderate. See, in this talk I was concentrating on the amount of carbohydrate. So on both the extremes are dangerous. Too much low carbohydrate in the diet and too high. Both are dangerous. We go for moderation.
May we move on, sir?
Thank you, Dr. Bino, for the excellent talk. Now, I call it, there's a popular belief that exercise may induce arrhythmias in hypertrophic cardiomyopathy. But some of the studies have shown that there is no increase in the sustained ventricular arrhythmias with the hypertrophic cardiomyopathy and exercise. So, Dr. Vinay Kumar, I'm inviting Dr. D. Vinay Kumar for giving an excellent talk on exercise in hypertrophic cardiomyopathy.
Good morning, respected teachers and dear colleagues. Hypertrophic cardiomyopathy, as we all know, is a very common entity. It is characterized by a thick and non-dilated LV in the absence of any other cardiac, systemic or metabolic condition. Mutation mainly occurs in the gene encoding the sarcomere proteins. It presents usually as an autosomal dominant condition, but at least a dozen mutations are there, 50% of which affect the beta-myosin heavy chain or myosin binding protein, and 40% are still unidentified genes. Many storage disorders can mimic hypertrophic cardiomyopathy either as a genocopy or as a phenocopy. There is inappropriate LVH and due to intrinsic muscle cause. Epidemiology frequency is as high as 1 in 500. There can be nearly 2 million affected people in India. Exact number is not known. And the progression to advanced heart failure is found to be more common in females. The obstruction in LV in HCM is typically dynamic, and the dynamicity depends on increase in contractility after load and the volume. Any increase in contractility like a VPC, beta agonist or exercise can increase the obstruction. Any increase in chamber volume reduces the level of obstruction, and any increase in afterload also reduces the level of obstruction. Pathophysiology, there is eccentric LV hypertrophy. There can be dynamic LV outflow obstruction either because of an LVOT hypertrophy or SAM of anterior mitral leaflet or both combined together. There can be associated mitral regurgitation, diastolic dysfunction, myocardial ischemia, dysrhythmias and autonomic dysfunction. Now, background, generally HCM patients are discouraged from participating in physical activity, but almost 45% of these patients meet with minimum guidelines for physical activity. Generally, HCM is associated with a low mortality, about 0.5% per year, and in many low intensity groups it is at par with control population. But it is said that almost 25% of the HCM patients die out of the disease. That is, their primary cause of death is HCM itself. And the prevalence of obesity is about 55%, and it's probably because of their inherent fear in engaging in active exercise. Again, 10% of these patients are found to suffer from psychiatric comorbidities such as anxiety, depression, alcohol abuse and like that. Minimally asymptomatic patients, those who are having a low metabolic exercise capacity, there is almost less than 5 METs were found to be at increased risk of death or development of severe symptoms compared with their fitter counterparts. Now, there are several potential benefits for exercise as well as the risks. The risks include increased arrhythmogenicity secondary to myocyte dysuria and fibrosis. Then the volume shift may contribute to increased LVOT obstruction and syncope. There can be abnormal intramural coronary arteries causing ischemia, catecholamine surge causing arrhythmogenicity, and increased myocardial oxygen requirement causing a supply-demand mismatch. So many beneficial points are also noted. These include a prevention or reversal of fibrosis and myocyte dysuria, heightened vagal tone causing a reduction in arrhythmias, peripheral adaptation, increased diastolic filling and stroke volume causing an apparent reduction in the outflow obstruction, and a reduction in the traditional cardiovascular risk factors. Now, the low intensity group, limited evidence for recommendations. Limited number of RCTs are there, and the available RCTs show in moderate intensity exercise that increases the VO2 max, increases the quality of life, and the arrhythmia burden is reduced. But the cardiac morphology and cardiac function remains unchanged in spite of exercise. Another study shows that there is increased functional capacity, increased exercise time, increased heart rate recovery, a lower NYHA class, and subjective improvement without any appreciable increase in adverse events. In high intensity exercise in observational athletes and all, it is found that the LV end diastolic dimensions increase, LV wall thickness decreases, cardiac function improves, VO2 max increases, there is a blended BP response, and there is a reduction in the resting LVOT gradient. There is no effect on LV fibrosis. Another study again shows there is increased LV end diastolic as well as end systolic volumes and dimensions, improved diastolic function, improved stroke volume, but no effect on LVOT gradients and fibrosis. Now, the ESC guidelines of 2014 says that patients should be advised against participation in competitive sports and discouraged from intense physical activity, especially when they have risk factors like other risk factors for sudden cardiac death or significant LV outflow obstruction. Then ESC as well as AHA have come down with a risk calculator where you feed the data, you will get the result. I don't know how much it is useful in practical life. Now, the recent HCM trial, one of the available randomized control trials had a enrollment of 136 candidates. Participants are randomly assigned for 16 weeks of moderate intensity exercise training or usual activity, and there was a statistically significant but small increase in exercise capacity at 16 weeks with no additional occurrence of sustained ventricular arrhythmias, cardiac deaths, or appropriate DC shocks in either group. The ACCH recommendation of 2020 recommends for most of the patients with HCM, mild to moderate intensity recreational activity is beneficial in improving cardiorespiratory fitness. But just like that, participation in high intensity recreational activities of or moderate to high intensity competitive sports may be considered only after a proper and shared discussion and evaluation. So these two are the most salient recommendations. Now, generally saying, people who are inactive may be prompted to undergo light to moderate recreational exercise activities regularly, but vigorous exercise and high intensity competitive sports must be taken up only after a proper discussion and evaluation. A shared decision making, there is a dialogue that allowing the patients and care providers to work together to select out options is always good, and that is useful when there are complex pathways that vary by the individual patient. Now, guidelines for stratification: survival from cardiac arrest due to a VT or VF, spontaneous or sustained ventricular tachycardia causing a hemodynamic compromise, a family history of sudden cardiac death, LV wall thickness of more than 30 millimeters, non-sustained VT, abnormal BP response during exercise, then a reduced LV ejection fraction of 50% or less, associated LV aneurysm or extensive late gadolinium enhancement in MRI are supposed to be indicative of a high cardiac risk. Now, classification of exercise in 2020 SCHA light, there is those who are having a low effort level are supposed to be having a low effort level, or those who are having a low level of positive exercise in box scale are supposed to be at a higher risk. Now, the last ACCA, this is a live trial present in the 2023 ACC, present by the American College of Cardiology, Rachel Lampert et al. Is the largest observation study available till date. Number 1,546, 40% of females, 20% younger than 25 years. Inclusion criteria: diagnosis of HCM or genotype without a phenotype. Exclusion criteria: those who are having a 3 or 4 NYHA class, then those who are having syndromic or inflammatory diseases or inability to complete the questionnaire due to any reason. And the outcomes: participants are surveyed for 6 months for the occurrence of events, and so that endpoints were death, resident cardiac arrest, syncope, or appropriate shock from a cardioverter. Results were: primary endpoint is experienced in 77 patients, 44 events in non-vigorous group, 33 events in vigorous exercise group. There was no significant difference. The composite endpoints, again, the difference was not very marked. But limitations were the participants were self-selected for vigorous exercise, there was no randomization, and participants were cared for in high volume centers. Now, caution to be advised during exercise: good hydration practices, avoid exercising in extremely adverse environmental conditions like hot and humid atmosphere. Then there should be, emergency should be prepared, that is, sufficient facilities for resuscitation should be there. And there is no evidence that a genotype positive individual without a phenotype are at risk more than the general population. So to conclude, a low to moderate exercise intensity is well tolerated. It probably betters the exercise capacity and quality of life. Added risks probably pose an extra risk. Sedentary life invests extra risk factors and hence detrimental, and they must be prompted to have moderate effort. A genotype without phenotype, probably there is no associated extra risk. A heavy exercise, there is limited evidence only, but probably it is not dangerous in those who are asymptomatic or lacks added risk factors. But there needs more evidence to accept or refute. Thank you all. Thank you.
Thank you, Dr. Vinamar, for the excellent talk. Now, in Kerala, our humidity level is very high, about 95% relative humidity, and the heat is also on the higher side. Any special consideration when you talk to the patients in our state?
Cannot follow you clearly, sir.
Can you hear me now?
No, yes, sir.
Our humidity level in Kerala, the
yes,
relative
sir.
humidity is
Yes, sir, yes.
95%. And temperature is also about 37 degree, 38. Now, any special advice when you advise exercise
So
to the patient in our
sir,
state?
it is recommended that if the environmental conditions are poor, heavy exertion is better avoided. So it's always better that, but I think those who are symptomatic, they must be forbidden from taking part in vigorous exercise. But those who are asymptomatic may probably be, after discussing with them all the pros and cons. But one thing is there's a prophylactic ICD implantation just for the sake of exercise is not recommended at all. Sir.
Will a routine exercise testing for evaluation help? Because then you will be able to, monitor the patient. You will get an idea about what is happening. So at least this much of exercise can be advised.
So
because
thing
the
is,
other, that algorithm and all that,
yes, sir.
I know a lot of things are there, but in real world,
So even now I think
none of us really
most
take
of,
it very seriously.
See, almost everything still lies in a gray zone, sir. Because most of this is they can have these arrhythmic deaths. I don't know whether a routine TMD program will select out those who are at high risk. I don't know, sir. So I think it is extremely unlikely.
One comment. I just want to know the type of exercise. You have isotonic exercise as well as isometric exercise, like weight training and all that. Which one of them is more likely to cause problems in hypertrophic cardiomyopathy? Just for my knowledge, I just wanted to know.
So again,
any idea?
A clear-cut distinction between isometric and isotonic exercise, nobody has made out, sir. We can have only assumptions, I think, sir.
Maybe
We will
more.
go to the. Thank you, Dr. Vinay Kumar.
Thank you, sir.
Excellent talk.
Thank you, sir. Thank you, sir.
Next talk is on arrhythmogenic mitral valve collapse, how to identify. Because MVP is so common, we should be able to identify the real dangerous arrhythmogenic substrate. Dr. Praveen.
Chairpersons, teachers, and my dear friends. Traditionally, MVP was considered to be a benign condition, and I'm going to throw into limelight certain features that make it a really malignant one. So going on to the topic, this will be my brief outline of the topic, a brief introduction, pathophysiological mechanisms, the ECG features, echo and cardiac MRIs, which suggestive of a malignant course, the risk stratification, and finally, few words to conclude. So as you know, MVP accounts for 1 to 3% of the total population. So Indian population with a 1.4 billion, 1% comes to 10 million. In 10 million population, having a condition which was supposed to be benign and now said to be malignant, there is going to be a huge controversy. So as traditionally, MVP is superior displacement of more than 2 millimeters above the annular plane of the mitral valve in the long axis view in systole. And it's characterized by fibromyxomatous degeneration. And the presentation can vary from MR, LV dysfunction, infective endocarditis, thromboembolism, arrhythmias, and sudden cardiac death. So this was a study which was conducted in San Francisco, a postmortem study of sudden cardiac death patients. I had a patient number of around 300 patients adjudicated with postmortem, and they found that around seven patients, that is 4%, had sudden arrhythmic deaths, and out of which 2% of the presumed sudden cardiac deaths were due to MVP. And interestingly, 6 patients were found, 7% had a diagnosis by echo. After the patients were having death, their echoes were reviewed, and then they found that these patients had MVP, and that too it was monoleaflet. Whereas in other patients, they had distinctive post-mortem findings suggestive of MVP in the post-mortem itself. So we have a subset which is really dangerous. So what is the traditional pathophysiological mechanisms? That is the marked proliferation of the spongiosa layer, where we have the proteoglycans and the glycosaminoglycans. This causes the interruption of the fibrosa and then develop fibrotic changes on the mitral valve leaflets. These forms the scars, and these scars are formed to trigger arrhythmias. And there is of course thinning and elongation of the caudate tendineae because of the elongation, and there is ventricular friction lesions again accounting for scars. Another interesting thing to be noted is that we have seen that anxious females having MVP. So there is definitely a level of catecholamines in me. There are studies way back in 1992 have showed that MVP patients have increased sympathetic activity, they have decreased vagal activity and elevated catecholamine levels. So these set of patients have increased risk during the perioperative or post-operative period when the catecholamine levels are very high. So we should know, when you link MVP with sudden cardiac death, you have a substrate, that is the myocardial scar due to the ventricular friction forces. You have a trigger due to the automacity and triggered a re-entry due to the scar. And then there are transient modulators which come into action like hypertrophic state, hemodynamic events and electrolyte imbalances. So these three comes together in a patient, they have a high chance of going in for a malignant course. So what are the ECG subsets where you can recognize that the patient has a malignant potential? That is, young women have chance to develop more of a malignant ventricular arrhythmias and sudden cardiac death. ECG features will have T-wave inversions, ST segment depressions and biphasic T-waves on the inferior leads, but this can be seen in all patients. So we cannot classify this as high risk. One thing that we noted is the PVCs. If it is multifocal PVCs, mainly arising the papillary muscles, studies have shown that in around 25 patients were taken up for EP study and ablation of the MVP patients. They had 27% PVCs, and out of which around 17 came from the posterior papillary muscle and around 10 from the papillary muscles. So they have shown that PVCs of multifocal origin have a high malignant course. And then again, PVCs can be from the fascicular system or the outflow tract. Now coming on to echo. Echo, a new term has come, is that a mitral annular disjunction. This is not new to the MVP alone. It can be dissociated from the MVP also. Studies have shown that around 20% of the MVP patients can have mitral annular disjunction, which has got a negative prognostic factor MVP. Now what is mitral annular disjunction is that you see that the roots of the annulus are separated from the ventricular myocardium. The arrow clearly shows that they are separated out, and some studies have shown that as the distance increases, there is a high chance of patients having malignant arrhythmias. So what is that is the detachment of the roots of the annulus from the ventricular myocardium. The most common affected valve is the posterior leaflet, that is the P1 and P2 before that, and anterior is because it is more supported by the trigone, so anterior is less affected. So you go by the 2D echo, frame by frame analysis, you will have this mitral annular disjunction. Then the 3D echo can show a paradoxical expansion and flattening of the involved disjunction, the annulus, and it can be found in patients without MVP also. And in a Norwegian study which enrolled around 116 patients, 34% presented with severe VT. Another exciting sign is the Pickel-Haube sign, which was found in patients with mitral annular disjunction, where you have a spiked pattern in the lateral annulus. A high velocity of more than 16 centimeters is again said to be associated with high risk. That is the tugging of the postropedial papillary muscle in the mid-systole by the myxomatous valve. So is severe MR an independent predictor of sudden cardiac death? No. It can be that studies have shown that most cases had bileaflet involvement and non-severe MR. So 83% had non-severe MR had sudden cardiac death. So MR severity per se won't have an increased risk for sudden cardiac death. Cardiac MRA will show the fibrotic scars. It could be mid-wall, patchy or subendocardial. And CMR has shown that as the the mitral regurgitant fraction increases, the scar density also, the scar percentage also goes. And classically, the infralateral wall is involved in MVP patients rather than the androbasal wall, which is seen in non-MVP patients. So the risk stratification, the AHA and ESC guidelines have no specific recommendations for MVP risk stratification because the current evidence doesn't show that the current evidence is not sufficient to risk stratify patients, but we have certain predictors which show that they are high risk. That is the complex ventricular ectopy, echo features of leaflet redundancy or mitral annular disjunction, repolarization abnormalities on the ECGs, and the multifocal VPCs, younger women with MVP, and then bileaflet mitral valve replacement and leaflet thickening. So to summarize, MVP, though it's considered as a benign condition, there is a recognizable subset that is associated with ventricular arrhythmias and sudden cardiac death. ECG features I have already mentioned. Echo can show mitral annular disjunction, and CMR can predict the scar regions. So patients with high-risk features should be referred for further evaluation but risk stratification, but this is currently challenging. But certain features like the ECG, then the Holter and the echo should be done in all patients, and if possible, certain subset of patients should have a cardiac MRI. And if still there is a risk is high, you have a high scar VT, and then multiple ectopics, you can even go for ablation or EP studies. But currently it's not recommended. Thank you.
Thank you, Dr. Praveen. Excellent talk. I think you have stressed the importance of that MAD, mitral annular disjunction, which I think we should look for and try to quantify.
So I think now when you see a mitral MVP patient, a young female coming, you should not pass off it just give a beta blocker. At least do a echo and then a Holter if needed, if she is complaining of palpitations. And if warranted, you can ask for a MRI also.
Any comments?
Very common combination.
See, but in our day-to-day practice, hypertrophic cardiomyopathy patients during our follow-up, we frequently encounter people developing sudden cardiac death and all that. But mitral valve prolapse, huge number are under our follow-up. But we don't encounter SCD that often.
Yes.
It is uncommon, but it's important to identify that small group who are at risk.
Thank you, Dr. Praveen, for the
Thank
excellent talk.
Thank you, sir.
Thank you. Next topic is transcoronary radiofrequency ablation by Dr. Rajeshekar Verma. This is a novel technique. It is useful in certain patients with hypertrophic cardiomyopathy in whom the gradients were high, they were not willing for surgical myomectomy or not willing for alcohol or not suitable for alcohol septal myocardial ablation. So, the topic, sir.
Thank you, sir. Good morning, everyone. Thanks to Dr. Jayagopal, sir, for giving me this opportunity. So basically, we look at transcoronary radiofrequency ablation as a process by which there is destruction or damage to tissue using radiofrequency current from a radio RF generator. And the approach is a transcoronary approach via the coronary arteries accessed by femoral, radial, brachial, or other routes. So as you all know, radiofrequency ablation has been used successfully in the ablation of pathway-mediated arrhythmias, atrial flutter, ventricular arrhythmias, etc. And you also have in hypertrophic obstructive cardiomyopathy, TASH, that is transcutaneous alcohol ablation of the septal hypertrophy, which has been done with pure ethanol. Utility has also been shown for endocardial ablation of the septal tissue in HOCM that is been called as IRASH. And due to the some features or some drawbacks of these procedures, animal studies have shown the feasibility of application of radiofrequency energy via the transcoronary route. So, as such, today the postulated indications are ablation of septal arteries in HOCM, occlusion of coronary fistulae, and treatment of certain ventricular arrhythmias which are refractory to endocardial or epicardial radiofrequency ablation. TASH, as you all know, may not be suitable in at least 5 to 15% of patients because of septal anatomy does not permit, or there are septal communications to veins or vessels, or they communicate with chambers. The volume of ethanol that is used previously used to be 3 to 4 ml, but now it's been reduced to 1 to 2 ml because you have the recognition of the fact that You don't need to reduce the septal tissue. You only need to promote the, you need to reduce the contractility of the septal muscle. And a small amount of alcohol is enough to achieve that. And the most prominent thing here is the risk of leak of alcohol, which can result in a large infarct, can result in a lot of arrhythmias and an increased incidence of pacemaker implantations. So ERASH, that is endocardial ablation, was again tried as an alternative. There's a need for precise ablation at the exact site where the anterior mitral leaflet comes in contact with the septal tissue. The transmural scar has been shown by contrast MR with such endocardial ablation without even septal reduction. That is enough to get good relief of gradients. But the amount of gradient reduction is usually a little lesser than what is achieved with TASH. And in the early part of the learning curve at least, you have more complications including tamponade and need for pacemaker implantation and complete heart block, needing pacemaker implantation. Unless this ERASH has been guided by electrophysiological mapping. So that necessitates a much greater learning curve for this procedure. So there was animal studies conducted on how RF energy can be given by a transcoronary route. So 13 healthy dogs anesthetized underwent angiogram via femoral route, 26 branches, 2 branches in each dog, 1 to 2 millimeter diameter of LAD and L6 were selectively wired with wire in a microcatheter or over the wire balloon. 10 to 20 millimeters, the wire was projecting beyond the microcatheter tip. The microcatheter acted as an insulator. Application of the radio frequency current was given by an adapter, which was a homemade adapter by the researchers, and they also occluded the blood flow with the balloon. So in this 20 to 30 watts of energy, radio frequency energy, every 15 to 30 seconds for 2 or 3 times were given. A slight resistance in the movement of the wire indicated a successful ablation. The wire tip, when it's brought back, showed coagulum tip on removal. On the diagram, you can see on the left-hand side, this is the normal wire. In the middle is the wire which has the coagulum formation because of the application of the radio frequency current and destruction of tissue. And with very high radio frequency currents used, on the extreme right, you have excess of coagulum formation. And the repeat angiogram showed, after 2 weeks, showed no recanalization and the whole vessel was completely occluded. So this is the picture which was shown. Here you can see the branch that is here in the middle, next to the catheter. The wire was put in that and radio frequency ablation was given through the transcoronary route. And after that, this vessel was completely occluded. The pathology of this specimen showed on the left-hand side, initially normal vessels, normal myocardium. Then you have thrombus formation in the coronary vessels and followed by vacuolation of the myocardial cells and further progressively the complete destruction of the vascular tissue followed by coagulative necrosis of the myocardium. So the study concluded that a safe and effective novel method to close small arteries with coagulative necrosis due to selective radiofrequency current application, and they postulated that there's a potential use in closure of coronary fistulae, PDA, HOCM, selected ventricular tachyarrhythmias, and probably some peripheral vessels. So this is the setup this is a video which was taken from our cath lab at Aster Medcity. So we show the radiofrequency ablator connected via the usual radiofrequency ablation catheter. The catheter tip is connected with crocodile clips to the end of a coronary wire. The coronary wire goes in a microcatheter and the microcatheter keeps it insulated. And to show the effect of ablation, we have dipped the microcatheter. The wire tip is placed in a bar of soap. The soap has got fatty acids, as you all know, which gets ablated. And this is ablation going on. You can see the fumes coming because of the ablation that is given at the tip of the coronary wire with the help of radiofrequency generator. So the first in-man case report was published very recently, 2023, in JACC Cardiovascular Interventions from a Chinese group. Qian et al. Showed the procedure in an 85-year-old lady with symptomatic hypertrophic cardiomyopathy who was unwilling for surgery, who had an LVOT gradient of 119 millimeters of mercury. The intrahiatal septal thickness was 19 millimeters. So this is the angiogram which showed a very prominent first septal artery and with multiple branches and 2 or 3 other branches after that. So selective cannulation with a microcatheter that showed an injection which showed that there's a communication from the septal arteries to coronary vein, so which precluded the use of alcohol. So they went ahead with RF ablation, 30 watts, impedance control mode 3 times, gradient dropped to 14 millimeter of mercury post-procedure. No symptoms at 1 month follow-up, no increase in gradients. And this is the post-angiogram follow-up showing that the vessel has been completely, the distal branch has been completely occluded. Another case report again in the same journal, the same volume. 20-year-old gentleman who presented with external angina, ECG showed T inversions, echo showed abnormal flow in the PA. This is the echo image showing the PA, coronary and the CT cardiac angiogram showed the abnormal vessels from both LAD and RCA. So this is the angiogram showing the abnormal branch from the RCA, supplying, entering into the pulmonary artery. And one more from the LAD. The pre-EFR, FFR was found to be 0.84, 0.86. This was the ablation procedure that was done in the RCA with successful results. Again for the LAD, again with successful results. The post-FFR improved to 0.94 in both vessels. In 3 months follow-up, both were found to be normal. CT angio showed complete closure of the AV fistula, no flow into the PA. VT also can be ablated in a similar manner. Only thing is that we don't have a case report as of now. This shows the effect of alcohol ablation in a coronary artery, and which shows that the arrhythmia has been successfully ablated with the use of alcohol in the coronary artery. It's postulated that instead of alcohol, we can use radiofrequency current for the same. In conclusion, transcoronary RFA is an exciting new modality to safely close small size vessels. Setup is easy in the cath lab with existing hardware. Careful attention to settings of RFA is needed, and larger case series studies and trials are needed before it is put to routine use. Thank you very much for your patient listening.
Thank you, Dr. Rajasekhar, for the excellent lucid talk. And any comments from the advantage is that the existing hardware can be used for the same purpose. The complications of alcohol septal ablation is not there. Any advantage over alcohol septal ablation?
Yes, the alcohol, once it's injected, you have no control over where the alcohol will go through coronaries, through capillaries. The amount of infarct cannot be appropriately assessed beforehand. And with the radiofrequency current application, you can be very, very precise and very, very selective in the vessel, that the amount of tissue that is ablated. So it can be very useful in the ablation of small size vessels, not just in septal arteries for HOCM, but in many other situations.
In PDA closure, is it effective PDA?
Yep, PDA closure has been postulated by the authors of the animal study. Probably it's not a transcoronary procedure anyway, and PDA being of that size, probably we can directly use the RF ablation catheter itself.
Any questions from the audience? Thank you for the excellent talk.
Thank you.
Well, thank you, Dr. Rajasekhar Verma. Next, we will go to a routine LA strain study needed in heart failure with preserved ejection fraction. Comparatively, a new modality which is fast catching up. And to speak on that, we have Dr. Meera from KIMS Health Trivandrum. Dr. Meera, please.
Good morning, respected chairpersons, teachers, colleagues, and my dear friends. First of all, let me thank CSI Kerala chapter for giving me an opportunity to talk on this relatively new topic. Slides are not moving. Excuse me. Slide moving.
Can you speak a little more close to the mic?
So, in this 8 minutes, I would like to discuss about, am I audible, sir? Am I audible now, sir? Am I audible now, sir?
Yes.
So in this 8 minutes, I will be discussing about the current diagnostic criteria for heart failure with preserved ejection fraction, whether we need any additional criteria or the current criteria, is it enough? Why do we need an additional criteria? Introduction to left atrial strain imaging, how to do LA strain imaging, the current evidence for using LA strain, the comparison between LA strain and other parameters, and a conclusion. So we know that in the diagnostic criteria, we know that for heart failure with preserved ejection fraction, you should have the signs and symptoms of heart failure with a normal or preserved ejection fraction and an LV diastolic dysfunction which has to be proven objectively. And the crux of the diagnosis is elevated filling pressures. So for diagnosing HFpEF, we need to have elevated filling pressures at rest or during exercise. So that is what we are trying to look at by using this LA strain pattern. So we know the criteria, major as well as minor criteria. If you look at the major criteria for heart failure with preserved ejection fraction, it is all septal E prime less than 7, lateral E prime less than 10, E by E prime more than 25, and TR velocity more than 2.8. You can see that all these criteria are basically Doppler Blaise criteria. All these criteria, and this is again TR velocity has got a lot of limitations. And then coming to the minor criteria, we have again borderline E by E prime 9 to 14. And global longitudinal strain of the LV has found a place here. Global ejection longitudinal strain less than 16% is included in the minor criteria. If you have 2 points, you can 2 points for each major criteria. And if the total number of points is more than 5, we can diagnose HFpEF. But if the points is between 2 to 4, that if you are in a borderline zone, we need additional criteria like hemodynamic, invasive hemodynamic measurements or diastolic stress test. So we are trying to see whether a new criteria like LA strain can help in such borderline situations. So now the limitations of the current diagnostic criteria, as I mentioned, they are all Doppler-based indices. They are angle dependent. They have tethering effects. They are mostly volume dependent. And the phasic atrial function cannot be assessed with the Doppler-based criteria. And we know the pro-BNP cutoffs are variable under various situations. Patients who are obese, patients who have renal failure, etc. We cannot rely on the pro-BNP for diagnosis of HFpEF. The current morphological criteria, the limitations are LA volume corresponds to the chronic LA pressure overload. This is basically based on the chronic LA. So we have nothing to suggest the acute pressure overload of the left atrium. Somebody help me with this. And when you index the LA volume to the body surface area, it is falsely low in obese patients because if the body surface area is more, LA volume index becomes less. So again, that has got a limitation. If index LA volume is in obese patients, it's falsely low. TR velocities we know that is associated with, in other conditions like pathologies of the lung, TR velocities may be elevated. Next slide. And the most important thing is response to heart failure therapy cannot be assessed with the current diagnostic criteria. Next slide. Now we move on to the left atrial strain. We know that strain evaluates a myocardial deformation. And strain rate examines the rate of change in the strain. Now we have in LA, next slide, we have 3 types of strain in LA. That is reservoir, 3 phases of LA contraction. One is a reservoir phase, second is a conduit phase, and the third is a contractile phase. Look at the ECG. At the peak of the QRS, we have the LA, ventricular systole begins and LA goes into diastole. The first part of the diastole, the LA is in the reservoir phase, where the maximum LA filling happens and the peak atrial longitudinal strain. This is a PALS. PALS, or the peak atrial longitudinal strain, is the criteria by which you can diagnose a LA reservoir strain. And then in the conduit phase, you have the early diastolic strain. And the last part after the atrial systole, we have the peak atrial contractile strain. That is a place where that is dependent on, that is less volume dependent. But most of the studies are done on the reservoir strain and not on the contractile strain. Next slide. Now this is how it is measured. Apical 2-chamber view, where you actually measure where you delineate the endocardial border. And this is a peak atrial longitudinal strain, and this is a peak atrial contractile strain. This is at the end of ventricular systole, during the ventricular systole, and this is the last part of ventricular diastole, that is during atrial systole. Next slide. Again, this is in apical 2-chamber and 4-chamber view. Next slide. Next slide. Yeah, we have a couple of demonstrative cases here. We have just started using this LA strain in our lab, and we're just standardizing the value. This is a patient, it's a normal patient actually. We have tried to analyze the left atrial strain, and this is a peak atrial longitudinal strain which happens during ventricular systole or the atrial diastole. And here the value is 37. The peak atrial longitudinal strain is 37, which is quite good. And the peak atrial contractile strain is the one which happens during atrial systole. That is the last part of ventricular diastole. Next slide. This is yet another patient in 4-chamber view. We have diagnosed a peak atrial longitudinal strain and peak atrial contractile strain. Next slide. Now, why do we look at left atrial strain? This is not influenced by the transducer position. This is independent of the tethering effects. It is less load dependent, and the phasic atrial contraction, that is reservoir, conduit, and contractile functions can be easily assessed by this strain analysis. Next slide. Now, what does the evidence say? Lot of evidence from 2015 we have seen. It is found to correlate with the diastolic dysfunction. It is found to correlate with the elevated pulmonary capillary wedge pressures, etc. Next slide. Here again, in patients to diagnose, differentiate between HFpEF and diastolic dysfunction, this has been found to be useful. Next slide. Now, this is the latest trial which says that there seems to be a strong association between reduction in LV filling pressure and improvement in LA function. One more minute. As indicated by the improvement in LA strain. So, here the point which I would like to stress is that whenever there is a response to treatment, we have to assess the response to treatment. LA strain is a better index than any of the current indices for assessment of improvement in the pulmonary capillary wedge pressure. Next slide. This is a trial which has come in the recent European Society journal. Next slide. The aim of the study was to include LA strain, whether LA strain should be included in the current diagnostic algorithm. Next slide. So here all patients with ejection fraction more than 50%, that is diastolic heart failure patients were analyzed, and those with elevated filling pressures, whether only 2 of the 3 criteria were positive. They were divided into 3 groups. Either they had to substitute TR velocity with LA strain, or substitute any missing additional criteria with LA strain, or add LA strain to the current additional diagnostic criteria. Next slide. And they found that when you substitute any missing additional criteria with LA strain, there was very high feasibility and with reasonably good specificity and sensitivity for detecting elevated filling pressure. Next slide. So 98% feasibility with a reasonably good sensitivity and specificity. Next slide. This led to the conclusion that LA strain improves the feasibility and overall accuracy of the current algorithm to discern LV filling pressures in patients with preserved LV function. Next slide. So there was an editorial statement also. Next slide. Next slide. So that recommended that multimodality imaging is required in HFpEF, and reservoir strain has been found to be better in giving conclusive in diagnosing HFpEF when there is inconclusive results. Next slide. So in summary, next slide. If LA volume and LA volume index are analogous to HbA1c. Suppose in diabetic management, if you take LA volume and LA volume index analogous to HbA1c, it gives an average of blood glucose level over 3 months. LA strain is analogous to GRBS. That is, you can get minute to minute improvement in LV function and pulmonary capillary wedge pressure. So LA strain is a very important diagnostic tool and in assessing the improvement to treatment and reduction in pulmonary capillary wedge pressure. So it can be routinely used in assessing HFpEF, provided we have the software and the feasibility to do it. Thank you.
Thank you, Dr. Meera, for this new concept which is catching up. What I understand, the mean value is something like minus 35. Am I right?
18 is taken as positive 18 because peak or atrial longitudinal strain is positive because it is taken in the reservoir phase. Okay. That means the atrium will be dilated and the strain will be positive. Okay. 18 is a cutoff. Okay. The ROC for this trial was taken and from many values, 18 was considered to be the significant association with elevated pulmonary capillary wedge.
Okay. And I think if it gets refined, probably this may replace the current
Doppler-based
TR jet 2.8 meter per second.
Yes.
Maybe change to this LA strain. Okay, thank you. Any comment? Dr. Nini?
See, many times when we use that H2PF score, we get a value of 6. We get a value of 6. So I think this will help.
Final comment, Dr.
This was
Sivaprasad?
in the
And is it applicable in AF patients?
So in this
And
trial-
one more, does it recommend that if you do ablation in that patient, it's going to be sustained?
Sir, this first question, sir, in this particular trial, they have excluded all the patients with AF. Because to strain analysis, it's difficult to do strain in AF patients. So AF, I think it's difficult. And response to ablation and response to therapy has been predicted with strain.
Thank you, Dr. Meera, for your very nice talk. Thank you.
Thank you, Dr. Meera. Now I invite Dr. Ramdas Nayak for tricuspid interventions ready for prime time.
Audible? Okay. Respected Chair and dear friends, thank you, Jai Gopal, for giving me this opportunity. It's an era of structural intervention, and we are all with TAVIs and mitral valve interventions, pulmonary valve interventions. Around 2,000 plus intervention was performed last year alone with TAVI, with 350 centers in India and roughly 35 in Kerala. But nothing much is heard on tricuspid valve. So are we ready for it? That's the whole idea of having this talk. Traditionally, tricuspid has always been kept aside. It has never been given the importance, whether it is surgical intervention too. As the surgical intervention has highest mortality, either when it is done alone or is it along with the left-sided valve surgery. The real reason why tricuspid valve is not being taken early into the intervention or surgery is the silent nature in which it presents, the elderly population, and the complexity of the anatomy of the tricuspid valve. So most often, this is tricuspid regurgitation is functional, and very hardly you see an organic tricuspid regurgitation. And we all know, as I alluded, that the mortality is very high if left untreated. And the prompt clinical identification is the most challenging, since most often this is silent. And the right-sided symptoms usually presents delayed because of its nature itself. It can be due to fatigue because of reduced cardiac output, or because of systemic congestion. You can have hepatomegaly, gut congestion, ascites, or peripheral edema. As already alluded, the clinical mortality is around 25% in 1 year, and optimization of most of the treatment in medical therapy is just by giving diuretic, and how much ever you do, it doesn't last long. And none of the therapies should be unnecessarily delayed surgical consideration of a suitable patient. Since the surgical mortality is very high, there is a lot of development to look into tricuspid valve intervention. With growing experience of transcatheter therapy in structural heart disease, many dedicated transcatheter tricuspid valve repair or replacement devices which mimic well-established surgical techniques are currently under development. As I discussed already, that there are anatomical challenges. It's a large annulus and a small RV and a humongous RA are the difficulty in the anatomical thing in challenges in considering a tricuspid valve surgery or tricuspid valve transcatheter intervention. So what are the interventional therapies available? It can be categorized into cooptation devices, annuloplasty devices, or bicaval devices, or tricuspid valve replacement. The TriClip is just similar to that of mitral clip. It's a mitral clip itself, which has implanted into the tricuspid valve. Around 75 patients have been performed on this on a study basis, TriIlluminate study, with success of 97% at 1 grade at least reduction in 91 patients. Similar study is on the process of 115 patients. The results will be out soon with first one month follow-up showing definite reduction in TR gradient. The former repair is again from Edward Life Science. It's a self-expanding foam-filled balloon that reduces the leaflet cooptation gap, thereby occupying the regurgitant orifice area. The device is delivered via a left subclavian approach with a rail anchored at the RV apex with almost 90% success with no hospital mortality and clinical benefit up to 1 year. It comes in 12, 15 and 18 sizes, and the problem with device in long run was the anchoring device had fractures and had caused perforation of the RV. So there is a difference. The newer devices are coming with the new anchoring technique, and we'll have to see how that flares as compared to the older device. The Pascal system is a mixture of the previous two devices. That is a former device and the mitral clip. But this particular thing has been only performed in a couple of patients in mitral valve, not on the tricuspid. They have been analyzing on the tricuspid. So it is still under process of into the market. The annuloplasty devices, again, it can be divided into suture annuloplasty and ring annuloplasty. This is a tri-align wherein the goal of the procedure is to make bicuspid excision of the tricuspid valve by placing two pledgets sequentially at the posteroseptal and the anteroposterior commissures, thereby making it bicuspid valve. So this is how the anatomical diagram looks like, and this is how the 3D picture after completing the procedure. You can see the pledgets at this particular point. A Trinch coil system is a corkscrew anchor implanted transfemorally in the anteroposterior commissure of the tricuspid annulus, and it's connected to the self-expanding stent which is placed in the inferior vena cava through a Dacron band. The tension applied by the tricuspid annulus translates into downsizing of the septolateral tricuspid annulus diameter. Successful implantation is happened in 75%, and the significant reduction of TR is in around 94%. Again, the downside of it is there are multiple corkscrew anchor failure, and now it has been replaced with nitinol coils. We have to look into how that comes out in the trials which are going to come up with. The two trials are the SCOUT and SCOUT 2. The SCOUT 2 is under process with 60 patients. The PASTA is again in a preclinical stage. It's a pledget-assisted suture tricuspid annuloplasty. It is done again by transapical or transjugular approach. The sutures are placed in the septal and the anterior tricuspid annulus. Cardioband is available. It's a CE mark brand again from Edward Life Science. It's a transfemoral route, similar to the surgical DeVega procedure. Adjustable ring that is implanted directly on the atrial side of the tricuspid annulus, which can be fastened by multiple repositionable anchors. Iris annuloplasty from Boston Scientific. It is in a trial mode. It is not even human trial. It's still in the preclinical mode. It's a semi-rigid adjustable ring placed in the position. Triapta is a transatrial intrapericardial tricuspid annuloplasty, wherein a nitinol loop is placed via the right atrial appendage into the annulus externally and tightened to see how much, depending on the TE, how low the tricuspid regurgitation goes in. This is one which is having a lot of trials, and which is more easily to be implanted, is a CAVI, wherein it reduces the systemic congestion by implanting balloon expandable or self-expanding valves in the SVC or the IVC, thereby abolishing the caval backflow. Two types of transcatheter heart valves are available. One is the balloon expandable by Sapien, and trick valve, which is self-expanding by Releases. Tricuspid valve replacement has been implanted first in 2017, the gate valve. The gate system is a transcatheter sutureless self-expanding valve stent dedicated to the native tricuspid valve replacement. The device consists of cone-shaped nitinol stent, 3 pericardial leaflets and anchoring winglets. The device is delivered through transjugular or transatrial mini thoracotomy approach. However, only 30 patients have been tried in, and the trial is ongoing. My experience with trick valve, we had 3 patients altogether. This is my longest follow-up patient of 36 months. This patient presented to us to the ER with frank failure with anasarca and scrotal edema of almost the size of a football with progressive dyspnea. We diagnosed him to have severe tricuspid regurgitation with mild RV dysfunction, chronic atrial fibrillation. He had stage 3 chronic kidney disease, child A liver disease. He had chronic anemia because of blood loss as well as chronic disease. And he was intolerant to diuretic because of hyponatremia and oral anticoagulation because he had recurrent hemoptysis. So this is how his echo shows. You can see that humongous RA, almost mild RV dysfunction. This is after improvisation of his oral medical therapy. The TAPSE was around 14, and there was no much of regurgitation gradient. You can see the IVC is hugely dilated with non-collapsing. The plan was discussed with heart team and they accepted with high risk. Hematology consultation, pulmonology consultation, all was done. This patient had then subsequently presented with massive hematemesis. Hemoglobin was 5.4, variceal ligation was done, and surgical intervention was ruled out. Hence, we decided to go with bicaval valve implantation. So the right heart pressures were taken. It was PA pressures are only 50. The contraindication if it is more than 60. So this is a RV angiogram which shows adequate RV function. The cardiac MRI shows the humongous RA with a small RV with adequate RV function. So these are the contraindications if TAPSE is less than 13, pulmonary arterial hypertension more than 65, untreated left-sided heart disease, recent CVA or ACS, bleeding diathesis or child C liver disease. This is how the IVC and the SSV valve are. The SSV valve has a long skirt to prevent PVL, and there is a belly to prevent downward dislodgement of the valve into the RA. The IVC valve is like a funnel with a short skirt to prevent PVL as well as not to obstruct the hepatic veins. These challenges in this case was AF needing long-term oral anticoagulation. He had bleeding diathesis, hemoptysis, hematemesis, chronic anemia, cirrhosis with esophageal varices which we had already ligated, hyponatremia, and choice of oral anticoagulation after post-implant because he could not take vitamin K antagonist, and vitamin K antagonist is very important for the next 3 months immediately after implant. The day of procedure, he probed bilateral femoral venous access, ACTB to kept maintained more than 250. This is the most important step to deploy the SVC valve. The placement of the pigtail or the wire as a marker to know where the RPA crosses the SVC. Subsequently, an angiogram, SVC angiogram. The third one is to place a thermo wire into the RA to look at the roof. Then to deploy the valve, and then subsequently having a check angio through the cubital vein or the brachial vein to see whether the skirt reaches the innominate, because in the future risk of if the patient requires an implant like device like pacemaker, if the skirt is at the innominate, you will not be able to pass a lead into it. Subsequently, the deployed, it's a self-expanding device, and this is how the SVC device looks. The IVC is deployed again by placing this is the most riskiest part because it can dislodge very easily. It's a short valve. So under TE guidance, it has to be placed. You can see the marker here. Okay, I'm sorry, I'll just go through 2 minutes. Marker here at the level, it has to be kept at the diaphragm level. That is a marker where exactly it has to go. And you can see the TE wherein you can see both the valves working well. You may think that the valve is slightly in the IVC, but that's a normal position. So post-implant, we had to resort to giving him enoxaparin for 6 months and subsequently rivaroxaban for first 3 months, followed by 15 milligram. Patient doing well with doing all his normal activities, no admissions, cardiac-related issues, hemoglobin stable, no hyponatremia, and adequate biventricular function. This is echocardiography after the implant, 34 months after immediate and the post-implant, which shows excellent RV function as well as LV function. To conclude, tricuspid valve disease, in particular, tricuspid regurgitation is highly prevalent condition with complex pathophysiology with long-term adverse consequences. Although historically neglected, tricuspid valve disease has gained increasing recognition in the past decade. Surgical treatment remains a standard of care but continues to have the highest mortality. Large number of patients still do not receive effective therapy. Several alternative, less invasive technologies for treating patients with severe native tricuspid valve disease at high surgical risk has been developed in the past decade with promising results. Thank you. Sorry for taking more time. I had no choice.
Thank you for the excellent talk. Since the prime time is over, I think we'll go to next time. Next topic.
Thank you, Naik, for the excellent talk.
Thank you to the chairpersons. We move on quickly to the next session.
Thank you, thank you.
May I please invite the next group of chairpersons. Session 3 now. Dr. Ashokan, Dr. Jairam, Dr. Rainatullah Misriya, and Dr. Venugopal, please, to chair the next session. For the kind attention of the delegates, we'll have no coffee or tea break. It's being served at the venue. Please help yourselves. We do not have a tea or coffee break. We move on to the session 3, stage complete revascularization in PAMI. Over to our chairpersons. May I request the speakers to kindly stick to time, please? We have overshot by 15 minutes, I think. Thank you.
I think we'll go to the session straight away. I think when all of you, when you do the primary angioplasty, the first thing that you look at, whether the patient has got a single vessel disease or a multi-vessel disease. And the question comes as to what you're going to do. Should we intervene in the non-culprit vessel or not? This has been an internal debate for a long, long time. And for this, we have a debate. We have two heavyweights in the field of cardiology. Dr. Karuna Das, who is going to talk on complete revascularization, and Dr. Sajan Narayan will be talking about stage procedures. So without wasting time, as we are behind schedule, let's go to Dr. Karuna Das, who will be talking to us about revascularization during the initial presentation of PAMI. Dr. Karuna Das, please.
Thank you, sir. Respected chairpersons, senior members of the faculty, and dear friends, this is the topic for debate. You require a staged or a complete revascularization during PAMI. What do you mean by PAMI? What is primary angioplasty in myocardial infarction? What is the time frame? If you look at the 2017 ESC guidelines, it is to be done within 12 hours for all patients. After 12 hours, if the patient is having angina, hemodynamic instability, or life-threatening arrhythmias, and as a class 2A indication, it has been extended to 48 hours. You may do it up to 48 hours. So that is primary angioplasty. So actually the debate is, do PTCA to the non-culprit lesion at the primary angioplasty itself, that is take care of all the lesions, or do PTCA to a non-culprit lesions at a later stage, either pre-discharge or post-discharge. Acute MI patients, almost 50% have multivessel disease. In 2010, it was shown by Cindy Grimes that multiple complex coronary plaques are associated with a bad outcome at 1 year. Recurrent ACS, repeat angioplasty, non-infarct artery angioplasty, and CABG. Despite that, if you look at the ACC-AHA guidelines of 2013, you clearly see what is shown in red. PCI of a non-infarct artery at the time of primary PCI in patients without hemodynamic compromise is a harm. It's harmful. While cardiogenic shock, irrespective of the time delay from MI onset, is a green class 1 indication. I want to emphasize this because the circle has now changed totally. So this was what they said. But soon after the publication of this guideline, randomized trials started coming. And the first one was the PRAMI trial, where complete revascularization was done during the index event, and they called it a preventive PCI. The primary outcome of death, non-fatal MI, refractory angina was significantly better if you could take care of all the lesions. But PRAMI met with a lot of criticism. Taken individually, death or non-fatal MI was not significant, and it was the refractory angina that contributed to this. Well, we can expect that patients will have angina if they have other lesions. And that too, this is a very subjective entity. They took up all lesions which were more than 50%. So many cases, probably it was not actually indicated. They did not touch upon CTOs, cardiogenic shock, LAD, LCX, osteal stenosis. So there was a lot of selection bias there. And this study was prematurely terminated, noting the benefit, so that it was not adequately powered. After this came the CVL PRIT trial. I don't know how to pronounce it, whether you should call it culprit trial, because another culprit trial is coming. Here, complete revascularization was performed at the time of primary PCI or before hospital discharge, 60% to 40% like that. Again, CTOs, shock, CABG were excluded. The primary outcome was mortality, MI, heart failure, and repeat revascularization, which was better in the complete revascularization group. Main difference being in repeat revascularization. A long-term follow-up of this study is also available. At 5 years, the complete revascularization group fared better. But they did not analyze whether that group which underwent complete revascularization at the time of index event or later benefited. The third one is the Dynami Prameluti trial. Again, complete revascularization was done under FFR guidance versus infarct-related artery alone. Here it was 2 days after the primary PCI that FFR and next revascularization was done. Better in the complete revascularization group. The fourth, at this stage, the ACC changed their recommendation. They promoted the non-culprit PCI from a class 3 to class 2B. It may be considered in selected patients who are hemodynamically stable, either at the time of primary PCI itself or as a planned procedure. 2017, again, fractional flow reserve guided multivessel angioplasty, the COMPARE acute trial was published. They showed that complete revascularization was better than culprit vessel angioplasty alone and can be done either during the index procedure or later. So when you come to the next guidelines of ESC, you find that non-IRA strategy has again been promoted. Routine revascularization of non-IRA lesions should be considered in STEMI patients with multivessel disease before hospital discharge, not at the time of the primary PCI. And non-IRA PCI should be considered in cardiogenic shock. That's also a class 2 indication. Just like the American guidelines, soon after the publication of this ESC came the culprit shock trial, which was totally against this. A staged revascularization of non-culprit lesion versus immediate multivessel PCI. Because we all think that in shock, if you can open up as much vessels as possible, it's better. They found that it is not so. Staged revascularization is better. 30-day risk of composite of death or severe renal failure leading to renal replacement therapy was less with staged revascularization. Then came the biggest trial of all this. All the previous trials, the numbers were around 600, 400. The complete trial, which randomized 4,000 patients, more than 70% stenosis in the non-culprit artery or 50 to 69% stenosis with FFR positive. They randomized them to PCI. 1 to 3 days was the median time when hospital multivessel PCI was performed, and 23 days when they were called back and done. So there were different groups in that. Routine non-culprit lesion PCI with a goal of complete revascularization performed either during the hospitalization or at discharge was superior to culprit lesion alone. So let us come to the latest guidelines from ACC/AHA SCI 2021. They say that in selected hemodynamically stable patients with STEMI and multivessel disease, after primary PCI, staged PCI, again staged PCI, not at the time of the first one, is a class 1A indication. PCI for non-infarculated artery stenosis along with the primary PCI may be considered a class 2B indication in a stable patient with a low complexity lesion, and it should not be considered in a shock state. So the guidelines have totally reversed, and they have proposed an algorithm. If the patient is cardiogenic shock, don't do non-culprit vessel PCI. Otherwise, if the patient is low risk, low complex lesion, as a class 2B indication, you may take up non-culprit arteries. Who is this low risk patient? Normal blood pressure and heart rate, LVEDP less than 20, no chronic renal insufficiency or acute kidney injury. Expected contrast volume, this is very, very important, less than 3 into the calculated glomerular filtration rate. Simple lesion anatomy. So in such cases, so you have to be very selective and take up if needed. Otherwise, if the lesions are complex, you should have a heart team discussion and consider CABG or even guideline mediated medical therapy. So what I understood after going through all these guidelines as well as the studies is very simple. Complete revascularization is better than culprit vessel alone. You have to revascularize the other lesions. But when? It should be done in a staged manner, maybe within the hospital admission or calling back after the hospital admission, but not along with the index procedure. Well, any story has two sides, so I have stated mine and I am waiting to hear the other side of the story.
Thank you, Dr. Karnadas. Please join us here. And now we invite Dr. Sajan Narayanan. And I don't think we'll have any gross difference of opinion. Both are going to talk about complete revascularization. And the only difference is whether to do it immediately at the time of index procedure or late. This is a main point of debate today.
Good morning to respected chairpersons, moderators and colleagues. The next 10 minutes I will try to enlist evidence why I believe that complete immediate revascularization should be offered to patients with distillation MI who have a multivessel disease and who are undergoing primary angioplasty. And this claim is subject to certain conditions. So this guidelines already discussed. This is ESCTS guidelines 2018, gives a class 2A level of evidence A recommendations for a strategy of routine revascularization before hospital discharge. And the references which have encouraged the guideline committee to provide such a recommendation is given there. This is ACC/AHA guidelines which was published last year, gives two recommendations. A higher level of recommendation of 1 for a strategy of staged PCI and a lower recommendation of 2B for a strategy of immediate PCI. And the references are given there. Only difference is that the complete trial, which was not published at the time of ESC guidelines, has been included and has encouraged the ACC guideline committee to provide a higher recommendation. Let us dive through some of these references and try to fish out what is the hidden truth. This is the first major study that has looked into the outcomes according to revascularization strategies in patients with distillation MI and multivessel disease. This is a single center experience from Italy, and it is very clear that culprit-only revascularization is inferior to complete revascularization. And in complete revascularization, whether it is staged or immediate complete, there was no much difference. But if you see the endpoint of freedom from redo PCI, the complete revascularization was better than stage 1, although it didn't reach statistical significance. And most importantly, about 11% of the patients who were randomized to stage revascularization arm needed unplanned revascularization during the waiting period. And that was mean period of 42 days. Means that whatever benefit of revascularizing the non-culprit lesions is obtained in the early peri-infarct period. This is the first randomized trial, primary trial, already discussed. All the patients randomized to complete revascularization have to undergo as an immediate procedure. And at the end of 23 months, the endpoints were firmly in favor of the combined endpoints. And refractory angina in this patient, in this group, the previous speaker has raised certain issues with that, but we should remember that the refractory angina needed to be documented with an objective evidence of inducible ischemia to be qualified as refractory, and it was adjudicated. Second trial is the culprit trial, same randomization protocol, and the operators had an option of performing it as an immediate or staged, but we should remember 64% of the patients underwent immediate revascularization. At the end of 1 year, complete revascularization was better than IRA only PCR. And in the culprit trial, there was a CMR sub-study which was performed before hospital discharge and at the end of 9 months. And if you see the CMR variables between the patients who are randomized to complete revascularization according to timing of the PCR, the total infarct size and total acute infarcts were lower in patients who are randomized to immediate complete revascularization. And not only that, the IRA infarct size was also lower in patients who underwent immediate PCR. And at the end of 9 months, if you see the infarct size that is lower down, the infarct size was lower in patients who underwent immediate PCR, meaning that whatever benefit of sealing the additional vulnerable plaques, you get it in the immediate period. And not only that, you improve the blood flow to watershed zones of the infarct lateral artery and reduce the total infarct size as well. Compare acute, tested that strategy of FFR-guided PCI. 83% of the patients underwent during index procedure. And at the end of 1 year, complete revascularization was better than IRA-only PCI. And this is the largest study that has looked into the topic. But we should remember that in complete trial, as per protocol, there was no option of performing immediate PCI. All the patients who are randomized to complete revascularization had to undergo as a stage procedure. And out of that, 60% of them underwent procedure during the index hospitalization and about 40% after the discharge at a mean period of 23 days. But even in this study, if you stratify according to the timing of the non-culprit lesion PCR, if you look at the endpoint of ischemia-driven revascularization, unstable angina, the benefit was more if you revascularize during hospitalization, meaning that it also echoes the point that earlier is better. Now, whatever studies that has been performed till date, that is 3 out of 5 studies, that is primary trial, culprit, and compare acute. All the procedures were done in complete revascularization as an immediate one. 2 trials, that is Dynamic 3, pre-multi, and complete trial, there was no option of performing an immediate PCR. Even in this trial, it is seen that if you perform a complete revascularization as early as possible, there is a benefit with regard to reduction in the further ischemic endpoints. Now, further trials have only tested the various strategies. This is FLOWER-MI that has looked into FFR-guided PCI versus angio-guided PCI. 95% were staged. There was no difference. Even in FRAME-MI trial, which was actually published early this year, FFR-guided PCI versus angiographic-guided PCI, 60% during the index procedure. And at the end of 3.5 years, FFR-guided PCI was better than angiographic-guided PCI. And one study that was published early last month, this actually pertains to our debate this morning. This is immediate versus stage complete revascularization ACS. 40% of them estimation MI, non-culprit lesion more than 2.5 millimeter, positive FFR, randomized to immediate versus stage PCI were performed either during index hospitalization or less than 6 weeks. Mean time was 15 days. And this trial was designed as a non-inferiority design, and the strategy of immediate complete revascularization met the criteria for non-inferiority. And most importantly, if you look at the landmark analysis at 30 days, all the endpoints were in favor of immediate complete revascularization. That is, individual components of endpoints, any myocardial infarction, unplanned ischemia-driven revascularization, any revascularizations were all significantly lower if you completely revascularize during the index procedure as compared to stage 1. And this also reflects the findings from the earlier studies that whatever benefit of sealing the additional vulnerable plaques is obtained in the early peri-infarct period. This summarizes the sum total of strategies that has been used. It is very clear that complete revascularization is better than culprit-only PCI. Among the strategies of complete revascularization, debate is going on whether it's FFR-guided or angiographic-guided. And if you are following an angiographic-guided complete revascularization, now the evidence is emerging that immediate may be better than stage. Now, how the immediate complete revascularization improves outcomes? It treats lesions which could potentially turn acute in the near future, seals additional vulnerable plaques, improves blood flow to watershed zones, prevents early adverse remodeling. Now, we should remember the profile of patients represented in these clinical trials. As already mentioned, very low-risk patients, low risk of comorbidities. Philip class 2 and class 4 were minuscule. Triple vessel disease was to the tune of 25 to 30% of the total population. And these lesions were primarily exclusions and not represented and average syntax score in complete was only 16, and syntax score in frame was 17. The CTOs affecting non-IRAs, left main as a non-IRA lesion. Complex anatomies, graft lesions were almost exclusion in all the trials. So let me conclude my argument, respected judges, that I believe that if the person comes with an ST elevation MI who belongs to the left half of your figure, low syntax score, Phillips class less than 2, normal systolic BP, the evidence is compelling that a complete revascularization is better than staged and immediate is better than staged. And if you have a patient who is on the right extreme, now you have evidence that immediate is actually worse. And if you have a patient who comes in the middle part of the figure, then it is left to hard time decision. I'll be happy to answer any rebuttals. Thank you.
You have, Dr. Karunadas, you have 2 minutes for. See, we need to address a question here very, very clearly. Immediate revascularization, the same sitting, you are going to do revascularization non-culprit vessels also. And stage means you are going to do it subsequently. Sarjan has been arguing for same sitting all vessels. That is Sarjan's argument. Karunadas is talking for staged.
Stage.
Yeah. Now the rebuttal from Dr. Karunadas.
Well, after hearing the other side of the story, this is what I have to say. Regarding the BioVasc trial, the latest one, which has clearly shown that immediate revascularization, immediate complete revascularization is better, it was a mixture of STEMI and NSTEMI. NSTEMI, very often we do have problems in identifying the culprit vessel. That is one criticism regarding that study. These are two old papers. There is an exaggeration of non-culprit stenosis severity during acute myocardial infarction. This study actually compared the angiograms at the time of MI and later, and they found that whatever lesions people thought were 50%, 70% were not actually 50, 70, it was less than that. There was a significant exaggeration of non-culprit lesion. So you are going to revascularize unnecessarily. Second thing, this is again an old study. An angioscopic follow-up was done in acute MI patients. They found that multiple plaques have ruptured, but very often they tend to seal off slowly. So probably there also intervention is not required. So my point of argument is that PCI of a non-culprit lesion as part of the index procedure makes your procedure time longer. You are going to use more contrast. Unnecessarily, you may be treating lesions which are amenable to medical therapy. You are working in a very hostile environment, prothrombotic milieu. You don't know. The second stent you place, it goes into problems. The whole thing is lost. And the renal status is often unknown as the patient is rushed from the casualty to our cath lab. So, at present, I still believe that in STEMI, you go for a complete revascularization, agreed, but in a staged manner, not at the time of the index procedure. Thank you.
Sarjan.
Just a couple of rebuttals. That the criticism that the non-culprit lesions are overestimated during acute procedure. If you see the study that is from, these studies are conducted in late 90s and early 2000s where they have systematically analyzed the angiograms between index procedure and as a variable period between 70 to 80 days after the procedure, which is not the standard practice now. ACCHA guidelines recommend that you should revascularize within 45 days. ESC guidelines recommend that you should revascularize before hospital discharge. So that doesn't mirror our practice now. You see the complete trial. All the patients were staged patients. The reason for non-culprit lesion being not significant is only 33 patients. If you see the BioVasc trial, if you see the patients who are randomized to stage revascularization, only one patient had for reason for deferral, one patient had not significant, that's only one patient. These are high volume centers, experienced operators. I feel, and also if you see the myth that the non-culprit lesions are exaggerated during ST lesion applies only to lesions in the range of 20 to 30%. The severe lesions doesn't undergo significant changes. And one more slide, if you see the data from Prospect 2, if you will be surprised to know that those lesions which turned acute on follow-up, the average diameter stenosis was only 45%. It was not much different from the lesions which did not have event. And 1/4 of the patients had a high plaque burden. And about 38% had an MLA of less than 4 millimeters square. And the other criticism that it can lead to high volume, you can see these are the data from the randomized trial. There was no much difference regarding the renal insufficiency. BioVas trial, latest trial, there was no difference in renal insufficiency. Mean volume of contrast in compare acute was only 24. So if you properly select the patients according to the guidelines, I feel that you don't have much risk of causing much damage to when you are performing additional PCI to non-corporate lesions. That's my argument.
Thank you. Both of you have done extremely well. You have presented your viewpoints extremely well. But can I have questions from the comments from the audience? 2 comments.
So that BioVask, I think, was that last study you showed. Actually, you circled the other events, but you didn't circle the mortality. The mortality was 0.8% in the immediate and some 0.6 or 0.4% in the delayed.
Madam, actually...
But it was not statistically significant, but the number was more. That means, like, suppose you're in an ICU, out of 100 patients, 3 extra patients died in the complete. But I don't know. I mean, I'm not commenting, but my personal experiences, staged is always better because I had 2 or 3 patients where we tried to do the non-culprit after a few days. And at that time, the patient became unstable, like had left main spasm. So we had to back out from revascularizing. Another patient I had no money to do the other vessel. But they're both still alive. But 2 cases doesn't make a story.
No, one practical point that we don't see, we all face this problem. And very often, economic factors also come into play, which we never say. When you do this thing, you're already primed for a primary angioplasty. You find multiple lesions requiring stents. At that point of time, very often we tend to stage a procedure purely because of buying time, because of economic reasons also. I think in our setup, when we take a decision, it should be patient-based decision rather than, this is my personal viewpoint, it should be a patient-based decision rather than purely scientific decision in this thing. I agree that both have presented their viewpoints very, very well. To me, personally, in our setup, probably a stage procedure would be my way of thinking. Nini, we don't have time.
See, in all these trials, they have not specified LAD versus non-LAD lesions. See, if the non-culprit lesion is an LAD lesion, immediate revascularization will help.
Actually, one Chinese trial, just an anecdote, one Chinese trial, they said that they will do only stage procedure because if they do angioplasty in the same sitting, the cardiologist will lose money. Therefore, they get... No, actually that study just quoted it. The cardiologists are more in favor of doing stage procedures purely because 2 procedures means they would get more income. So they are more in favor of that. Anyway, thank you so much for an excellent discussion.
Both the speakers done a wonderful job in the sense that all the points have been covered. Now, we all know that this procedure is patient-oriented. Should be patient. Patient prefers all the lesion which is significant to be done at the same sitting. The question is, there's guidelines says that is a class 1 indication now to tackle non-complex lesion at the same sitting. There's no difference. We have the studies, we've shown that complete revascularization is mandatory. The question is, which lesion, how you are going to select, whether it use IFR, FFR or CMR, when to do it. This is a controversy. Second one is, the question is whether to do the complex lesion at the first sitting. And the patient-oriented, you have to see the patient's overall, the renal function and other aspects. So my question is to Dr. Sajan Narayanan at this stage, if you have a complex lesion and with culprit, do you tackle immediately after the culprit lesions?
No,
this is the one thing we would like to know from you.
No, actually, I have already presented that. Say, for example, if you see the syntax score has been reported, anatomical syntax score has been reported only for 2 trials. That is for complete and frame IMI. All the other studies, we don't have syntax score reported. And if the average syntax score was only tune of 16 to 17, that means very low risk patients were included in that study. And post CABG patients were exclusion criteria for almost all the patients. And CTOs of non-IRAs like bifurcations, all these cases were excluded. So if this argument applies only to very low risk patients who come with less than class 2, the CLIP class 2, and who can be revascularized with additional 50 to 60 ml of contrast.
So the same thing, if you see a non-complex lesion after culprit, do you agree with that way to tackle that simple lesions?
The guidelines are very clear. If the lesion is simple and all the criteria are fulfilled, you may go ahead. So it's an operator and patient preference.
Final.
The strategy of revascularization depends on the hemodynamic status and symptom status. Symptom status, ischemia status either by symptoms or by FFR or other nuclear studies.
Thank you so much.
Thank you. Thank you to the chairpersons and the presenters of this session. Move on quickly to the next session, session 4, case-based discussion, a case of recurrent PE. May I invite the chairpersons, Dr. Anil Kumar, Dr. Marcos, Dr. Rajesh Kumar, and Dr. Rajiv, please. Move on to the next session, Dr. Anil Kumar, Dr. Marcos, Dr. Rajesh Kumar, and Dr. Rajiv, please. Quickly invite Dr. Hari Prasad. Hand over the proceedings to our esteemed chairpersons. Once again, may I remind the chairpersons and the speakers, we are late by 10 minutes, so we request the speakers to kindly stick to the stipulated time. Thank you.
Yes, we'll go for the first.
Good morning, respected seniors and my dear friends. This is a case-based scenario of a 48-year-old female admitted with history of worsening breathlessness. On admission, she was sick and tachypneic with a BP of 90 by 70 millimeters of mercury and heart rate of 100 per minute. ECG was showing sinus tachy with S1 Q3 T3. So initial investigations, blood investigations were within normal limits except for hypokalemia of potassium 3.1 and raised SGOT SGPT levels. The troponins were within normal limits, but marked elevation of NT-proBNP and D-dimer was seen, along with a raised CRP of 19. The initial echo shows marked dilation of the RA and RV chambers and the thrombus in the RA dangling into the RV across the tricuspid valve with moderate tricuspid regurgitation. The septum is displaced towards the LV, forming a D-shaped left ventricle, and you can see the clear thrombus in the RA moving across the tricuspid valve into the RV. So this patient diagnosis was confirmed by CT pulmonary angio, which showed acute pulmonary thromboembolism, and the venous Doppler of both lower limb showed DVT. She was immediately lysed with tenecteplase, after which she showed a dramatic improvement, followed which she was continued on low molecular weight heparin and discharged with rivaroxaban 15 mg twice for 3 weeks, followed by 20 mg OD and torsemide and sildenafil. Echo, which showed after a few days later on follow-up, showed a dramatic improvement in the RV diameter, which came down to 1.8 centimeters and decreased PA pressures. Echo after 1 week showed these kind of parameters, which showed improved RA and RV function and decreased size of right-sided chambers and no thrombus seen in the right atrium, which was seen earlier. So she was continued on Novak, but in due course she developed breathlessness and anemia, where HB was seen at 6.5 grams, which was improved with 2 points of PRBC transfusion. Echo at this point of time showed PA pressures of 40 plus. So she was followed up a year later with worsening of breathlessness. Echo at this point of time showed worsening of RV chambers and with RV dilatation and increased PA pressures. ECG at that time showed
S1Q3T3 with sinus tachycardia, ST depressions in inferior leads, RBS more than 1 in V1 and deep S in V5, V6. Echoes this time showed again worsening of right-sided chambers with gross dilatation of RA, RV and RV dysfunction. The IVC is dilated with non-compressive and there is a moderate to severe tricuspid regurgitation. The septum is again displaced towards the LV, forming a D-shaped left ventricle. These are the parameters. So she developed this breathlessness despite on Novak and sildenafil. This time she presented with a BP of 100/70 and pulse of 90 per minute. And echo RV diameter worsened to 4.2 centimeters, which was previously 1.8, and PA pressure grossly elevated to 70 plus. So CT pulmonary angio suggested chronic thromboembolic pulmonary embolism. This is the echo follow-up after 6 months, which showed dilated RA, RV and no much improvement in PA pressures. The next will be discussed. Thank you.
Dr. Hari Prasad has very beautifully described a case of recurrent pulmonary thromboembolism. As you know, recurrent pulmonary thromboembolism is a very difficult situation to manage. Now, how this particular case will be managed, that will be explained by Dr. Jimmy George. Over to Dr. Jimmy for the treatment modality.
Yeah, thank you, sir. So, after the case history, which is a long 2 years one, I'll just summarize the scenario. This is a female patient in her late 40s diagnosed with pulmonary arterial hypertension. The cause, rightly pointed out as an acute pulmonary thromboembolism, lysed with tenecteplase and later NOAC was continued. She was followed up but developed some anemia, and a year later she had a worsening pulmonary artery hypertension. And this time CT was showing again thromboembolism, but this is a chronic thromboembolic pulmonary artery hypertension at that scenario of second year follow-up. So at this situation, what are the management options available now? As you know that whenever the pulmonary artery pressure exceeds 20 millimeters in right heart catheterization, called pulmonary hypertension, it's basically the resistance to the blood flow as well as the vasculopathy also adds to it because of the increased hypertrophy of the medial layers as well as the thickening of adventitia and fibrosis along with this thrombus causing a chronic scenario. So anything more than 3 months of acute pulmonary embolism, there are high chances of progressing into a chronic thromboembolic episodes. There is both pulmonary vasculopathy as well as the hyperplasia, proliferation, and the plexiform lesions causing a right heart dysfunction. So if you see the classification, this comes under the fourth stage, that is the CTPH with PA obstruction in the first one. And if you see that there are not much treatment options available in majority, though only around less than 5% of patients only have CTPH, the options are still scarce and surgical options is always available for the right time. So it's a fatal long-term complications of acute pulmonary embolism, and 50% of patients will have history of acute pulmonary embolism. So early detection of CTPH is very important because now few available options over pulmonary endarterectomy is also available out. If you see for the incidence of CTPH in few trials in the last 2 decades, it's roughly something between 1% to 8%. So roughly 3 to 4% patients have an incidence of CTPH following a pulmonary embolism. And there are certain predisposition factors, especially the thrombophilic disorders and APLAS, thyroid disorders, malignancies and myeloproliferative disorders, infected IV lines, pacemakers or shunts, as well as chronic diseases like inflammatory bowel disease and osteomyelitis. With a history of splenectomy, all these predoses the formation of a chronic thromboembolic pulmonary hypertension. The diagnosis still echo-wise need to be followed up, the tricuspid regurgitation velocity, as well as other signs of pulmonary hypertension, echo-wise, and follow with a CT imaging, adds on to patients with high risk of forming chronic pulmonary embolism. This is basically the algorithm for early detection. So if you have an unprovoked pulmonary embolism with an RV dysfunction or those requiring a lysis or an embolectomy, the scoring system increases up. A delay in diagnosis as well as comorbidities also makes the patient at high risk of chronic thromboembolism, and that needs to be checked out as a patient admits with acute pulmonary embolism. Now, majority of these patients with acute pulmonary embolism are resolved both anatomically as well as hemodynamically. But when you have this associated risk factors, there could be a high chance of 3 to 4% of patients progressing into chronic thromboembolic pulmonary hypertension. The main principles of treatment is pulmonary endarterectomy. Balloon pulmonary angioplasty is another option. And the pharmacotherapy treatments also has a role when there is persistent pulmonary hypertension after the first two treatment. So when you have a proximal pulmonary artery fibrotic disease, pulmonary endarterectomy is the treatment of choice. The easy accessibility of this area to the surgical side, as well as the removal of maximum obstruction, is feasible. But the centers are limited in our country. At least 50 procedures annually is required in the Western literature to be a center for pulmonary endarterectomy. When you have more distal progression, then balloon pulmonary angioplasty is another option where you can do balloon dilatation and open the obstruction, as well as thrombus aspiration also could be done at the same time, stenting also in very discrete tight stenosis. But when you have a microvasculopathy, there would be only medical therapy which would be available and which could be possible even after pulmonary endarterectomy and balloon pulmonary angioplasty. So especially pulmonary endarterectomy is for those with class 3-4 with a more than 300 dyne resistance. Surgical removal, but is associated with its comorbidities. They got to this video just showing the removal of the endarterectomy, where they can completely remove, especially from the proximal part of the pulmonary vessels, and the resistance as well as the obstruction could be almost completely taken care of. And the chance of progression of microvasculopathy also could be reduced to an extent. So this is showing the removal of the different classifications on the surgical side. I'll just rush on to the pulmonary angioplasty procedure, which is another good alternative and is no longer considered experimental because of its evolving, as well as the right patient selection is the most important part. This is one of our cases where we are doing a balloon pulmonary angioplasty. This is with the help of interventional radiologist also. So there's a balloon dilatation done, and this was the constricted right pulmonary artery, which was after multiple dilatation opened up. So complications are still there with balloon angioplasty with vascular injury, wire perforations, as well as contrast-induced issues and lung injury. Angiojet in acute situation or acute on chronic situation is also another thing where you can maximum aspirate with saline and as well as aspirate the maximum thrombus. There's one of the cases with the large right lung completely occluded. Even after lysis, this patient had come with repeated large thrombus, which was aspirated by angiojet. And that was the final result on table. And after 2 weeks, it was almost 50 to 60% resolution. So coming to the medical management, Reosigat is an only drug which is now approved out. And basically, it's a soluble guanylyl cyclase stimulator. It has got both nitric oxide synthesized independent of it, as well as it accentuates the action of nitric oxide pathway, the prostaglandin pathway too. The CHEST trial was something which had shown almost of 16 weeks with 261 patients, there was an increase in the 6 minutes walk of almost 45 meters considered with the placebo. These are the different actions of what drugs are available, the prostanoids, as well as the endothelin receptor antagonist, as well as the soluble guanylyl cyclase, which along with the nitric oxide or without nitric oxide facilitates further progression or anti-proliferative and anti-fibrotic actions. MERIT trial was something where macitentan was used in a 10 mg, And here also you can see that the results showed there was a reduction in the pulmonary vascular resistance as well as the 6 minutes walk time, similar to what was seen in the earlier CHEST-1 study. Sildenafil, though an age-old drug, it was considered, but not much, a small trial only, not much difference was seen. But when it was titrated along with riociguat, the effect was seen early. Last but not the least is the selexipag, the prostaglandin oral inhibitors. So this was done in a Japanese study where they had seen that almost the improvement in the pulmonary vascular resistance as well as the hemodynamic parameters and the exercise capacity were increased when patients were given selexipag daily. On concluding in this case with a lady with recurrent pulmonary embolism, CTPH as such has a poor prognosis if left untreated. Pulmonary endarterectomy is the treatment of choice. But when you have certain situations where surgery is not accessible or surgeon is not available for surgery, then interventional procedures like BPA as well as stenting could be another option too. Very few drugs are there. Riociguat is a promising drug, and it's only one approved for the persistent group for pulmonary hypertension. Thank you.
Problem we face is the chronic thromboembolism anticoagulation HB4. This is the most difficult condition we have to treat. HB4, chronic thromboembolism anticoagulation.
Yeah, anticoagulation should be continued, sir, but only thing is, along with anticoagulation, the microvasculopathy, how much should be prevented up? That is the important part.
Just a word of caution, such patients when they come to us, they would be on a lot of PH medication. So riociguat and sildenafil or tadalafil are the same group and they should never be combined because the patient will have hypertension which you will not be able to correct. So since they are from the same group, ideally riociguat is the first choice, and if you want to replace it with tadalafil or sildenafil, you should stop riociguat. But riociguat, as you said, is the first choice. Then you can go for endothelin receptor antagonist. The other drugs are all prostacyclin group of drugs, either the parenteral one or the oral one, which is selexipag. Yeah. This question is to Hari. What was the precipitating factor for the index episode of pulmonary embolism? Any idea what was the in this patient?
I think the workup was negative. I think the DVT was negative. Nothing much was
even
obtained.
protein C, protein S was it looked into?
Yeah, it was not our case. Anyway, I think that was worked up. I think it was.
Dr. Jimmy has beautifully explained the treatment strategy for this patient. Suppose there may be some clinical situation in which massive pulmonary embolism patient will come. We will lyse the patient, and some patients may develop on the third or fourth day again massive pulmonary embolism. What should be the strategy in that type of patient?
Recurrent episodes of pulmonary embolism progressing up. Actually, I think along with anticoagulation, the pulmonary hypertension medications should be started early, and if not, you may need to add a dual therapy of pulmonary hypertension also as a combination, either because trials have shown sequential pulmonary antihypertension medications as well as starting it together also. The benefits were not much difference. But at the same time, I think a CT follow-up also need to be seen to see any major thrombus forming, which could be either surgically removed or interventionally removed out along with the medications.
Thank you, Jimmy, for the excellent presentation. We'll now go on to the next topic, pulmonary artery denervation by Dr. Sunil. I invite Dr. Sunil.
Good afternoon. As the earlier speaker had spoken that PH is always a very difficult entity to treat. This is an emerging and a new concept, pulmonary artery denervation. Next couple of minutes I'll be speaking on pulmonary artery denervation. PH, primary pulmonary hypertension was described first in 1951. And the treatment modality for primary PH were not adequate. They used to try digoxin, calcium channel blockers, anticoagulation. None of them were proven effective. Until 1987, first prostaglandin was discovered for use of thing, and it got ratification in 1995 by FDA. Since the 2000, every year, nearly every year, new drugs have been approved for the treatment of pulmonary hypertension. This says that this PH, we have not yet conquered this specialty of this pulmonary arterial hypertension. Now the concept of denervation. See, we have a lot of medicines against pulmonary vasoactive molecules like prostaglandin, thromboxane, everything. These act on the either endothelial cells or the smooth muscle cells. Now another option to reduce a vasoconstrictive effect is by sympathetic nerve ablation. So if you ablate the sympathetic system, it has shown to reduce the pulmonary arterial hypertension. The reason is that people with PAH have elevated heightened sympathetic nerve system. And not only that, normal person, there is actually 30 to 40% norepinephrine level is degraded by, catabolized or degraded by the lung tissue. This is absent in people with PAH. Now, if, like corrective causes, when there are corrective causes of PH, like VSD PH, once you do the corrective surgery, VSD closure is done. There is a return of the normal catabolism of norepinephrine in the lung tissue. So this postulate was the reason why they tried sympathetic blockade for pulmonary arterial hypertension. Now, initially, animal studies were tried. Animal studies, canine studies from 1918, we have animal studies. Initially, PH was induced by balloon dilatation. Later, medications, like now currently, usually thromboxane is used to induce pulmonary arterial hypertension. Techniques for PH techniques for ablation, nerve ablation were surgical, chemical or radiofrequency. Now, the anatomy of pulmonary artery. The main pulmonary baroreceptors are present at the junction of pulmonary arteries, bifurcation at the bifurcation. And predominantly, the fibers, it reaches from the coronary, the deep and the superficial coronary plexus, and the fibers flow through the left pulmonary artery. So the left pulmonary trunk is supposed to have the more innervation, autonomic nerve system. 70% of the nerve, 71% of the thing, it is sympathetic and 29% is parasympathetic. And what is especially interesting for the interventionist is that around 40% of these sympathetic and parasympathetic fibers are found at the depth of 0.4 mm. So this is amenable for endovascular therapies. So this is the reason why endovascular therapy has been attempted in many of the people. How to do it is usually through a 6 French catheter. Right heart cath is done usually using a pigtail. We take a RV pressure and PA pressures, and then PA angiogram is done. PA angiogram is done to know the level of bifurcation of pulmonary arteries. So the bifurcation point, because the ablation is done usually in the first, ablation is done in the first 1 to 2 millimeters of the bifurcation, here and here, ablation. So pulmonary angiogram is the most important. Once pulmonary angiogram is done, the pigtail is exchanged with the right heart catheter. And then ablation, usually the trials have shown 3 catheters, different catheters have used. One is circular decapolar, then simplicity catheter, which is used in renal denervation, and a new system, TIVUS system. This is a ultrasound based, it is not a thing. This is developed by Israel. It's an ultrasound based radiofrequency ablation catheter. Usually the energy selected is 15 watts, temperature range of around 45 to 50 Celsius, and it's given over 120 seconds. 50% of people will complain of chest pain, which usually requires moderate sedation. In the whole case series, only 1% required general anesthesia. No major complication has been reported as of now, and patient requires an ACT of around 250 and requires aspirin for first 3 months after post-procedure. Data till now, what is the proof of the pudding? So data till first case report of 2014, we have around 12 reports of pulmonary arterial denervation. 490 subjects have been, humans have undergone this procedure. 6 case series, 3 randomized trials, and 3. The first-in-man trial was published in 2014 by Chen et al. They subjected 21 patients with PAH. This PAH was varying. It was not only primary pulmonary hypertension. all the classes of PH. 13 patients underwent pulmonary arterial denervation. And the point to be done is that it is done, the PA ablation is done within 2 millimeters of the orifice of the left and LPA and RPA. And another thing which is, this is the first, Prophy is the first randomized, it's a multicentric trial which showed that ablation has shown 20% reduction in PVR at 4 to 6 months follow-up. Usually, most of the trials usually give more ablation in the left pulmonary artery. The reason is because they have more sympathetic nerves are more prominent in the left side system. Except this trial, which they gave only 2 ablations in the left side, stating that the recurrent laryngeal nerve, sorry, I just finished one side. Recurrent laryngeal nerve is, among all the case reports, this is all the published data of pulmonary arterial denervation. I'll come to this Romanov et al. 25 cases of, this 25 subjects were exclusively chronic thromboembolic PH. And they found that there is around 100 to 150 dyne per centimeter square fall in PVRI, 60 meters increase in the 6-minute walk test, and pH, mean pulmonary arterial pressure, fell by around 10 mmHg. So in context to the current scenario, pulmonary arterial denervation is also an option. And last year, when meta-analysis was also published, they showed that there is improvement in 6-minute walk test, reduced mean pulmonary arterial pressure, improved cardiac output, but there's no significant patient mortality, no benefit in patient admission and patient mortality. Take-home message, pulmonary arterial denervation is in the primitive stage of development. There's limited data, and there is no standard procedures. Some people have used left pulmonary artery, given more ablation in the left pulmonary artery. Some studies have shown more ablation in the right. So it requires standardization. Thank you.
Thank you, Dr. Sunil. May I now invite Dr. George Kosi to deliver his lecture on sotatercept. Is it a game changer?
Good afternoon. The name of this drug is sotatercept. Is it a game changer in chronic thromboembolic pulmonary hypertension? Sotatercept. The management, long-term oral anticoagulation anyway is required. The mechanical obstructions have to be relieved. The proximal PA fibrotic obstruction, PEA, distal PA fibrotic obstruction, BPA, and microvasculopathy, we require medical treatment. And when you look at the pharmacological treatment, basically 3 pathways are targeted: the prostacyclin, the endothelin, and the nitric oxide, but still the 5-year mortality is around 60%. And microvasculopathy, riociguat, we have strong data. Phase 3 RCT, inoperable cases, and after PEA, 16 weeks follow-up. Improved 6-minute walk distance and 31% reduction in PVR. Treprostinil, again we have data, improved 6-minute walk distance. Macitentan, people have tried up to 75 milligram, fall in PVR and 6-minute walk distance. Combination of sildenafil with ERA can also be tried. Selexipag also some little data. But what about the new drug? Reverse remodeling is very important in the pulmonary vasculature. Vascular remodeling caused by hyperproliferation of the endothelial and smooth muscle cells lining the vessel. This is due to disbalance of the anti-proliferative and pro-proliferative signaling mediators. And basically these are activins and related proteins and ligands. And sotatercept is a fusion protein that contains the Fc domain of the human IgG1, which is supposed to bind to human activin type 2 receptors. I also do not understand this completely. This acts as a ligand trap that binds to activins and other ligands, restoring the balance. So please understand that this is a novel pathway, an activin signaling inhibitor. I think that will be enough so that the balance will be tilted appropriately. And is there any clinical evidence for this drug? Initially came in 2021 NEJM Pulsar trial, 106 patients, 3 groups, SOTA 0.3, SOTA 0.7 and placebo, subcutaneous once in 3 weeks. That is how it is given. 24 weeks follow-up. So small study, but they did demonstrate a fall in PVR by 2 Wood units with SOTA 0.3, 3 Wood unit with SOTA 0.7. Marginal improvement in 6-minute walk distance of 24 meters. But the benefit was less with 0.7 compared to 0.3. There was some reduction in NT-proBNP. Now we have the recent trial published 2 weeks ago, NEJM, April 20, 2023. Multi-center phase 3 trial, PH, class 2 and 3, 163 patients in the SOTA group and 160 in placebo. Subcutaneous, start with 0.3, target dose 0.7, administered once in 21 days with 24 weeks follow-up. The primary endpoint was improvement in the 6-minute walk distance. Average 40 meters, 400 became 440. Risk of death and clinical worsening reduced by 84%. Looks very impressive. 26.3 versus 5.5%. 3.8% versus 1.2% is the mortality. Now look at the fall in PVR. Reduced from 10 Wood unit to 7.5 Wood unit. So a reduction of 2.5 units. Improvement in functional class. Fall in NT-proBNP. Everything p-value is less than 0.001. What about the mean PA pressure? Mean PA pressure of 53 became 40. So average 14 millimeters of mercury. Side effect thrombocytopenia, epistaxis and bleeding, telangiectasia, increase in hemoglobin, increase in blood pressure, and 1 patient in the treatment group had sudden cardiac death. So one concern is bleeding and telangiectasia. So is it a real game changer? We are not too sure. PAH is a disease with poor outcome. Sotatercept looks promising because a new pathway is being addressed. There is an improvement in the 6-minute walk distance, functional class, reduction in clinical deterioration and death, mean PA pressure, PVR, and NT-proBNP. Acceptable side effects, but very limited data in chronic thromboembolic pulmonary hypertension. Best results likely when combined with pulmonary endarterectomy and balloon pulmonary angioplasty. But still, the reduction in PVR is from 10 Wood unit to 7.5 Wood unit. That is all. And mean PA pressure, 14 millimeters. Okay, looks promising, but may not be a game changer. Thank you very much.
Thank you, Kaushik. This drug has a multiple mechanism that increase the apoptosis, decrease the infiltration and all. Like that decreases. I also went through the net to know about it, and I was also in the same condition as Kaushik told. Very difficult to understand the mechanism. However, it is a new drug, and your opinion.
Sir, George Kokshi, sir. So you made a statement that this drug is to be used in PAH due to chronic thromboembolic pulmonary hypertension. Can't it be used in primary pulmonary hypertension? Why did you make such a categorical statement?
No, actually there is no data in chronic thromboembolic pulmonary hypertension. It is primarily useful in so-called idiopathic PAH. Primary pulmonary hypertension.
I got it. I thought I heard the other way.
No, I am telling that there is only very limited data, if at all,
Yeah,
in
because I was
chronic
wondering how you
thromboembolic
could...
pulmonary hypertension. The data is with riociguat. Riociguat also produces 30% reduction in PVR. This also produces 25% reduction. Because basically we started with 10 wood unit, and at the end of the trial, you have 7.5 wood unit. Same thing was obtained with Riociguat. So you cannot tell it is better than Riociguat, but this is addressing a different pathway. So it looks promising.
Then that mortality was seen with the higher dose, wasn't it, sir? But the 0.7, it was not with the 0.3.
See, the issue is the number of patients included in the trial is so small. In the initial trial, it is just 108 patients. And in the second group, it is 160 plus 160. So mortality reduction is not statistically significant. But the point they are highlighting, clinical deterioration, there is an 84% difference. If you take the composite of clinical deterioration and mortality, there is an 84% difference between sotatercept and placebo. Looks promising. Oh, too early to say. No, it is all on top of standard treatment. Because these people had the PEA, the BPA, and all the other treatment, including endothelin receptor antagonist and phosphodiesterase, everything was given.
I have a nurse who's in Italy. She's got idiopathic pulmonary hypertension. She was on ipoprostenol infusion. Now she's part of this trial. Her mean PA pressure dropped from 50 to 30 on the 9th injection of this.
Well, actually, in the trial, it was 14. Anyway, it looks promising because all along we had only 3 pathways. Now there is this 4th pathway. So that's a great thing.
Plus the denervation.
The innovation.
The last comes the lung transplantation.
Suppose patient is on Novax for that, and they are getting recurrent thromboembolic pulmonary embolism. Will you change to oral vitamin K antagonist? No. Recurrent thromboembolic pulmonary embolism. Recurrent thromboembolic pulmonary embolism patient on Novax. Novax is also recommended for pulmonary embolism. If they are getting recurrent pulmonary embolism, will you change to vitamin K?
No, in fact, that was one of the reasons why this topic was kept. No, all of us have seen in our clinical practice, I don't know, we were discussing, patients on Novax still get recurrent pulmonary embolism. The question is, what Anil Robbie said, will you switch over to warfarin?
I think one point is if it is an APLS syndrome, certainly warfarin has to be given. There's no controversy on that. The other situation, overall, I think vitamin K antagonists are more powerful and having a more consistent effect compared to Novak. And you can monitor the INR. You have low intensity, high intensity. You can manipulate. Whereas you don't have any such thing with a Novak. You can keep a high INR. Suppose you find an event happening with an INR of 2.5, you can hike it up to 3 or even 3.5. That flexibility is not there with a Novak. Maybe, but basically we don't know what is happening.
Yes,
that is the problem with Novak.
Yes, we had a good discussion, and our vice president is restless.
No, but you should not give anticoagulation to a bleeding patient. That's what I wanted to say. If the patient is recurrently bleeding, don't give anticoagulation in PH.
We'll wind up the session.
Thank you so much, sir.
Let's give a big hand to all the speakers for this wonderful session. Thank you.
Quickly move on to the next session, session 5, ACS
All the
management.
speakers has very well explained their
I'd like to thank
points. So we will wind up the section. Thank you.
Sorry, sir. I'd like to thank the chairpersons for this session. Quickly move on to the next session, ACS management. May I please invite the chairpersons for this session, Dr. Devarajan, Dr. Hisham Ahmed, Dr. Jayaprakash Pillai, and Dr. Koshi Ipan, please. Kindly may I remind the presenters, kindly stick to your stipulated time. We are already running 15 minutes late. May I hand over the proceedings now to our esteemed chairpersons. Thank you, sir.
Dear all,
welcome to the new session. The first one is inflammation as a target of post-ACS. We know that inflammation plays an important role both in the genesis and progression of atherosclerosis, and it is also responsible for many of the adverse events after ACS. So tackling this inflammation in the post-ACS period has become a novel approach in many of the trials. To talk about this particular topic of inflammation as a target post-ACS, may I welcome Dr. Govindanani.
Respected Chairperson, my dear friends, my topic today is inflammation as a target in post-acute coronary syndrome patients. Now we know chronic coronary syndrome is a systemic disease and hence requires systemic treatment, optimal medical therapy, and that has been shown to reduce event rate. Whereas local treatment revascularization has not helped and data shows that it does not reduce event rate. On the other hand, acute coronary syndrome is a local manifestation of a systemic disease, and hence you require systemic treatment, optimal medical therapy, and local treatment, revascularization. And this combination has saved lives, and this combination has also reduced events. So the million-dollar question will be, what, when, where, which, how, why a stable plaque gets converted to a culprit plaque. A fairly benign disease in the vast majority, chronic coronary syndrome, gets converted to a life-threatening disease, that is the acute coronary syndrome. Is it the vulnerable plaque? If you look at the PROSPECT trial, where the vulnerable plaque was defined as a baseline plaque burden of at least 70%, minimal luminal area of 4 square millimeter or less, and presence of thin cap fibroatheromas, major adverse cardiovascular events originated from lesions when all three variables were present in just 18.2%, which in turn means that 81.8% of these lesions did not lead to events. So obviously, vulnerable plaque is not the end of the story. Is it cholesterol? Well, the Fourier trial, where the LDL cholesterol was reduced to 30 milligram at 48 weeks, reduce the primary endpoint by 15%, but you can look at it in another way and say that 85% of events occurred in spite of an LDL of 35. And if you look at MACE, same thing, 20% reduction, meaning 80% occurred in spite of an LDL of 35 milligram per deciliter. Remember, at the end of 3 years, 1 in 10 patients developed an event in spite of an LDL cholesterol of 30 milligram. So that is why now we have been thinking about the residual risk. Well, there are several residual risks, but my topic today will be this, the residual inflammatory risk, which has been characterized by the eponym RIR. Let me start with measuring the residual inflammatory risk. Based on the magnitude of risk associations and availability of clinical assays, HSCRP is now considered the benchmark biomarker for inflammatory risk in ASCVD. IL-6 is good. It may be more precise, therapeutically target the pathogenic pathway, but there are problems with assays, there are problems with validations. And of course, there are a lot of other biomarkers which may provide complementary information under investigation. Now we know systemic vascular inflammation plays multiple maladaptive roles. It contributes to the pathogenesis, progression, destabilization of ASCVD, basically 3 roles. 1, it drives the atherogenic progression in the clinically stable phase of disease, which means the plaque becomes bigger when there is inflammation. 2, it converts a vulnerable plaque into a culprit plaque. It destabilizes by probably dissolving the fibrous cap. And last is probably what is more important, and which I am going to talk now. It exaggerates the inflammatory response to cardiomyocyte necrosis in MI. After MI, when the myocardium dies, an inflammatory response is initiated. And in patients who have already got a systemic vascular inflammation, this response is exaggerated. So let us come to myocardial infarction. Cardiomyocyte necrosis liberates injurious molecules which interact with pattern recognition receptors such as toll-like receptors, and together with complement activation and reactive oxygen species induce cytokine and chemokine upregulation, promoting coronary and systemic inflammatory response. So inflammation not only produces MI by acting as a trigger, it also is the result of myocardial infarction. The necrosis itself produces inflammatory response, which in turn further injures the myocardium and lead to heart failure, and the widespread inflammation throughout the coronary tree can lead to recurrent events also, increased risk of recurrent MI, overall leading to a higher post-infarction mortality. So the inflammation that is produced by myocardial infarction is also very important, and that should be the target, or should that be the target? That is the question. However, multiple trials targeting early inflammatory response has been neutral, possibly because the inter-individual variability is underappreciated, which can be driven by various environmental or genetic factors. Now, some patients already, even in the chronic stable phase, have an antecedent inflammatory milieu. And in these patients, when myocardial infarction occurs, there is a more exaggerated response to this stimuli. This is known as trained immunity or innate immune memory, which is described in other diseases also. Remember, only this myocardial infarction has inflammation, plaque fissure. There can be plaque fissure without inflammation, plaque erosion. None of these things have inflammation. So uniform treatment is not going to help. You have to select the patients who has to be treated. Let us look at this representative patient one. Here you can see the hsCRP is already elevated in the chronic stable phase. So there is already chronic vascular inflammation, and then this inflammation acts as a trigger and myocardial infarction develops. And when myocardial infarction develops, there is a strong post-MI inflammatory response. And these are the patients where probably we should target immunization to reduce post-MI heart failure and recurrent MI. So there is a risk of active LV remodeling, heart failure and MI, and finally see that there is persistent inflammation and residual risk, which means these patients are going to develop further events later also. Compared to, this is usually plaque fissure. Compared to this representative patient 2, where you can see the hsCRP is low. There is no active inflammation at all in the baseline state. The trigger is not inflammation for the MI, and hence obviously when the patient develops MI, the post-inflammatory response is mild, and at the end of the day, you can see that the inflammation is suppressed by routine medical therapy, no need of any anti-inflammatory treatment at all. So that is usually erosion, spasm, and supply-demand imbalance. So in acute coronary syndrome, hsCRP measured on presentation tells you that the trigger for ACS has been inflammation. And it provides prognostic information on the risk of recurrent inflammation-related atherothrombosis. But if you measure hsCRP, the magnitude of persistence of hsCRP after a myocardial infarction, which is probably the response to the dead myocardium, the necrotic myocardium, that will identify inflammation-related risk of post-MI heart failure, recurrent MI, or mortality. So both are different. Inflammation can precipitate MI, and the inflammation due to the necrosis can be a prognostic marker for heart failure as well as recurrent MI. Well, right now we have only this pathway which is being studied, the interleukin 1 beta converted to interleukin 1/6 and hsCRP, all CANTOS, colchicine, etc., etc. But of course, the future is bright. Several molecules are being tried. So to conclude, ladies and gentlemen, and Mr. Chairperson, inflammation, we all know, acts as a trigger for ACS in a select group of patients. But inflammation as a response to the myocardial death in MI may predict future heart failure, recurrent MI, again in a select group of patients. And it is this group of patients probably who will benefit when you treat inflammation as a target in the post-MI phase, reducing heart failure, recurrent MI, and overall mortality. In fact, as I was listening to the debate with Karunadas and Sergeant Sergeant Narayanan on post-culprit lesion, on the non-culprit lesion being revascularized, a thought came to me that maybe Karunadas or Sergeant can do a trial looking at the hsCRP of patients post-MI, maybe 48 hours or 1 week after the event, and finding out what happens to the result if you revascularize only those patients who has persistent inflammation and leave those patients who have no persistent inflammation to medical therapy alone. Just a thought that came to me now, half an hour ago. Thank you.
Thank you, Dr. Unni, for the excellent presentation. As usual, it was really highly informative. But you have mentioned about the inflammation. Then what about using certain drugs, commonly used colchicine, low-dose colchicine? Now it has come as a treatment, especially in the post-ACS, as well as in the stable coronary artery disease, showing some sort of benefit. If so, how long should we use this particular drug? It is easily available.
No, right now, whatever data is there, whether it is Cantos or colchicine, etc., are on patients who had 1 month or 2 weeks MI before MI. So they have been targeting chronic systemic inflammation. They are not targeting post-MI inflammation, which is the topic my day. As I said, those studies have really been neutral. Maybe you have to select those patients who had a rise in some particular value, maybe rise in hsCRP after MI. Then maybe you will have some results. But trials are going on. Maybe right now you have to keep our fingers crossed.
Now, especially for, if you say that there is an increase in the hsCRP, and the statin is the only drug now available which has got the anti-inflammatory property. Because earlier some of the trials have shown there is a significant reduction in hsCRP with statins. So what else can we give, especially to prevent this one?
No, other than anti-inflammatory, even in the anti-inflammatory group, while canakinumab and colchicine showed benefit, methotrexate did not show any benefit. In one CERTIS trial, methotrexate did not show any benefit, and it did not reduce hsCRP also. So that is why I said this pathway is now being investigated, IL-1B, IL-6 pathway.
Govindran, what is your approach to your personal patients? Do you make it a routine to start some of your patients on colchicine, and how long, and what is the dose that you recommend?
To be frank, I have not given colchicine to anybody. I have no personal experience.
I just wanted to inform you that we are part of a new trial called the ZEUS trial. This is a monoclonal antibody called siltivecumab, which is actually targeting the IL-6 and the entry criteria is those. Yes. Yeah, with a high CRP and inflammatory marker. So this is supposed to be a game changer in future ACS.
Hopefully.
Thank you, Dr. Unni, for the excellent presentation.
Even after many trials, we are still not, there is still confusion whether how long the dual antiplatelet therapy should be continued. We are not confident enough to stop the antiplatelets. Even after 2 years or 3 years, the patients are still continuing dual antiplatelets. So this issue, to address this issue, we have a Dr. Anup Govindath. What's a short dual antiplatelet therapy? Where do we stand now?
Good morning to you all. I would like to thank Dr. Jay Gopal and Dr. Prabha Madam for giving me an opportunity to speak on this topic. The topic is short dual antiplatelet therapy in post-ACS patients. Where are we now? Why this topic? Because it is clear from all the trials that you have to give 1 year of total dual antiplatelet therapy, and then withdraw to a single antiplatelet like aspirin for long duration. So in such cases with high bleeding risk, what do? Whenever there is an acute myocardial infarction or an acute coronary syndrome, there is plaque fissuring. And when there is plaque fissuring, we know that the internal elastic lamina is breached. When the internal elastic lamina is breached, platelet activation is very, very severe. So a single agent with one pathway is not enough to block the platelet activation. So you need a dual antiplatelet. Once this internal elastic lamina is healed, which occurs a total of mean 3 months, and it is completed in a total of 9 months, you can switch over to a single antiplatelet therapy, because then it behaves like a chronic stable case. So intermittently in the acute and subacute phase, the problem is you have to reduce the ischemic outcomes. So dual antiplatelet therapy including aspirin and clopidogrel is widely used with proven benefit for the prevention of recurrent ischemic events after acute coronary syndrome. And it is already clearly shown that platelets play a central role in atherothrombosis, and platelet inhibition is crucial. So in all the trials, an association of aspirin with an antiplatelet agent, be it clopidogrel, prasugrel or ticagrelor, is the current standard therapy. Earlier guidelines used dual antiplatelet therapy for 12 months, and this was after the CURE trial results in 2001. CURE trial clearly showed that if you combine clopidogrel and aspirin versus aspirin alone in the acute and subacute phase, there was a 20% ischemic risk reduction in the combination when compared to the single monotherapy. So the mean duration of DAPT in these trials was 9 months, that is from 3 to 12 months. So all the trials, that is the European and American guidelines, came up with an idea of 1 year of dual antiplatelet therapy after an acute coronary syndrome. But despite 12 months of dual antiplatelet therapy, there is a large number of patients who had recurrent ischemic events. To reduce the ischemic events, if you increase the potency of the dual antiplatelet blockade, there was high bleeding risks. So to mitigate this, the DAPT duration adjustment may sometimes be beneficial for a significant proportion of patients who have been selected. DAPT is essential to reduce the risk of stent thrombosis and target lesion revascularization at the site of PCI. And secondarily, another area, recurrent ischemic event is also prevented by dual antiplatelet therapy. But the problem is, if you continue dual antiplatelet therapy in a high-risk individual, there is a high risk of bleeding, and this bleeding risk may be even more dangerous than recurrent myocardial infarction. So data from meta-analysis and precise DAPT study supported the use of DAPT for 3 to 6 months in high bleeding risk ACS. So short-term DAPT has consistently shown non-inferiority compared to the 12-month DAPT. So let us go to the terminology. Standard DAPT now is ticagrelor and aspirin given for 12 months. Short DAPT is ticagrelor and aspirin given for 3 months. What is de-escalation therapy? De-escalation therapy is you give ticagrelor and aspirin for 1 month and convert to clopidogrel and aspirin thereafter. So now we need a balance. The balance is required between the ischemic risk and the bleeding risk. So any attempt at reducing the ischemic risk may increase the bleeding risk. So how to balance this is very, very important. So assessing the patient at the time of entry to hospital is very important. If a patient has previous history of major bleeding, if there is severe anemia, very low platelet count, previous hemorrhagic CVA, or patient has severe liver disease, or is a known case of malignancy, these patients are at high risk of bleeding. If you go for femoral intervention with GP2B3A inhibitors in full dose, or you are taking a post-thrombolized patient for PCI, or you are taking a patient for PCI who is already on anticoagulants, the risk is high. Then we assess the ischemic risk of the patient. If the patient's age is more than 75 years, if the patient is diabetic, if the patient is a case of chronic kidney disease, recurrent myocardial infarction, previous stent thrombosis, or polyvascular atherosclerotic disease, or a patient is having very high BMI, the ischemic risk is high in such a patient. Also, when we do intervention, if we perform a multi-vessel intervention, or if we are performing a CTO intervention or a bifurcation lesion, the risk is higher. Suppose you have optimized a stent and you are not able to optimize a stent. There is a stent under expansion or malapposition. This patient has a higher ischemic risk when compared to a normal patient. In these cases, what is to be done? So, major trials on short DAPT. The STOP DAPT 2 compared 1 month of dual antiplatelet with 12 months DAPT in low to moderate bleeding risk, and it was clearly shown that there was no increase in the primary endpoints of cardiovascular death, myocardial infarction, stent thrombosis, and there was a lower bleeding risk. But the problem here is most of the stable patients were included in this trial. So when they introduced acute coronary syndrome patients like STEMI and NSTEMI, it was clearly shown that if you give 1 month DAPT, there was a 2-fold higher increase in myocardial infarction. In the master DAPT trial, high bleeding risk patients were given 1 month of dual antiplatelet therapy versus standard therapy, and the primary endpoints were non-inferior to the standard DAPT with lower bleeding risk. And it was after this trial, the term abbreviated DAPT came into being. In the global leaders trial again, now the difference in this trial is ticagrelor plus aspirin was given for 1 month, and the continuation was not with aspirin, it was with ticagrelor for 23 months. So this trial showed that there was lower endpoints of cardiovascular death, myocardial infarction, stroke, and there was a 31% relative risk reduction in bleeding. In the Twilight trial, this trial is very, very important because it included all subsets of patients, those with high bleeding risk, those in whom complex PCIs were done, CTO subsets, bifurcation interventions, diabetic subsets, and a large number of patients who had acute coronary syndrome was studied, and it was shown that if you give dual antiplatelet therapy for 3 months and continue with a ticagrelor monotherapy, there was a 44% reduction in bleeding risk with no significant increase in the ischemic risk. The TICO trial again showed that if you give dual antiplatelet therapy for 3 months and then ticagrelor monotherapy, bleeding risk was reduced and reduced all-cause mortality, myocardial infarction, stent thrombosis, stroke, and target vessel revascularization. So in the meta-analysis, in the short dual antiplatelet therapy trial, there was only a 2.8% reduction in bleeding, whereas the long DAPT, it was 3.8% statistically significant. These are the ongoing trials, TPAS, ACLOS, Smart Choice 2, Smart Choice 3, all showed a benefit of 1 month DAPT followed by a ticagrelor monotherapy after that helps in high bleeding risk patients. What is de-escalation? You start the patient on ticagrelor and aspirin and then convert it into clopidogrel and aspirin in 1 month. And it has been shown in some trials, like the TOPIC trial, that the de-escalation was superior in terms of lower cardiovascular death, myocardial infarction, stroke, and there was also a decreased bleeding complications. In TALOS acute myocardial infarction trial, unguided DAPT de-escalation, 45% reduction in clinical events and reduced bleeding. What is guided and unguided de-escalation? Guided de-escalation is when you do a platelet function test and then you start clopidogrel, it is guided. Or you go for a CYP2C9 testing and then you go for de-escalation, it would help. So in both these trials, it was clearly shown that short DAPT is beneficial when compared to that of the 12 months DAPT. Now in the guidelines, it's a two-way indication. In selected patients, dual antiplatelet can be shortened for 1 to 3 months and then monotherapy to reduce the time of bleeding. So if you have an ACS patient, the dictum is you give a dual antiplatelet therapy for 1 year. If the patient is at risk of high bleeding, give it for 1 to 3 months in case of high bleeding risk and then continue with a ticagrelor monotherapy. But in non-ACS patient, stable patient, dual antiplatelet therapy can stop 1 month and after that you can continue the patient on ticagrelor monotherapy. But at the index 7, at 6 months and 12 months, you should reassess the ischemic risk before this switch. Thank you.
That was a very good presentation, Dr. Anup. It's a very important topic, so we can have 1 or 2 comments from the audience.
So you're advocating that ticagrelor monotherapy is very good. Now I'll ask you a question.
Yeah.
You have a patient with a stent, long stent, 38 millimeter stent on ticagrelor. What will be your advice about stopping the ticagrelor before a surgery? I'll tell you one thing, there is a randomized trial comparing stopping ticagrelor for 3 days versus 1 week. Please answer.
Yeah, madam, if you have a long stent in situ and if it is more than 3 months since the PCI has been done, you can stop ticagrelor for 3 to 5 days before surgery and then continue, provided that you are doing the surgery on aspirin. This is the only exception is for neuro interventions, where in neuro surgical procedures you have to stop the dual antiplatelet for 14 days. For all others, you can continue with the surgery.
Yeah, so why I ask this question is, there's a randomized trial showing that unless you stop the ticagrelor 5 days in advance, there'll be heavy bleeding compared to 2 days. So I wanted to stop it for 2 days in a patient, but when I saw the trial, I stopped it for 5 days.
Right.
But I don't know the outcome of the surgery yet.
So we will just conclude this session and we will move on to the next session.
Thank you, sir.
And the next one is on this one, on the treatment of ISR. Whether DEP or restenting is, which one is better? We know that there are so many modalities for the treatment of ISR. However, the 2 modalities which are very prominent and have been recommended by the revascularization committee is either DEP or DES or DCP. Now to talk on this one, may I invite Dr. Rajesh.
Thank you, Jayagopal sir, for this opportunity. Respected teachers, colleagues, my dear friends. Over the next 8 minutes or so, I'll be talking about a drug-eluting balloon versus a drug-eluting stent in the scenario of an in-stent restenosis. In-stent restenosis remains the most common cause of stent failure. A stent may fail because of multiple reasons, the most common of which is mechanical factors, which include underexpansion, undersizing, a fracture, a gap within the overlap stents, the stent type, or there may be edge stenosis, edge restenosis. Or it may be vessel-related factors like multiple stent layers you have already put in, vessel calcification, calcific nodules, vessel size, a smaller vessel size, or a residual plaque burden. Particularly relevant to today's afternoon's discussion is probably the biology of restenosis or the histology of the tissue within or inside the stent. It may be a neointimal hyperplasia, a novoatherosclerosis with associated calcification or thrombus, a homogeneous or a heterogeneous appearance on an OCT imaging, a focal or a diffuse pattern on an angiogram, and the obstruction severity. So, what are the essential differences between a bare metal stent in-stent restenosis and a drug-eluting stent in-stent restenosis? Although superficially they might appear common, they are biologically different entities. In-stent restenosis in a bare metal stent is classically associated with neointimal hyperplasia, which is defined as the accumulation of smooth muscle cells and extracellular matrix within the intima, whereas novoatherosclerosis or neoatherosclerosis is the pathology which is defined as the presence of foamy macrophages inside the intima in case of a drug-eluting stent restenosis. This atherosclerosis may be associated with either necrotic core, thrombus formation, or calcification. I must confess that this is an oversimplification and there is considerable crossover between the two entities as the stenosis evolves over time. But for practical purposes or for discussion purposes, novoatherosclerosis is a predominant pathology or biology in a drug-eluting stent in-stent restenosis and neointimal hyperplasia in a bare metal stent in-stent restenosis. In real life, the closest that we can get to this histology is by imaging. Angiographic studies have shown that a diffuse pattern is more common with a bare metal stent restenosis, whereas in drug-eluting stents it tends to be more focal. The temporal studies or the time course of late luminal studies have shown that a late luminal loss maximally occurs in case of a bare metal stent by around 6 to 8 months' time when the neointimal hyperplasia is at its maximum, beyond which the neointima actually regresses either as a result of a positive remodeling, some contraction of the neointima as well as a result of vessel healing. But long-term studies, including ours, have shown that there may be a second peak that happens beyond 4 years. So there is an initial peak for bare metal stent stenosis at 6 months and then a second one that is happening at around 4 years because this neointima further degrades into novoatherosclerosis. Nothing of that sort happens in case of a drug-eluting stent restenosis where the late luminal loss is continuous and probably goes on till 5 years of age because the ongoing inflammation is going on and the vessel healing is delayed. So that brings us to the question, is intravascular imaging mandatory to treat ISR? Yes, it helps in identifying the degree of in-stent restenosis. It identifies the underlying pathological mechanism of restenosis. ESC guidelines tell that you should have a class 2A level of evidence B recommendation for that. It enables a more targeted treatment, but the larger question is that there are no RCTs thus far supporting the differential treatment of ISR based on intravascular imaging will improve outcomes. And there is paucity of data on long-term outcomes. So logically, it's better to use intravascular imaging if you have it, but it's okay to treat an ISR without this because you don't have evidence for that. Whether you should use an OCT or an IVUS, OCT clearly scores over IVUS with this regard. When you grade this in the score of good, feasible, good and very good, it can be seen that OCT clearly shows better images compared to that of IVUS, largely because of its superior resolution and also because that we are more interested in pathology that is towards the near field. Tissue penetration, which is a hurdle with OCT, is not an issue in case of imaging with ISR. So OCT, if it is available, will make our life easier. This is how it would appear. Neointimal hyperplasia would appear as homogeneous, bright and uniform layer, and novoatherosclerosis will appear as heterogeneous with showing necrotic core as well as foamy macrophages as well. There are other features also, I'll not go into the details. Now that we have understood and defined ISR, how to treat it, there are multiple modalities that are tested, and all of them have been tested in head-on trials as well as in meta-analysis. But the two technologies that have emerged preeminent in the treatment of ISR are the drug-eluting stents as well as the drug-coated balloons. Neointimal hyperplasia and negative remodeling contribute significantly to in-stent restenosis, and both of it can be taken care by the sustained release of antiproliferative drugs. Drug-coated balloon comes as an interesting proposition in this scenario because it leaves nothing behind. The essential construct of an drug-coated balloon is other than the balloon consists of a matrix coating, which includes an active drug, which ideally should be lipophilic so that it can be transferred into the tissues fast, as well as it contains an excipient, which increases the solubility of the drug so that the rapidity of transfer into the tissues can be accelerated. Paclitaxel was the natural choice to begin with because it is highly lipophilic, and we now have multiple manufacturers. But as you can see, they are all widely different. The additives are different, the substance class is different, the dose of the drug is different, and more importantly, all these balloons have been tried and tested only in small trials just to meet the regulatory approval criteria. When meta-analysis started showing that sirolimus stents are better than paclitaxel stents, people looked at sirolimus also as an option for drug-coated balloons. But the problem with the sirolimus was that it has a lesser lipophilicity and it has a reversible action. But we still have at least two balloons in India that have sirolimus coated. But the larger point here is that there is no class effect, that all balloons should be considered individual. Taken individually, both drug-eluting stents as well as drug-coated balloons do fairly well in treatment of in-stent restenosis. The ISR Desire showed that it is better than balloon angioplasty. There was no difference between paclitaxel and drug-eluting stents. There was no difference between an everolimus and a sotariolimus eluting stents. And with regards to drug-coated balloons, it was shown that if you have pre-treatment with a scoring balloon as shown in the ISR Desire 4 trial, we have a better results. But how does it compare when you compare a paclitaxel balloon with that of a standard stents? There are no trials so far between the sirolimus eluting balloons as well as stents. There are no randomized controlled trials, although there are bare metal stent studies as well as drug-eluting stent studies with regards to paclitaxel balloons. Our present day practice as well as the guideline recommendations is based on this study, the Daedalus study, which is a meta-analysis of the 10 randomized trials with the highest quality of evidence involving more than 200 patients followed up for 3 years, and they showed that the primary efficacy endpoint for a drug-coated balloon versus a drug-eluting stent is better with a drug-eluting stent. The primary efficacy endpoint. There was no difference with regard to the primary safety endpoint, which was a combination of all-cause death, cardiac death, myocardial infarction, and target lesion thrombosis. So, in the largest meta-analysis has shown that if for treating the drug-eluting stents, for stents in in-stent restenosis, a drug-eluting stent is clearly better than that of a paclitaxel eluting balloon. Let us deep dive into it a bit more. I'll just take 1 minute to explain this. Drug-coated balloon with drug-eluting stents in this scenario of bare metal stent versus in-stent restenosis. Let us look at the first one. In the entire scenario of in-stent restenosis, if you use, whether you were to use a drug-coated stent or a drug-eluting balloon, you can see that the efficacy is clearly better for bare metal stent compared to that of a drug-eluting stent. That means BMS ISR is a better disease to treat than drug-eluting stent ISR. Now let us look at the same data from the in-stent restenosis point of view, from the device disease that is restenosed. The bare metal stent restenosis, it can be seen that there is no significant difference between the drug-eluting stent and a drug-coated balloon, whereas for a drug-eluting stent ISR, a drug-eluting stent is better than a drug-coated balloon. And if you look at the drug-coated from the device point of view, it can be seen that a drug-coated balloon fares significantly better in a bare metal stent scenario compared to that of a drug-eluting stent. This is my last slide. So how do you deal with in-stent restenosis now? Perform an intravascular imaging if it is available, address the mechanical issues, and this is the first thing to do, and that should be done at the first instance, and do it again and again and again before you use any device. And then depending on the device you have, if you have a bare metal stent in-stent restenosis, you can use a drug-eluting balloon or a drug-eluting stent, or other types a drug-eluting stent is preferred over a drug-coated balloon. And these are the scenarios where a drug-coated balloon may be preferred over a drug-eluting stent when you have a residual lesion of less than 30%, no flow-limiting dissection, large side branch, or avoid another stent layer, or when there is a high bleeding risk. Thank you for your time.
Thank you, Dr. Rajesh, for the excellent presentation. 2 small questions. Number 1, in patients with the recurrent ISR, which is better? Number 2, when you are using this DES for ISR, will you use a different limus stent or the same limus stent?
Yeah. For the first question, sir, if then since there is already 2 layers of stents, it may be better to use a drug-coated balloon compared to that of a drug-eluting stent. Second is a homodus versus a heterodus. There are different studies, but that question is probably not relevant now since we don't have paclitaxel eluding stents. And further, even when they were available, those technologies, that strategy has not been shown to be much of use. Thank you.
We will, after very nice presentation, Dr. Rajesh, we will move on to the next one.
We see more and more young patients with young people with acute syndrome recently. So is it what is the role of imaging studies in these young patients with acute coronary syndrome? To address this issue, we have Dr. Sajir Keti. He is talking on ACS in the very young. Is OCT mandatory?
Thank you, Jayagopal sir, for giving this opportunity. And respected teachers and friends, my topic is ACS in the very young is OCT mandatory. As you know, the most common pathology in acute coronary syndrome is the rupture of vulnerable plaque leading to coronary thrombosis and occlusion of the coronary artery, that is in 60 to 70% of cases. Autopsy studies reveal two other pathophysiologic mechanisms for acute coronary syndrome, that is the plaque erosion, that is in 25 to 30% of cases, then calcified nodule, that is in 5% of cases. With the introduction of OCT imaging, we could have the in vivo recognition of this lesion morphology in a case of acute coronary syndrome. So in plaque rupture, that is more common in ST elevation, MI, there is massive thrombus formation and rupture of the fibrous cap, and there is red thrombus formation. Whereas in plaque erosion, mainly seen in non-ST elevation MI, mainly in younger age, more in females, since there is no rupture of the fibrous cap, only the endothelial cells are eroded, there is less thrombus formation and more preserved vascular structure and larger lumen and patent culprit artery, and there is white thrombus. So that is the difference between the rupture, plaque rupture and plaque erosion. And regarding calcified nodule, that is mainly seen in elderly patients with ACS. And this is the OCT picture of a plaque rupture and plaque erosion and calcified nodule. So this regarding plaque erosion, that is more common in young ACS patients. Around 30% of patients is having plaque erosion on OCT imaging. So on OCT we have a disrupted fibrous plaque with underlying necrotic lipid core, that is plaque rupture. If underlying calcium, that is calcified nodule. If intact fibrous cap, we have plaque erosion. So according to the current guidelines, stent implantation is the recommended to treat culprit lesion in patient with STEMI. But the recent data showed that this one-size-fits-all approach may not be the best choice for patient with ACS, caused by plaque erosion and other non-atherosclerotic mechanisms such as spontaneous coronary artery dissections. And what are the limitations of angiography in primary PCI? That is inaccurate assessment of lesion morphology and underlying mechanisms, and suboptimal identification of post-stent result, under expansion, malapposition, head dissection and tissue protrusions. So currently there is no recommendation for routine use of OCT in acute coronary syndromes. But there are few studies investigated the value of OCT imaging in systematically optimizing the reperfusion strategy in the context of STEMI with moderate stenotic lesion less than 70% cases. So what are the utility of OCT in ACS? To evaluate the plaque compositions, to evaluate the lesion morphology, and to design the treatment strategy, and for post-stenting assessment. First comes the erosion study. It's a single standard study. It is a prospective proof concept study. That is effective antithrombotic therapy without stenting. OCT-based assessment in plaque erosion. That is, this study was done to assess whether patients with ACS caused by plaque erosion can be managed with antithrombotic therapy without stent implantations. Patient diagnosed with plaque erosion by OCT and residual diameter stenosis less than 70% on CAG were included. The primary endpoint was more than 50% reduction of thrombus volume measured by OCT at 1 month. Out of 405 patients, 103 patients had plaque erosion, that is 25% of study population had plaque erosion, and they were followed up after 1 month. In this group of patients, only 55 patients underwent medical therapy without stenting. And this is the baseline data. You can see the thrombus volume at baseline was 3.7 thrombus volume, which was at 1 month follow-up reduced to 0.2%. That is 94% reduction in thrombus volume, and also thrombus burden also you can see there is significant reduction at 1 month. So this is a representative case study from this erosion study. In this case, you can see in the LAD there is a 55% lesion. This is a serial OCT showing the plaque erosion with white thrombus, and after 1 month you can see still 45% stenosis, with no visible thrombus over in the fibrous plaque. And the minimal flow area increased from 2.4 to 4. So erosion study showed that adoption of medical therapy without stenting might be a feasible option for STEMI caused by non-obstructive plaque erosions. Then comes the erosion 3 study. It is a multi-center randomized controlled trial, included all STEMI patients within 12 hours of symptom onset with target lesion in native coronary artery and non-obstructive residual lesions with TIMI-3 flow at presentation or after wiring or thrombectomy. Out of 246 patients, one group allocated the OCT-guided group and other angio-guided group. You can see in the OCT-guided group, plaque rupture was seen in 74% of patients and plaque erosion in 29% of patients. And out of which, plaque erosion, 44 patients underwent stenting, and plaque rupture, 44 patients underwent stenting, and plaque erosion, 4 patients underwent stenting. And in the OCT group, the 43% of patients underwent stenting, and in the angiography guided group, 58% of patients underwent stenting. So OCT guidance was associated with a 15% reduction of stent implantation compared with angiography guidance, and this was the primary efficacy endpoint. And coming to the survival rate, it's almost better with OCT guided group at 30 days. So after I got this topic, I did a OCT in a 35-year-old male with inferior MI that showed a plaque rupture, and subsequently this patient underwent stenting since it was a case of plaque rupture. So this OCT guided shift of reperfusion strategy in patient's tummy, OCT allowed more accurate stent and balloon sizing and evaluation of stent expansion, apposition and tissue prolapse, and non-obstructive erosions, ruptures without high-risk features, and other non-atherosclerotic causes. Non-stenting medical therapy might be an option. So this is the potential future approach for evaluation and management of patients with ACS. In a case of STEMI, you should do angio and OCT. If plaque rupture, do for stenting. If there is plaque erosion, there is a chance for antithrombotic therapy without stenting in non-obstructive lesions. That is applicable in case of non-ST elevation ACS also. So to conclude, in young patients of ACS without major risk factors, one can predict plaque erosion, and OCT must be planned while performing CAG to confirm the diagnosis. Routine use of OCT in all cases is not recommended now during primary PCI, and this may be incorporated in the guidelines in future if more data is available. This concept will lead to a major paradigm shift in the diagnosis and management of ACS in future. Thank you.
So in selected cases, at least, young patients with ACS, image-guided PCI is giving some benefit, because we can see whether stenting is actually required or not. Is there any questions from the audience?
What is the age limit to say as young and very young? Because it is very young. So what is the cutoff age to say young and very young?
Less than 45, it is young, sir. Less than 30, it's very young.
Okay, thank you. Thank you, Dr. Sajir, for the excellent presentation. We will go to the other one, that is SCAD in ACS implications. We know that SCAD is a non-atherosclerotic disease spectrum with a varying presentation starting from ACS to sudden cardiac death. It has got and the prognosis as well as the treatment is still a controversy. Now I request Dr. Srigala to present this particular topic.
Good afternoon, respected chairpersons and my dear friends and senior colleagues. I would like to thank at the outset Dr. Jayagopal sir and the organizing team for giving me opportunity to present this topic in front of you. So in the next 8 minutes, I will be dealing with spontaneous coronary artery dissection. What is the update? So spontaneous coronary artery dissection, SCAD, was first described in 1931 by Pretty in a young pregnant lady. It's a rare non-atherosclerotic cause of acute coronary syndrome, and majority of patients are young, otherwise healthy females without any classic cardiovascular risk factors. So it contributes to a rare cause of acute coronary syndrome, that is 0.1 to 0.4% of cases, and almost 75% of cases in young females is due to spontaneous coronary artery dissection. So causative factors, the predisposing factors as discussed earlier is a pregnancy is the most common predisposing factor, especially postpartum period. Also, a few patients belong to a category of connective tissue disease like fibromuscular dysplasia and also after hormonal therapy. Potential stressors in these persons include extreme physical exertion, intense emotional stress, sympathomimetic drugs. Childbirth itself can cause SCAD and Valsalva-like activities. So the basic pathophysiology have been divided into two. These stressors can cause a shear stress on the coronary artery wall, which causes an intimal tear in these persons. And this is the initiating event in many patients. This causes a separation of the inner intimal lining from the outer vessel wall, causing an intramural hematoma. And propagation of this hematoma causes the formation of a true lumen and a thrombus containing false lumen. Another less common theory is a rupture of vasa vasorum causing spontaneous intra-arterial hemorrhage. This is shown in this slide. And arteries involved majority as LAD, that is in 30 to 40% cases, and circ in 20%, right coronary artery in 10 to 30%, and left main is rare 4%. So now we can deal with this angiographic classification of this SCAD, which was first described by Yipsaw. The type 1 is just a contrast staining of the arterial wall. So you can see multiple radiolucent lumens. This is due to the intimal tear creating the false lumen. You can see as a dye hang up in the affected vessels because of dye stasis in the false lumen. Type 2 is the most common variety, which is seen in 60 to 75% of cases. This is due to a collection of the blood in the muscular layer. And in angiogram, you can see as an abrupt change in the coronary caliber. And this is a diffuse more than 20 millimeter with no response to intracoronary nitroglycerin and no lesions in other coronary vessels, as you can see in this slide. So this is a diffuse long segment, we will think is a spasm, so there is no response to intracoronary nitroglycerin. Two have been subdivided into 2A and 2B. 2A is confined to a coronary artery segment, and 2B, the dissection extends up to the terminal artery, that is up to the entire segment of the artery. Type 3 is again similar, but it's a focal, less than 20 millimeter stenosis without atherosclerotic changes in other vessels. And two other subtypes have also been included, type 4, which causes total occlusion of the distal artery because of external compression by the intramural hematoma. Also the intermediate variety, which puts types 1 and 2 together. How can you diagnose typical angina, palpitation or fatigue in a middle-aged healthy female? ECG features of STEMI in 50% or ST depression in others. Minority can present with arrhythmias, shock or sudden cardiac death. Pregnancy and postpartum SCAD have worst outcomes. Genetic association have also increased the risk in some persons, and these are the genes which have been studied in these persons. Investigations, routine ECG, echo and intravascular imaging plays a major role in differentiating what is the type of the lesion in these persons, also cardiac MRI. So this is the intracoronary imaging picture. In IVUS, you can see the classic triple band, white, black, white of the intima media membrane, and this is a pathognomonic feature for SCAD. OCT is preferred because of the better spatial resolution. You can see the hematoma inside the intima or in the media. Also, there's a separation of the two lumens, that is a false as well as the true lumen. Also, with OCT, you can differentiate whether it's an atherosclerotic plaque erosion or a plaque rupture or a non-atherosclerotic cause like spontaneous coronary artery dissection. And this is the OCT findings of SCAD I described earlier. In type 1, you can see the intramural hematoma. In type 2 and type 3, almost the picture is similar. Other investigations like cardiac MR is indicated in pregnant women for avoiding coronary angiogram and also for differentiating myocarditis and tachycardiomyopathy. And if the evidence of acute coronary in subset of patient is unclear, then you can go for cardiac MR. Evidence of myocardial infarction with subendocardial late gadolinium enhancement can be observed in these persons. Coronary CT is done less commonly in this subgroup of patients. You can identify the luminal stenosis, epicardial fat strand, tortuosity, bridging and regional wall motion abnormality. So natural history, majority heals spontaneously with time and complete resolution takes 1 month in stable patients. 10 to 30% of recurrence risk have been observed in 10-year follow-up trials, and long-term survival is better compared to the atherosclerotic causes of acute coronary syndrome. In-hospital MI is around 5% and long-term MACE events is observed in 20% of cases. And please note, conservative treatment group had a better outcome compared to the intervention treatment group. This is just a scoring system to know which all patients we should select for intravascular imaging. Basically, connective tissue disease, young ladies, patients on hormonal therapy, no other coronary risk factors, all this puts the diagnosis of SCAD in the first, and then you should try for an OCT or IVUS. So medical treatment, as discussed, aspirin, acute and long term. Clopidogrel role is controversial. You can use in the acute phase. Beta blockers has got an important role because it reduces vascular shear stress and complications. ACE inhibitors indicated in patients with LV dysfunction. Anti-anginals in persons with post-SCAD chest pain syndromes because of vasospasm. Statins, no role because there is no lesions in other coronary vessels. Indications for PCI in patients with ongoing symptoms or hemodynamic instability. The main challenge is propagation of this hematoma and guide wire manipulation in the true lumen and late stent malposition. So preferably PCI should be image guided and long stents should be used to cover 5 to 10 millimeter proximal and distal to the intramural hematoma. You can also use cutting balloon to fenestrate the intramural hematoma, and biovascular scaffolds is preferred to avoid late stent malposition. Bypass indications very few, multivessel involvement, failed PCI, left main involvement, and also extensive proximal artery dissection involving multiple territories. And prevention, no primary prevention. Secondary prevention, you can avoid these persons to extreme physical exertion or activities, and also you can ask them to avoid pregnancy because pregnancy is one factor which increases the risk of SCAD. Also avoid isometric exercise and continue medical treatment. Thank you for the patient listening. This is a pathologic picture of SCAD. This is a true lumen and a false lumen. Thank you, sir.
Thank you, Dr. Srigala, for the excellent presentation. I just want to ask one question. What is the exercise prescription that you will give to these patients with SCAD?
Exercise?
Prescription. Suppose that the patient has got a scan.
They should not lift, I mean, we have to avoid exercises which increases, isometric exercise should be avoided.
Can they take part in sports?
Sports, no.
No. And
No.
suppose if the patient has got a scan of the left main, what do you do? I mean, is it a conservative line of management? Scan of the left main.
Scared of?
Left main.
Left main.
Yes.
So usually scared of left main, the recommended treatment is CABG, sir.
No, CABG, which vessel will you graft?
CABG?
How, I mean, where will you put the graft?
Through the graft.
Suppose there is no flow compromise. Patient has got left main scat. What is the mode of treatment? Is it conservative?
Conservative, sir. If the patient is stable with left main, they should undergo CABG. For
No, how? I mean, if you put a graft, there will be competitive flow. So if there is no flow compromise.
If there is no flow compromise, conservative treatment is recommended, sir.
Thank you, Dr. Srigala,
Thank
for
you,
the
sir.
excellent presentation.
Last topic of this session is ectatic coronaries and ACS in a real challenge in management, done by Dr. Anand M. Pillai.
Thanks to Jayagopal sir, respected chairpersons, teachers and friends. I'll be talking about ectatic coronaries and ACS, a real challenge in management. I'll start with 3 short cases. This was an inferior wall STEMI, and you can see that the distal LCX and probably left PDA is occluded and thrombotic. Clearly ectatic vessels can be seen. The ST elevation was only subtle. The patient was clinically stable. We opted for a medical management even without trying to wire or open up the vessel. A check angio seen on the right side taken 2 days later shows that the vessel has partially recanalized with distal flow has been re-established, so medically managed. This was an anterior wall STEMI. A mid LAD is occluded and clearly ectatic. We had an unstable guide, and this is a selective angiogram with the guide liner in place. We had wired the vessel, done a thrombus aspiration as well as some ballooning, despite of which we are not able to recanalize the vessel. This patient was treated with intracoronary lysis followed by 2B3A infusion. A check angiogram was taken 24 hours later. On the right side, you see a very nicely recanalized LAD, which to begin with, we had difficulty re-establishing flow despite balloon angioplasty. So a case treated with intracoronary lysis and 2B3As. This is only a still frame, right-sided ectasia, STEMI inferior. After it has been ballooned, you can see a very heavy thrombus burden. Uniform ectasia, as you see, and we decided to stent this case. A 5 millimeter stent was put and was post-dilated with a 6 millimeter balloon with a good final result. So 3 short case scenarios, first one medically managed, second one with intracoronary lysis and 2B3As, and third one with stenting. So by definition, coronary artery ectasia, the diameter is more than 1.5 times a normal segment, more than 50% of the length of the vessel is involved, up to 5% of patients undergoing angiogram, has been shown to have a higher cardiovascular mortality and events. RCA is most common, followed by LAD, circumflex, and left main. There is a fair bit of overlap between ectasia and aneurysm. Aneurysm is when it is a focal dilatation. It can be saccular or fusiform. True versus pseudoaneurysm. This is a classification type 1 to 4. 1 is when 2 or 3 vessels are ectatic. Type 2 is when 1 vessel is ectatic and 1 is aneurysmal. Type 3 when only 1 vessel is ectatic, and type 4 when only 1 vessel is aneurysmal. The pathophysiology is predominantly thought to be atherosclerosis, but it is slightly different from the typical garden variety atherosclerosis. There is much more intense inflammation as well as probably chronic inflammation. There is a definite component of lysis of the extracellular membrane with metalloproteinases, which probably leads to a more of a positive remodeling as opposed to a negative remodeling that we see with garden variety atherosclerosis. Apart from atherosclerosis, other rarer reasons could be systemic vasculitis, connective tissue disorders, genetic diseases, infections. Kawasaki diseases in childhood is a predisposing factor. And post-COVID scenario, obviously, we have seen a lot of young thrombotic ACS in which we have seen that the vessels are ectatic or aneurysmal, likely because of a systemic inflammation and specifically affecting the coronaries with coronary vasculitis. Risk factors include the traditional factors of atherosclerosis. There is an association with bicuspid aortic valve as well as aortic aneurysm. Some reason in diabetic patients, because of predominant negative remodeling, ectasia is found to be less common. This is a large observational study over an 11-year period where 20,000 coronary angiograms were screened and the prevalence was 0.85%. And important to also recognize the fact that all ectasia are not the same. Some of them have a superadded atherosclerotic stenotic changes like the one I think Dr. Sanjeev had presented today. A very ectatic right coronary artery with a very focal segment in the middle. So more than 75% of these cases also have stenotic disease and 25% are isolated ectasia. Mechanism of ACS can either be a plaque rupture, as you see here, can be thrombosis from the stasis, it can be a distal embolization, or it can be impaired perfusion from slow flow. There were mixed outcomes in the earlier trials. Obviously, there are no randomized controlled trial with categorizing the interventions particularly, but generally it has been seen that the cardiovascular mortality and morbidity are higher. So what to do with these patients has to be dealt on a case-by-case basis. Things to consider is the vessel predominantly or uniformly ectatic versus if there are any stenosis. If it is predominantly ectatic, probably there is a higher thrombus burden. You can do an aspiration. You can probably kind of open up the stenotic segment, and if you're able to establish distal flow, a continued anticoagulation might suffice in a lot of the cases. Estimating the vessel size is very challenging. We had the discussion today morning. So because of the same, stenting can be tough because a landing segment may not be obtained because of diffuse ectatic changes, and stenting can also subsequently lead to malapposition and stent thrombosis. Imaging can help. OCT is suboptimal because of incomplete blood clearance and low penetration depth in larger vessels. IVUS gives you better penetration and can have a better assessment of the vessel. So in most cases, wiring, thrombus suction might be adequate plus or minus balloon angioplasty. The thrombus burden is very high. Intracoronary lysis can be used with or without 2B3A inhibitors, and rarely, as in the third case that I had showed, where there was more of a uniform ectasia, there was a very significant stenosis, there was a good landing zone proximally and distally, stenting can be done, and that particular case was done with IVUS. The vessel size was almost 6. We had put a 5 millimeter stent and post-dilated that to 6 millimeters, and image guidance preferably mandatory in the case of stenting in an ectatic vessel. Medical management, there are no trials or guidelines as such, but oral anticoagulation is an option. Dual antiplatelet therapy is an option. I think clinically most of us kind of put them on a single newer anticoagulant with a single antiplatelet because there is concomitant atherosclerosis which also has to be dealt with. Statins and AC inhibitors are used for their pleiotropic effect on the endothelium. This is a simplified algorithm for treatment. Medical management including oral anticoagulants, particularly with the newer oral anticoagulant, it is much more easier to manage as opposed to giving them warfarin. Single or dual antiplatelet therapy depending on the bleeding risk. Interventions, rarely surgical options need to be considered, particularly in aneurysmal vessels which are at risk of rupture. So the practical risk of an aneurysm rupturing and causing a tamponade is very low. More of an important consideration in probably a pseudoaneurysm, which is an entity in itself. Pseudoaneurysm more commonly happens post PCI, usage of sterilized material. You have to make sure it's not a mycotic aneurysm. And stenting in such a case can cause inflammation and continued infection in the stent as well. Otherwise, the different options that we talked about can be deployed. This is a case from literature where there is a large aneurysm which is treated by a combination of stent-assisted coiling followed by a covered stent. Covered stent, more of an option in aneurysm or in pseudoaneurysm. Graftmaster and Papyrus are the two commonly used covered stents. Thank you.
That was a very good, coverage of the topic and a very good presentation. Any questions from the audience?
Anand, how long will you continue anticoagulants for these patients, and which all patients should you use? Patients for all patients with ectatic coronaries, should we start them on anticoagulation, and how long should you continue?
I don't think we have any guidelines or specific data supporting that. It has to be guided on a case-to-case basis. I think depending on how the angiogram looks, whether the patient has presented with a STEMI or NSTEMI, or what is the burden of infarction which has happened. So I don't have a clear-cut answer to that. Some degree of where we talked about the duration during which the inflammation persists, we can continue it, I think, until all the thrombotic burden has been dissolved. So probably at least 1 to 3 months is what I would roughly suggest. And then to be followed up depending on the bleeding risk and individual pathology.
Just one question. Suppose in asymptomatic patients, incidentally found the coronary ectasia, no CAD, should we give antiplatelets or anticoagulants?
I think I would at least start an antiplatelet, may not start an anticoagulant because the patient has not had an event. So otherwise, I would treat it as a secondary prevention now that a primary atherosclerotic pathology has been found. As I said, predominantly it is a form of atherosclerosis which leads to the ectasia with a predominant positive remodeling. So I would suggest at least a single antiplatelet and not an anticoagulant.
And regarding the previous question, and reports are there for low-dose rivaroxaban, 2.5 milligrams PD with aspirin. Should be given for a period of 6 months, then aspirin lifelong. This one, we would like to conclude the session by congratulating all the speakers for their excellent presentation. Thank you.
Thank you, sir. Thank you to the esteemed chairpersons and the speakers of the session. May I invite the next set of chairpersons for session 6, Advances in Therapy. Chairpersons, please. Dr. Arun Kumar, Dr. Haripriya Jayakumar, Dr. Himal Raj, and Dr. Joji Boban, please. First speaker, Dr. Saji Subramaniam. May I request the chairpersons to kindly make sure that the presenters adhere to time, please. Thank you. Over to you, sir, ma'am.
Now, all very interesting topics and very relevant topics of our day-to-day practice. So, we have heard of the crosstalk between the organs. So, to enlighten on this topic of heart failure and changes in kidney function, I'll call upon Suji.
Thank you, Arun. Respected Chair, senior members of CSI, and respected colleagues and dear friends. We know that heart failure and kidney function is always a conflicting points. We have multiple pillars in the management of heart failure, and sometimes the limiting factor, the inertia to start all these pillars, are a worsening renal function or a blood pressure. So I am not touching upon all the points of heart failure and kidney function. Let me concentrate on which we are all familiar with. Let me touch upon our RAS inhibition, which is the most important crucial point whenever we have to start RAS inhibition in heart failure. And whenever we start a RAS inhibition, we see the creatinine increasing, we see the potassium increasing, and we are forced to withhold our RAS inhibition. So, let me today concentrate on RAS inhibition and heart failure management and its impact on renal function. So, we know that many of our HFrEF patients with renal dysfunction with a florid state. Almost 30 to 50% of our patients are having renal dysfunction. It can be due to a cardiorenal syndrome, due to a reduced perfusion to the kidneys, or it can be due to a intrinsic renal disease like diabetic nephropathy, hypertensive nephropathy, or any other intrinsic kidney disease. So CKD and heart failure always play a interplay. 50 to 60% of our heart failure patients presents with a GFR less than 60, and 20 to 30% incidence of acute kidney injury during treatment for acute heart failure. And we know that in this high risk group of CKD patients, the incidence of heart failure is very high. It amounts to almost 20%. And 44% of heart failure with end-stage renal disease are having heart failure. And we are denying all the guidelines-mediated therapies to these group of patients who are at the high risk of having heart failure and death and mortality due to heart failure. So we know that it's always a complicated coexistence of heart failure and kidney disease. It leads to hospitalization, rehospitalization, ICU admissions, and finally leads to a renal replacement and cardiac death. So worsening renal function has a direct and independent consequences on heart failure symptoms and adverse clinical outcome. We know that whenever there is a deterioration on the clinical context, that translates to a decrease in the eGFR. And we can see that the red tip of the pyramid, that is in the acute kidney injury and worsening renal function, translate to the highest mortality. And due to the high disease burden of heart failure and kidney disease, these always interplay. And it is necessary to understand the changes in kidney function during treatment of both CKD and heart failure in chronic heart failure patients and those with acute decompensation of heart failure. And we are all familiar with this diagram. In chronic heart failure patients, there is a progressive loss of renal function which occurs over a period of time. We can see that there is a renal disease, there is a heart failure, there is a reduced renal perfusion which leads to a decreased intraglomerular physiology, and there is a glomerular edema, renal edema also due to heart failure. There is a backward failure also that is also adding to the worsening renal function. So heart failure disrupts kidney function in multiple pathophysiological mechanisms and leads to a cardiorenal syndrome that further perpetuates the heart failure progression. So acute heart failure leads to forward failure, backward failure, decreased renal blood flow by both these mechanisms, and finally resulted in worsening renal function, and we have a acute kidney injury or a worsening renal function. So we all know, we are all convinced about RAS inhibition, which is a cornerstone therapy for managing both chronic and acute heart failure, and it is one of the major factors which leads to a transient renal dysfunction. What happens is generally it leads to withdrawal or stoppage of RAS inhibition. But is it beneficial to stop RAS? Let us look at the data. We can see that when we start, in those patients when we don't start RAS inhibition, they all start with a high eGFR. The red line denotes their natural history. They having the maximum heart failure mortality. When we start the RAS inhibition, it goes to the blue line. So without RAS inhibition and with RAS inhibition, there is always an advantage path. So there is always a reduction in mortality and improvement in eGFR when we introduce a RAS in this high-risk group of patients. So RAS is always associated with a lower risk of heart failure, admission and mortality, despite showing an acute drop in eGFR. So continuation of RAS inhibition leads to a longer life expectancy and delay in worsening renal failure. And 1 year mortality on patients who continued on RAS is 28% compared to almost double, 41% of patients who are RAS discontinued. So what we do in this group of patients is always monitor the change in renal function in HFrEF patients. We have to clinically assess, compare with the basal renal function. If it is only a less than 30% decrease in eGFR, don't withdraw your RAS drugs. Assess the fluid status. Sometimes the worsening renal function can be due to a patient's over dehydration or over diuresis. So you can have your clinical parameters like JVP, there is an orthostatic postural drop in BAP, blood pressure, and edema status, that is the hydration status. And if the patient is dehydrated, you can decrease the dose of diuretics, which doesn't have any mortality benefit. And you can interpret the BP in the context of all these values. And only reduce or withdraw RAS if there is a severe symptomatic hypotension or if there is a severe hyperkalemia which you can't manage. So a simple increase in serum creatinine is not enough. That shows the effect of RAS inhibition only. You have to increase the serum creatine. Less than 30% increase is only there. Continue the RAS if there is no symptomatic hypotension. If it is a drop by 30 to 50% in GFR, you can temporarily reduce the dose. If creatinine increase more than 50%, then only consider stopping of RAS. And we have a lot of molecules for RAS inhibition, ACE, ARB, and ARNI. Which molecule we will use? Choosing the right RAS is very important, especially in this current context. And we have data from multi-center analysis and meta-analysis with papers from Dam and Polito and Spaniel. And what the comparison shows that ARNI delayed the decline in eGFR by 2.4 ml per minute when compared to ACE ARB. And there is a 11% reduction in risk of worsening renal function with ARNI as compared to ACE ARB in HFrEF patients. And there is a 4% reduction in this also. What the data from the Paradigm trial, Paragon trial, all shows that the hyperkalemia risk is less with the Paradigm and the Paragon shows that it was almost 3.5 to 4% with ARNI, with ACE and ARB, and only 1.7 to 2 with ARNI. So ARNI is less likely to cause deterioration of renal function, and it is more safe in heart failure and less propensity to develop hyperkalemia. So eGFR decreases, this translates in acute heart failure setting also. And we can see that this is a paper from McMurray. The serum creatinine more than 2.5 is 3.3% in the ARNI group compared to the 4.5% in the enalapril group. And serum potassium level was persistently lower with sacubitril valsartan when compared to enalapril. So in patients, those who are admitted with acute decompensated heart failure also, there is a 11% reduction with incidence of worsening renal function in ADHF patients with sacubitril. So not only in chronic heart failure, also in acute decompensated heart failure, there is a significant reduction in decline in eGFR. And there is a 41% reduction in hyperkalemia after switching to ARNI compared to ACE. So the recent guideline shows that a transient decrease in renal function should not prompt the interruption of a RAS inhibitor, especially that of a ARNI. And ARNI is recommended as a first-line therapy in HFrEF patients. And if urea and creatinine or potassium does rise excessively, consider stopping other nephrotoxic drugs, or we can use newer anti-hyperkalemic drugs like Petromer, which is even coming to our part of the world. We can use it to treat hyperkalemia. If there is no signs of congestion, reduce the dose of diuretic. And you have to closely monitor potassium, you have to closely monitor eGFR and creatinine. And if the eGFR is more than 60, there is no dose adjustment is required. If it is 30 to 60, still you can continue the drug. Only less than 30, you have to decrease the dose of the drug. So ESC recommends to better understand the cardiorenal physiology and to titrate, to closely monitor and to continue this group of drugs. So initiate sacubitril valsartan in HFrEF patients with renal dysfunction, and RAS inhibition shouldn't be denied to this group of patients who are high risk of heart failure mortality, because it reduces the rate of eGFR decline, lowers incidence of high creatinine, lowers incidence of hyperkalemia, and reduce incidence of worsening renal function. Thank you.
So, this I think you are very clear. Initiating RNA will help because it transfers a significant reduction in the events, right?
Yeah.
So, but if this patient is being taken up for a CAG, so for a example, there's a patient actually came to me yesterday. So he has severe LV dysfunction, and troponins are also elevated. So in that case,
we have to hold for 24 to 48 hours, and post CAG we have to monitor wait for 72 hours in reintroducing this group of drugs.
Yeah, definitely.
Transiently.
Okay, definitely. You want to convey that the early initiation of ARNI should be the...
Even in, now we have one data from Trivandrum Medical College from Jacob George sir, even shows that in CKD group of patients, we have trial data up to eGFR of 30, more than 30, but even in CKD group of patients, they have studied 80 CKD patients, and out of them all fared well with ARNI. Only 1 or 2 patients need to be stopped with worsening renal function.
Any questions from the floor?
Thank you.
Thank you, sir, for clarifying the topic. This is an exciting time in the management of heart failure. We have new drugs in our armamentarium. So, to discuss on this, I invite Dr. Krishna Kumar, sir.
Sorry to interrupt, ma'am. Once again, on behalf of the organizers, may I request the speakers to kindly maintain your stipulated time, please. Thank you.
Respected chairpersons and dignitaries from the and delegates. So good afternoon to all and welcome to the presentation titled Optimizing Guideline Directed Medical Therapy with Novel Therapies in Worsening Heart Failure. So what is worsening heart failure? I think previous speaker has elaborately told what is chronic HFrEF and heart failure with reduced ejection fraction. So what is worsening heart failure? So worsening heart failure is a different party animal. So if you are asking what are the different grades of classification of heart failure, it is stage A, stage B. Stage B is asymptomatic, stage C is symptomatic, and stage D is advanced heart failure. So if you are taking symptomatic heart failure, that is stage C, that can be divided into new onset or de novo heart failure, that is newly diagnosed heart failure with no previous history of heart failure, and the heart failure that is a resolution of symptoms, and there is persistent heart failure. And the fourth category that is going on to that is worsening heart failure, that is going on to the advanced heart failure. So how we are classifying, in what way we are discussing, defining worsening heart failure. In the next slide we will show. So definition, pathophysiology and site of care of worsening heart failure. So definition, what it includes? It includes worsening symptoms and signs of heart failure. We all of us, we know chronic heart failure is a chronic progressive condition. It is punctuated by in between some events. It is unknown, so precipitated by acute coronary syndrome or so many things. So it includes worsening heart failure, includes worsening symptoms and signs of heart failure. It requires intensification of treatment. Intensification of treatment means the 40 milligram furosemide can be increased to 80 milligram. So intensification of treatment, generally including diuretic therapy, it occurring patients with pre-existing heart failure. So that excludes the patients with the de novo. And the pathophysiologist is as part of the disease progression, and the main pathophysiology is congestion. And site of care can be emergency casualty or emergency department, or in a small setting, hospitalization, ambulatory with IV therapy, or with escalation of oral therapy. It excludes new onset heart failure. It excludes episodes with concomitant factors like acute coronary syndrome and all, and precipitating factors as a main cause it excludes. So episodes requiring no changes in heart failure treatment also, this definition excludes. And why is worsening heart failure important? Because you have seen this cartoon. The green part of the cartoon shows heart failure risk variable months to years. It is no heart failure. Then initial diagnosis, so baseline heart failure risk is their initial diagnosis and treatment. Then with the initiation of GDMT, because previous speaker has already said GDMT, that the fabulous 4 drugs have started with devices ICD or CRT, and worsening heart failure risk is in between. After that, it is punctuated by a worsening heart failure risk. Worsening heart failure despite optimal medical therapy and device therapy, and it goes on to advanced heart failure risk. So the post-event period, especially following an worsening heart period, is a key time to optimize. Post-event means following an admission. It's a key time to optimize medical therapy for heart failure. Risk of cardiovascular death or heart failure hospitalization is 46% higher in patients with or without a recent hospitalization. So guidelines recommend optimizing therapy in hospital or scheduling an early follow-up. So during the peri-admission period, so before discharge, you have to start the guideline-directed therapy as early as possible, as delineated by evidence by the strong heart failure trial. So targeting peri-discharge phase to improve outcomes. You can see the yellow lines, yellow cartoon, early initiation of peri-discharge phase management with transition to chronic care. There are so many trials are there. Pioneer HF, Victoria with Variciguat, Pioneer HF with Sequative Lasat, and Soloist WHF with SGLT2, FMAHF with IV iron, so Impulse with empagliflozin. Strong heart failure is the optimization of the GDMT, rapid optimization of the GDMT. So we can see the peri-discharge phase is a critical phase for optimizing the GDMT. The 4 foundational or the fabulous 4 pillars of survival in enhancing heart failure treatment is RNA beta blockers, MRA and SGLT2. 4 drugs in 4 weeks. This was the target of the strong heart failure trial. You can see the strong heart failure trial design. And it was the primary endpoint is 180-day heart failure readmission or all-cause mortality. In the high-intensity care group, that's aimed to updated oral medication within 2 weeks, there is 15.2% incidence of all-cause death or heart failure readmission by day 180. And the usual care group, that is the usual care, that is not rapid, 23%. So that significant hazard ratio is 0.6, is 34% relative risk reduction in the all-cause death and heart failure. That was astonishing, and the trial was prematurely stopped. So our discussion is not on these things. Worsening heart failure, what are the new therapies? So approach to the management of worsening heart failure is prompt identification and management of precipitants, prompt identification of worsening heart failure with aggressive optimization of background GDMT, early institution of IV diuretic therapy with the use of additive therapies, addition of therapies for chronic management shown to be effective in WHF despite optimal therapy. That includes the new therapy, that is vericiguat. So the IV diuretics we have already discussed. Because this session discussed on the novel therapy, I am strictly focusing on the new molecule vericiguat. There was a trial with acetozolamide called EDWARD trial. This was IV diuretics. So what is the novel therapy that is in the worsening heart failure, that is vericiguat? So in the worsening heart failure, this I already told, this is a different pathophysiology. There is decrease in the availability of nitric oxide. And even though nitric oxide is available, it is not, the soluble guanylate cyclase is not active with even in the presence of the nitric oxide. So if you are giving this new drug, that is a soluble guanylate cyclase activator, it, independent of nitric oxide and in synergy with the nitric oxide, it converts GTP, that is guanosine triphosphate, into cyclic guanosine monophosphate. There's an SGC stimulation, that is soluble guanylate cyclase stimulation, resulting in improved myocardial function, reduced left ventricular remodeling, improved vascular function, decreased fibrosis, and decreased inflammation. So this was the Victoria trial. Key inclusion criteria is LV ejection fraction less than 45% and NIHA class 2 to 4, recent heart, that is worsening heart failure, NT-proBNP more than 1000 picogram per deciliter, receiving currently available GDMT for heart failure. Vericiguat started 2.5 to then 5 milligram and 10 milligram over 2 weeks interval. So the baseline characteristics reflect a high-risk population in the Victoria, similar to the high-risk heart failure population. And so vericiguat significantly reduced the primary composite outcome of first heart failure hospitalization or CV death. You can see the NNT, absolute risk reduction is 4.2 events per 100 patient years. Annual NNT is 24. And the cardiovascular benefit of vericiguat is mediated by an early and sustained reduction in the NT-proBNP level. So you can see the, comparing with the paradigm trial, DAPA-HF and EMBER reduced, the Victoria trial, you can see it has got the similar absolute risk reduction. So it is a very important, even though it doesn't have a mortality reduction, but it decreases the heart failure hospitalization and cardiovascular deaths as a primary endpoint. So vericiguat has favorable safety profile. It doesn't have a much, no significant hypotension, no significant difference in syncope, similar adverse events. So a range of patients could benefit from vericiguat initiation. That is clinical scenario 1. A patient who experienced a decompensation event under optimal background therapy can be prescribed vericiguat. And on optimal therapy with decompensation, you can start on vericiguat. If the patients develop intolerance to GDMT, you can start vericiguat in this worsening heart failure. So vericiguat is, according to the guidelines, it's a class 2B indications. In selected high-risk patients with and recent worsening of heart failure already on GDMT, and oral SGC stimulator may be considered to reduce heart failure, hospitalization of heart failure and CV death, class 2B indication. So optimizing the GDMT with novel therapies for worsening heart failure, you can see the new drug, vericiguat, and summarizing the slide, the prevention part, you can see SGC activators in patients with LV ejection fraction less than 45% in this worsening heart failure. Thank you.
Thank you, sir. Any questions from the floor?
We can go to the next speaker. Thank you. So this is very important topic. Another important topic, this ticagrelor, whether it is more efficient in platelet inhibition. So with that we need to know, because it's already the global leaders trial as well as other trials are coming up with the efficacy of shorter DAP duration. So the might of ticagrelor is to be known. So to elaborate on that, I invite Dr. Divagaran.
Thank you. Respected chairpersons, seniors, teachers and friends. My topic is ticagrelor, more efficient platelet inhibition and beyond. We know that ticagrelor is a reversible inhibitor of ADP receptor P2Y12. It is a direct acting drug and it's not a prodrug. And it has got faster onset and offset of action and with a more predictable and more potent antiplatelet effect and having pleiotropic effects. The guidelines recommend 12 months of DAPT in post-PCI patients in the ACS setting, that is STEMI and NSTEMI patients, whereas in stable CAD patients, 6 months of DAPT is recommended. We have to balance the ischemic risk versus the bleeding risk on choosing the antiplatelet therapy regimens to optimize the outcomes. Ticagrelor provides significant benefit in high thrombotic risk patients. We know the procedure-related and the patient-related risk factors. More the number of risk factors, ticagrelor provides significant benefit in such patients. The rationale for DAPT with ticagrelor for 12 months in ACS comes mainly from Plateau trial and the Pegasus trial and from several other studies. Several studies compared ticagrelor with the clopidogrel and found that ticagrelor was superior to clopidogrel in terms of primary efficacy endpoints. The PHILO trial was a negative trial for ticagrelor, whereas on comparison with prasugrel, the Prague 18 and the ISAR React 5 trials showed superiority of prasugrel, but those were open label design trials and there was more discontinuation in the ticagrelor arm. Coming to the Plateau trial was a landmark trial, more than 18,000 patients, a multi-center randomized trial. Ticagrelor was compared with clopidogrel in patients with acute coronary syndrome, both STEMI and NSTEMI patients. And at the end of 12 months, the primary endpoint of death, MI or stroke was less with ticagrelor. And the major bleeding was comparable, but there was an increase in the non-procedure related bleeding. You can see that the primary endpoints were less with ticagrelor, whereas the bleeding was comparable. There was a 21% relative risk reduction of CV death and 16% in MI with ticagrelor. The Pegasus TIMI 54 trial studied the extended use of ticagrelor in patients, post-MI patients. Patients with the MI in the 1 to 3 years previously were assigned to either ticagrelor 90 mg BD dosage or 60 mg BD dosage or in comparison with placebo on top of aspirin. All the patients received aspirin and at the end of 3 years, ticagrelor reduced the risk of death, MI or stroke, but there was increase in the major bleeding. You can see that the primary endpoints were less with ticagrelor. And in high-risk patients undergoing PCI, high bleeding risk patients undergoing PCI, we can de-escalate the DAP duration to 1 to 3 months or maximum up to 6 months. And in low bleeding risk patients, we can continue up to 12 months or more. We have the DAP de-escalation and bleeding mitigation strategies like ticagrelor monotherapy or clopidogrel monotherapy or aspirin monotherapy or aspirin plus clopidogrel DAPT. The Twilight trial compared one of such strategy, the ticagrelor monotherapy versus dual therapy with aspirin in patients undergoing PCI. More than 7,000 patients were studied. The trial evaluated bleeding and ischemic endpoints at the end of 1 year and found that the ticagrelor monotherapy was associated with a lower risk of bleeding. That was expected because the monotherapy compared to the dual therapy, bleeding will be less. But what was unexpected was the primary ischemic endpoints were comparable. You can see that the bleeding was less with the ticagrelor monotherapy, whereas the primary ischemic endpoints were comparable, were similar. The primary efficacy endpoints were similar with ticagrelor monotherapy and the dual therapy group. Ticagrelor has got a very limited role in the atrial fibrillation patients undergoing PCI. The clopidogrel is a preferred drug in this setting. In selected patients with high ischemic risk, we can give ticagrelor as part of triple therapy for 1 week. and for a maximum of 1 month. And after that, we have to continue clopidogrel plus oral anticoagulant. And after 12 months, oral anticoagulants has to be continued. The trials of ticagrelor in extracoronary indications like stroke, peripheral arterial disease, and in CABG and stable CAD patients showed a comparable efficacy and safety of clopidogrel with aspirin or clopidogrel, but firm conclusions are anticipated from currently ongoing studies. The Socrates trial compared ticagrelor with aspirin in more than 13,000 patients with ischemic stroke or TIA, and was found that ticagrelor was not superior to aspirin in reducing the rate of stroke, EMI, or death at 90 days. Whereas the Thales investigators studied ticagrelor plus aspirin combination therapy versus aspirin alone in acute ischemic stroke or TIA patients, and found that the combination of ticagrelor and aspirin after a stroke or TIA was better than aspirin alone in preventing stroke or death at 30 days. Severe bleeding was rare but occurred more frequently in the dual antiplatelet therapy group. You can see that the primary endpoints were less with ticagrelor combination group. The bleeding was comparable. Ticagrelor in the peripheral arterial disease setting, the Euclid trial studied ticagrelor versus clopidogrel and found that ticagrelor was not shown to be superior to clopidogrel for the reduction of CV events. Major bleeding occurred at similar rates with ticagrelor and clopidogrel. You can see that the ischemic endpoints were similar with ticagrelor and clopidogrel. The trials of ticagrelor in CABG, post-CABG patients, the TICAB and DACAB trials, the TICAB trial failed to show that ticagrelor was superior to aspirin at preventing adverse events after CABG. Among patients undergoing CABG, ticagrelor monotherapy did not reduce the major adverse cardiac events versus the aspirin monotherapy. The DACAB trial showed that, whereas the DACAB trial showed that the combination of aspirin and ticagrelor improved the venous graft patency at 1 year compared to aspirin monotherapy. The THEMIS trial studied stable CAD patients with diabetes and found that ticagrelor plus aspirin combination was superior in reducing the death, EMI, or stroke at the end of 40 months. The major bleeding was more in the ticagrelor group. The bleeding was more in the ticagrelor group. Regarding the pleiotropic effects of ticagrelor, we have the beneficial and the adverse effects. Adverse effects like bronchoconstriction and dyspnea and bradycardia, that was due to the stimulation of vagal C fibers of the phrenic nerve, and the beneficial effects like increase in the coronary blood flow, anti-inflammatory effect, vascular cardiac remodeling prevention effect, ischemic reperfusion injury prevention effect, and endothelial regeneration, and so on. The pleiotropic effects are a research topic, and further insights are awaited from the trials. The take-home message, ticagrelor is a potent platelet inhibitor, which is most beneficial in the high thrombotic risk patient. Both the standard 12-month therapy and the extended use of ticagrelor reduces CV events in patients with acute coronary syndrome. There is no one-size-fits-all approach in DAPT with ticagrelor. We have to tailor the therapy according to the balancing the ischemic versus the bleeding risk. Even though trials showed comparable safety and efficacy of ticagrelor and aspirin or clopidogrel in extracoronary conditions and in CABG, firm conclusions are anticipated from the currently ongoing studies. We cannot routinely recommend ticagrelor in such situations because of some more bleeding complications. And regarding the pleiotropic effects of ticagrelor, it's an active research topic. The indications of ticagrelor are likely to expand once the results are out. Thank you. Special thanks to the Scientific Committee Chairman, Dr. Jayagopal sir, for this opportunity. Thank you all.
Any data on the 60 mg ticagrelor? Any use? 60 mg.
I don't know that.
90 mg instead of 60 mg. They say that we can continue with 60 mg. So any data on that?
I'm not sure about that.
Okay. Thank you.
Dr. Divakaran, there's always a problem when you use a NOAC and then an antiplatelet. Is
Yes,
there
sir.
any data on the safety of use of NOAC with ticagrelor?
There is no such data, sir. The post-trial, Augustus trial, and the Pioneer AF trial, all trials compared clopidogrel. The ticagrelor, there is no sufficient data to recommend. And in high ischemic risk patients, we can give a ticagrelor triple therapy for 1 week only in the post-PCI patients with atrial fibrillation. But sufficient data is not supporting ticagrelor.
Thank you.
Pegasus trial was 60 mg. Post after 1 year, up to 36 months, 60 mg ticagrelor.
Okay. You asked Pegasus trial. Okay, it was Pegasus trial compared. I didn't get the question properly. The Pegasus trial compared 90 milligram dose of ticagrelor, 90 milligram BD, similarly 60 milligram BD versus aspirin. But all the patients received aspirin versus placebo. But all the 3 groups of patients received aspirin. The endpoints were similar with the 90 milligram dose and the 60 milligram dose also.
Okay, thank you.
I think for want of time, can we go to the next session?